Good morning, everybody. It's a pleasure to start this session. The first lecture is by none other than Dr. Naresh Bhatt. He is a pioneer in NBI and training in NBI in India. So I request him to start his talk.
Thank you, Parimal, and good morning, everybody. At the outset, thank you, Amol, for having me here again.
Good morning, everybody. It's a pleasure to start this session. The first lecture is by none other than Dr. Naresh Bhatt.
Task. This is when to use NBI.
He is a pioneer in NBI. And
for me, NBI is
NBI
every time,
India.
Every single time that
so
you need to.
So I request him to start his talk.
You do endoscopy. Thank you, Parimal, and good morning, everybody. Available at your outset, at the tip of your
NBI
scope. You can switch to NBI whenever you want. So any lesion that needs a second look certainly needs NBI. I'm aware that there are practices where people do a screening endoscopy with white light and then call them NBI is every time, every single time that you need to special interrogation with NBI. I'm not quite sure whether that's the way it should go, but nonetheless, this is the practice in some areas. And hence, I guess they have issues as to decide when to use NBI and when not to. When we consider an endoscopic diagnosis, I think there are several issues. One, of course, is detection. Second is you detect the lesion, then you have some kind of a differential diagnosis. And if it's a tumor, you want to know the depth of the tumor and the border of the tumor to decide what your therapeutic strategy is. For the youngsters here, I'd like you to remember this rule of 4. Is when you do endoscopy, always expect abnormalities. Which means that you must have a good idea of what the patient's problem is, what his background is, whether he's a smoker, non-smoker, whether he's possibly had treatment for H. pylori, what's his family history, and so on and so forth. Once you are able to have some kind of stratification of what his risk factors are, and then you start the endoscopy, then you find that you must use techniques to improve the pickup rates, interrogate the lesions adequately, and then, of course, sample them. We all know that cancer needs more vessels. And NBI has largely developed beyond this hypothesis that angiogenesis is an important part of cancer. And if we can pick up this angiogenesis in some way, we may be able to pick up the lesions at a much earlier stage. So this is a thing in the esophagus where we find that the IPCLs change in number and in their configuration and so on, depending on whether there is a neoplastic lesion. Similarly, if you look at this paper from Professor Tanaka, it clearly shows us that varying from a polyp, which is a hyperplastic polyp, to that which has got carcinoma and deep submucosal invasion, that the size of the vessels, microvessels, steadily increase. So if you have a vessel that is much larger, then you can straightaway suspect that there may be a neoplastic component. If the vessels are not only large, but they are irregular, meandering, and so on and so forth, you can assume that perhaps they are more advanced cancers. So the important thing as NBI is concerned is the assessment of the microvessels. If you look at this patients, there are two patients, both have got fairly similar lesions there, a little depressed lesion. But once you have magnification NBI, then you find that this area, which is the area in question here, are very different. And all you have to look at is the vessels here to make out that this is certainly sinister, while this is not. And the biopsies that are there alongside clearly show you that the upper bundle is a malignant gastric lesion, while the one lower down is benign. Now, when I said expect lesions, this is a patient who had a squamous cell cancer in the lower half of the esophagus. And when we did an evaluation of the proximal esophagus, we found that there was an abnormal area which is fairly localized, and the IPCLs here were clearly abnormal. That this patient had a distal larger lesion, which is clearly malignant, but more proximally also he had a lesion which was some kind of a carcinoma in situ, or at least high-grade dysplasia. Now, why is this important? Because it clearly changed the management, that you're not going to go and resect the lower end, as you might have planned, but consider a treatment both for the upper esophagus and the lower esophagus as well. Now, colonic polyp is something that Dr. Rajesh Puri will be talking to us later. But here, if you clearly look at this thing, you can see these abnormal vessels. I showed you that paper by Professor Tanaka. And if you look at these vessels, are clearly abnormal, but they're not only just uniformly abnormal, they are a little irregular in size, and therefore, this not only is just an adenomatous polyp, but a high-grade adenoma or maybe a carcinoma in situ. Here again, your management strategy will change, because here you may be expected to do a more complete resection, or even consider EMR or ESD rather than just a simple polypectomy. So coming back to when to expect abnormalities. Obviously, any patient having an endoscopy, you should expect abnormality. Otherwise, there's really no business size. But patients who are smokers or abusers of tobacco, patients with Barrett's, you do expect that you may find some areas of dysplasia or a malignant change. You have patients with chronic H. pylori gastritis with atrophy. We know that they again have a good chance of harboring a malignancy there. A patient with an upper aerodigestive cancer, we know, can have an increased risk of a cancer elsewhere. So while going in and finding out that he's got a cancer in the lower esophagus, we also need to look at the pharynx and larynx to find out whether he's got a lesion there. If you have a family history of cancer, obviously means that you're going to look at it in a little more detail. And patients who have small colonic polyps, which we think as hyperplastic polyps, one must be aware that a group of them actually are serrated adenomas and carry the risk of cancer. Which really means, as I said right at the beginning, that you must take a good history. You must stratify what his risk is. Okay, this patient is 50, he's a smoker, he's got a family history of cancer. I'm going to be extremely wary of allowing someone to do a 2-minute Maggie endoscopy. He's going to have a good quality endoscopy with NBI as well to be able to pick up very early lesions. So as far as technique is concerned, very important to ensure that you have sedated the patient, you use Buscopan, you have a clean field, use a water jet to clean up. Sometimes we use a cap to be able to look at those lesions a little more critically. Some people use acetic acid to be able to look at the surface much better, but very important is to have patience. If you don't have patience, you can't be in this business of finding early lesions. We know this Korea's cascade. And so, if you have patients who are here, arthritis with intestinal metaplasia, in these patients, it's easy to recognize that on white light. And when you find this, then start looking very carefully, even on white light endoscopy, start looking for lesions which may be suspicious. There may be a little change in color, it may look a little red, it may look a little white, it may look a little irregular, may look a little elevated, a little depressed, whatever. You must be able to recognize those lesions and then interrogate them appropriately. Whenever I meet young gastroenterologists who have acquired a scope with NBI capabilities, I say, what are you going to look for? No, sir, I want to study what NBI looks in varices. I want to do a study on NBI in solitary rectal ulcer. Please understand there's absolutely no role. Once there's a lot of ulceration, there is no role of NBI. Your surface is knocked off. So what are you going to study there? Varices, SUR, subepithelial lesions. Again, NBI is not a modality that is useful. And remember that inflammation is a big confounder. Inflammation also has angiogenesis. So once there's inflammation, it's extremely difficult to interpret what is happening in the mucosa. So if there's a lesion, a large lesion that's ulcerated, you may find it, very difficult to say, is this a malignant lesion with ulceration, or is it just a large lesion that is, getting ulcerated because it's in the lumen and, getting affected by the stream of food or feces. So inflammation and ulceration are two enemies as far as NBI is concerned. So NBI, therefore, is specially useful in screening high-risk patients, interrogation of flat lesions. If you have a large lesion that's 5 centimeters, ulcerated, clearly malignant, don't waste your time on NBI. And evaluation and decision-making in colonic polyps, definitely we find a special role for NBI. Thank you.
Thank you, Dr. Bhatt. That was an informative talk about the lesions which need magnification. And now we go on. Do you have any questions for him? Questions or comments? All right. So we move on to the next talk.
Rajesh,
All right.
I think that's a very good question. It's like, suppose we darken this room and I say, I have lost my pen here, right? You're not going to take a torch and start screening this whole room. What do you say? Where were you sitting? And said, okay, I was sitting in the first row on the third chair. And then you say, all right, let's use a torch and search there. So that's the kind of analogy I would use. It's always and always white light endoscopy. Once you have found a suspicious lesion, then you interrogate it with NBI. It's never NBI alone. Remember that when you use NBI, it also darkens the field to an extent. So it's not a great screening modality directly. So small area, interrogate with NBI, while the whole thing otherwise, you look at it with white light.
Do you still use the white light in esophagus and then put NBI, or in esophagus you directly go with an NBI?
Yeah, I'm aware that a lot of people actually use NBI. See, the esophagus is a little different because it's a fairly narrow tube. So you can just use NBI maybe on your way back just to screen. But because what happens is that the color stands out. The color of the abdominal mucosa stands out. It's almost like putting Lugol's iodine there. So esophagus may be an exception, but I would still, my practice is to use white light and then interrogate it with NBI rather than use it as
one last question with your answers only. Would you like to apply the NBI while going in or while coming out? Because while coming out, there is a possibility in colonoscopy, you may produce the artifacts. In endoscopy, you may produce the artifacts. So you prefer while putting an NBI while going in colon, or while completing the colonoscopy?
No, whenever I see a lesion, it doesn't matter whether it's when I'm on my way in or way out. When I see that lesion, I interrogate it with NBI right then.
Thank you.
Next question, please.
Dr. Naresh, if there is a doubt on white light endoscopy, if there is a class A reflux esophagitis or not, would switching to NBI bring out the lesion better? Class A reflux.
Yeah, that's a good question, but I'm sure someone who's dealing with esophagus may want to address it. I'll leave it. there. Only thing, yes, definitely you can bring out the erosions better. There is something called minimal esophagitis, which you can appreciate on NBI. I'll leave it to, is Pradeep speaking on it? I think I'll leave that answer to him.
Does it have any clinical significance if you're picking up early esophagitis or minimal esophagitis?
Yes, it has, because if you have a patient with heartburn, for example, he's got some esophageal symptoms, and you say endoscopy normal, you say either it is non-erosive reflux disease or you say it is functional heartburn. The treatment differs. But if you give it a name that there is erosion, whether it's micro erosion or minimal esophagitis, you're very clear that your strategy is treating him like erosive disease. So it makes things easier.
That will be the last question.
When you are going to use acetic acid instead of a plain water wash?
I actually don't use acetic acid. Maybe Pradeep will answer some of them, those questions. I don't use, but it's supposed to bring out the surface characteristics much better, and the micro surface patterns are much better with that. I have really no experience with acetic acid. I'll go on to the second talk.
Yeah.
Yes, there's a change in sequence of the talks. And now Dr. Naresh Bhatt will continue with the second talk, which is NBI in stomach lesions.
This is actually Dr. Rupa was supposed to deliver this talk. Unfortunately, she couldn't make it, so I'm just covering this for her. The important thing to remember about NBI or any kind of endoscopy in the stomach is to have a systematic stomach screening protocol, which has been popularized by Kenshi Yao and his group. And basically, you'll go to the antrum, take pictures, go to the mid-body, take pictures, go to the upper body, take pictures, and then again in a retrospective, retroflex view, you again take pictures of fundus, upper body, and incisura. And these are all documented. So if you do this, the chances of you missing anything is much smaller. So this is the first message that's important. When you look at NBI in the stomach, you find that this is a body, and the body has a beehive-like pattern. There are multiple round areas here, and these dark are the collecting venules. And this is important, as you'll see later. So remember, body has a beehive or rounded kind of appearance of the surface, pits, and you have collecting venules. And you have this honeycomb pattern inside that. If you look at the antrum, they are a little more ridged, and you have this subepithelial capillary network, which is a little more coiled, and you don't see collecting venules in the antrum. And this is largely because if you look at the anatomy, this is what the body is, and this is the capillary network, and there's a crypt opening, which you are seeing, in a kind of cross-sectional imaging. This is the basis for that. So when we're talking about gastric disease, I'm going to talk about just 3 or 4 issues. H. pylori or chronic gastritis. When we have any kind of gastritis, whether it's H. pylori related or not, what you find is some changes in the pits become larger. But what is fairly suggestive of H. pylori infection is the loss of collecting venules. You don't see the collecting venules at all, those darker structures that I showed you earlier. It's the kind of starfish-like structures. So if you have changes in the pit as well as loss of collecting venules, remember that this can be appreciated only in the body. Changes in the antrum are not specific for H. pylori. So if you want to assess H. pylori gastropathy, come to the body, look for the collecting venules, and look for the pits. So this you can fairly accurately predict that it may be an H. pylori related problem. And if you look at the changes from rounded, it becomes more linear, ridged, and finally becomes papillary, which is the phases of the evolution to intestinal metaplasia. Now, for early gastric cancer, we have Professor Kenshi Yao's classification of looking at the vessels on the surface, the MV, the microvessels, and the microsurface. And you classify it whether it's regular, irregular or absent, the vessels and the surface. And if you have an irregular microvessel pattern or an irregular surface pattern with a line of delineation, a line of demarcation, then you can be fairly certain that this patient has got an early gastric cancer. Just to show you some examples, here you've got these lesions here, there are two of them. You can find out that here the demarcation line is present. You can make out definitely the demarcation line. Then are the vessels or the surface irregular? Here they appear fairly regular, so there's no irregularity, so this is not cancerous. Now if you look at this area, you can find out there's a line of demarcation very clearly. If you look at these vessels, are clearly abnormal. You can see some large vessels, some irregular vessels. So vessels definitely abnormal, line of demarcation, so this patient has got cancer. So this is the kind of algorithm that one uses when we are trying to look at gastric cancer. Is it an area of localized area, clearly made out, line of demarcation, and then look at vessels and surface. This is kind of a little elevated lesion, Paris 1S. And if you look at these things, you can make out, it certainly looks a little abnormal, but if you put it in a cartoon, you can make out that these pits are varying in size. Some are large. Look at vessels and some surface. Are, kind of look almost like septate. Some are smaller. This is kind of a little elevated. Some vessels lesion are distinctly abnormal. So this is not just adenoma, but it's progressed beyond an adenoma. So maybe carcinoma as well. Again, the same thing. Line of demarcation, abnormal vessels. This is a early gastric cancer. Similar looking lesion here, but it's quite regular inside, and this is just an erosion. So in the microerosion, the pit pattern is fairly similar to the surroundings. Vascular pattern is similar to surroundings, and the demarcation line is not so well made out. So if you look at what's the summary in early gastric cancer, if you say is NBI useful for detection of early gastric cancer, it's perhaps not very strong. So you have to depend on white light endoscopy to pick up these lesions. Just to reiterate what Rajesh and we were discussing earlier, is that your first diagnosis has to come from white light endoscopy. Can it differentiate malignant from non-malignant? Very certainly yes. It's a pretty good modality. Can it tell us the extent of the early gastric cancer? Again, pretty good. Though the Japanese still use an additional chromoendoscopy before they resect the lesion. And can it tell us tumor depth? Unfortunately, it's not a good modality to tell us tumor depth. It's good in the colon, but not good in the stomach. Again, to reiterate that what rules apply in the colon don't necessarily apply in the stomach or the esophagus. So each organ, you must know its appearances and significance quite distinctly. I can stop here at this stage.
Thank you, Dr. Bhatt. I would like to know from you, some workers feel that while you are scanning the stomach mucosa, it's essential to have a soft rubber cap on your scope so that you can fix the mucosa at about 2 millimeters. You get a better view. Yeah. What's your opinion?
Yeah, if you're using the 180 series and you don't have this dual focus system or near focus thing that we have with the 190 scopes, you certainly need a cap. With the newer scopes, the cap is not so essential because that helps you stabilize the scope at a fixed distance from the mucosa, and you can get very sharp images. So a cap is certainly useful, but it has to be a soft cap because if you traumatize, then you can't. Once there's some bleeding, then you can't evaluate the mucosa surface.
Any questions from the audience?
Naresh, I have a question. Other than Olympus, there are a lot of people using their standards in this similar field are quite different. So if somebody is using, most of the literature is on NBI. So if somebody is using FICE or the Pentax I, whatever it is called, how do you get together all these concepts and make a diagnosis?
That's a bit of a challenge because 80% of the literature is all on NBI because they moved in earlier. The others are a little more complicated to use because you have many more switches, many more settings and so on. However, once you start doing it, it's not very different. And I'm sure, I think Pradeep has got some published literature on this, and maybe he can tell you, because he's used both and compared, maybe he'll be able to tell us a little more on this.
I'm Dr. Vikas Singla. Sir, if on endoscopy I have suspicion of early gastric cancer and I'm planning for endotherapy, so how can I assess the depth of the lesion?
I didn't get the second part. You
Yeah.
got an early gastric cancer?
And planning for the endotherapy.
Yes.
And how can I assess the depth of the lesion?
Depth of the lesion?
Yes.
It's very difficult. So if you have what looks like an early gastric cancer, it's assumed that it's not deep. What
Yes.
you can look at is distensibility. What you do is distend the lumen, see whether there's some tethering, then suck out, see what happens to the mucosa. That is perhaps the best test to make out whether it is going deep or not.
Okay, thank
But you can't make it on the surface characteristic. So just to again reiterate, it is important to be a good white light endoscopist before you can even think of doing NBI. NBI is just an add-on. Your basic skills have to be white light endoscopy.
We move on to the next talk, which will be delivered by Dr. Pradeep Bhandari. He'll be talking to you about NBI-based treatment algorithms for Barrett's esophagus.
Hi, good morning, everyone. Sorry. Excellent. So, I'm really grateful for Amol to invite me back home where I belong. It's nice to see such a big interest in ESD and third space endoscopy. As you know, the EMR and ESD has always excited a lot of interest, but now the third space is exciting even more interest. And it's great to see poems in the third space developing at such a fast pace in the West. In the past, we've always been about 10 years behind Japan, but this time we're catching up very fast. He's given me a very interesting topic to talk about NBI-based treatment algorithms. So I made some of those algorithms myself, but they're generally speaking very practical ways of looking at Barrett's. I'm practicing in a city called Portsmouth, which is on the south coast of England. It's about 50 miles south of London. So if you do come, please visit us. It's a very beautiful city. It's got a lot of maritime history because it was the base for the World War II where all the Navy was. So it's a big naval base. All the ships were launched from here. We have some very interesting places to visit. If you go on top of this and have coffee there, you can almost see France across the English Channel. And of course, my hospital is another interesting place. I would like you to invite to our next annual event. But moving on to current topic of NBI-assisted Barrett's treatment, I'll focus mainly on the diagnosis, what the algorithm for Barrett's treatment is, and how NBI helps. So, I know that Barrett's is not that common here, but you look at this Barrett's, patient has had surveillance for about 15 years. Every time patient comes for surveillance, they take multiple biopsies. When they get biopsies taken, there is a new squamous epithelium which generates. And if you just go back, you'll find this is a complete mess. When you have so many squamous islands, it's so difficult to assess what's going on in this Barrett's. So you have to be very, very careful when you're assessing this Barrett's because there will be a small area which looks different, and that's what we found out. You can see with NBI, it's quite obvious. There's a raised 2A area. You can then use near focus, and I don't know if you can see, but there are abnormal vessels here. So this is obviously a very suspicious area. But in general, Barrett's can be very difficult to assess. This is lucky that this lesion was raised to A. Majority of the lesions in Barrett's are very flat. So almost morphologically, they're very difficult to differentiate from normal Barrett's. If you're using NBI, you need to be very familiar with the Bing classification, which Pratik's group published. It's an international classification, which is very, very simple, and basically defines mucosal pattern as regular and irregular, and similarly vessel pattern as regular and irregular. And basically it means that if you have regular patterns, it's normal Barrett's with intestinal metaplasia. If you have irregular patterns, then this is likely to be neoplastic. And they only included high-grade dysplasia and above, not low-grade dysplasia, because low-grade dysplasia is very difficult to find with most of the modalities that we have. It has reasonable accuracy. We would like it to be better, but this is probably the best you can do at this stage. You should remember that this classification came out 2 years ago, before we had the 290 that we have, or 190 that you have here. So things can only get better now. These are those older images of normal Barrett's showing different vessel patterns and surface patterns, which are all normal. And these are some images of high-grade dysplasia and intramucosal cancers showing abnormal vessel patterns and mucosal patterns. As you can see, none of these areas are raised. They are very flat, so it can be very easy to miss. But the key remains very high-definition white light. With that, you look for any suspicious area, and then you use NBI to evaluate that area. The evidence for NBI is reasonable. I think we have a lot of studies which have shown that there's an increased pickup rate with NBI for Barrett's neoplasia. The only disadvantage is that there's a lot of inter-observer variability, and that's because people believe that NBI is just pressing the button. It requires a lot more than pressing the button, and we've done some training curves and training exercises. We've seen that you need to see at least about 100 neoplastic lesions before you get really good at it. So that's why there's a lot of inter-observer variability. And the other problem with these studies is they are all enriched population where a lot of patients had neoplasia. When you have a population like that, your sensitivity is always going to be very good. I don't know if trimodal imaging system is available here. I guess not, because you're using 160 and 190. But Olympus has got a very good platform where you use white light, autofluorescent imaging, and NBI. And again, there's a good evidence that this can really improve your pickup rate. So hopefully my video will work to show you the principles of this trimodal imaging. This is a very high definition white light, and you can see this area in Barrett's is abnormal. Rest of the Barrett's looks fine, but this is definitely an abnormal neoplastic area. When you switch on to autofluorescent mode, you can see the neoplastic area becomes pink. The rest of the Barrett's remains green. That this can really reflect technology. You can easily pick up an area of concern. Doesn't tell you a lot more than that. Once you find an area of concern, a pink spot like that, then you change over to NBI to interrogate it and find out exactly what it is. And NBI gives you very close assessment of the vessel pattern, and then you can make out exactly what it is, whether it's esophagitis, neoplasia, or an invasive cancer. And here you can see that the vessel pattern is certainly very suspicious, suggestive of possibly a deep SM invasive cancer. And that's what it turned out to be, an SM2 cancer. ASG set up PV criteria for optical technologies like NBI, FICE, whatever optical technology, eye scan, whatever you want to use. And if you want to replace random biopsies using just optical biopsy, they say that your per patient sensitivity of the technology should be more than 90%, and your negative predictive value should be more than 98% for high-grade dysplasia and cancer. That's a very, very big ask. I think most of the technologies have the potential, but haven't been demonstrated to meet that, apart from one technology, which is acetic acid. It's very simple to use. We've been working on it for a long time. because our bulk of our work is Barrett's. It's basically acetic acid when you spray. Everything takes up acetic acid and everything goes white. And then the area of neoplasia loses its whiteness quicker than the surrounding normal mucosa. So there's a differential loss of whitening. And this is what you see here, is these areas, red spots that you see, is where the whitening has been lost. So these are neoplastic areas. We use 2.5%. Some people use 1.5, but 2.5% has got the best evidence. And that's what I would recommend if you're using Barrett's, if you don't have the high spec NBI. This is the work that my group did a little while ago, where we found, basically capitalized on this differential loss of aceto whitening. And we found that if you have a normal Barrett's, it stays white for a long time, you can see here. As compared to cancer, if you have a cancer, within about 20 seconds of spraying acetic acid, the cancer loses its whitening. So there's a huge gap, and that's how you can make these diagnoses and pick up a lesion very, very quickly, despite them being very flat. And here we managed to achieve a negative predictive value of what ASG PV criteria asked for. The data has come from two big groups, ours and from the Wiesbaden, and both show similar sensitivities. So acetic acid certainly has a potential. The beauty is, doesn't matter which platform you're using, acetic acid would still work and you'll be able to get. It also allows you to pick up these lesions with standard definition endoscope. But NBI now is very good. If you have a high definition 190 series, NBI is brilliant, and I'm sure very soon you'll see data which shows as good result as acetic acid. This is just a simple video showing a very old-fashioned endoscope, standard definition. This is Barrett's. You can see there's nothing wrong with this Barrett's. Looks completely normal. I can't see any area of abnormality in this Barrett's. We spray 2.5% acetic acid. As I said, everything goes white. That's the aceto whitening that you see with acetic acid. You just wait for another 30 to 40 seconds, and you see this area of differential loss of aceto whitening, tiny little area where it's gone red. And this one biopsy turned out to be high-grade dysplasia. So this is where you need to target. Out of this 12 centimeter of Barrett's, you could potentially take 24, 30 biopsies. If you miss this tiny area, you won't find it. So that's where the beauty of acetic acid is. In terms of treatment algorithm for Barrett's neoplasia, this is very simple. Endoscopic treatment up to SM1 and surgical treatment for anything beyond SM1. Endoscopic treatment, anything which is visible has to be resected. We never ablate. All visible lesions need to be removed. If it's not visible, but it's neoplastic, then we ablate. So low-grade dysplasia most of the time is not visible, and therefore it goes straight for ablation. Whereas high-grade dysplasia, 97 to 96% of the time is visible, and we always resect a lesion and then ablate the rest of the Barrett's. Intramucosal cancer, SM invasive cancers, these, it's very difficult to make that differentiation all the time. So our strategy is always to resect them en bloc and then ablate the rest of the Barrett's. As I said, SM1 and above goes for surgery. This is the landmark paper which changed all the Barrett's management algorithms, where RFA was shown to be very effective. And since then, this two-step strategy has been developed where we resect all visible lesions and ablate all the residual Barrett's. And this has been proven to be very effective and has become the norm for Barrett's management now. This is a recent addition. The SURF trial showed that patients with low-grade dysplasia are at high risk of developing cancers. So now even low-grade dysplasia has been included into ablation strategy. Previously, we were not treating low-grade dysplasia. This is just a video illustrating a patient who had a high-grade dysplasia resected by EMR. Somewhere around here, now he comes for halo ablation. This is their new RFA Express, which is a one-step ablation device. It does its own measurements and does its own ablation. So you don't have to measure and then use a different size balloon. Everything is done at the same time. You need, once it's ablated, you are using this very fast treatment strategy where we do not clean, we just do 2 hits and we take the balloon out. So it's very fast now, very effective. You can use hybrid APC. We've done a lot of work where we found hybrid APC again. A similar patient with EMR for intramucosal now requires ablation. The hybrid APC is a very effective device where you use the same APC catheter to do an injection. You'll see here. So it's connected to the RB pump. You inject, lift the Barrett's, and then you do very high power ablation. You see here. So it's because you injected and created a cushion, it gives you the confidence to do this look at that. It's very easy to lift. Once the mucosa is lifted, you do a very high power ablation, and that's equally effective as RFA. Although it's a little bit messy, a little bit patchy, might require few more attempts than RFA. But again, it's catching up. How does NBI change our treatment algorithms? This is the patient referred to us with a no visible lesion. So high-grade dysplasia on biopsy, no visible lesion, so for ablation. But when you use NBI, you can see there's definitely a visible lesion. And that's why this patient should not have ablation. It needs resection. And when we did the resection, everything came back as intramucosal cancer, which was fine. And then you can go for ablation. So again, it's very important to use NBI before treatment. Oh, I'm carrying on too much. Okay. This is very, very quick. This is a lesion where on white light looks very suspicious. When you use NBI, you can see clear delineation lines. So you can see it's so bright, you don't even need NBI. You can see the whole lesion with white light. When you switch on NBI, it's very clear. The margins of the lesion, we know it involves more than 50% of the circumference. And that's what helps us improve the management of these patients. You can use near focus if you are worried, but I've got all the information now I need to treat this patient. Finally, this is another good example where NBI made a difference. We did the marking with white light, and what we found was this nodular lesion was easily visible. There was a flat area which we didn't think was involved. When we switched over to NBI, you can see this is suspicious. So this is suspicious pattern on the nodular area, which is very obvious. When we go down and see this flat area just past the nodule, again, there's an area of cancer here. This was easily missed. You can see a clear demarcation line there. As we come back, you'll see it's very clear. This is an invasive cancer here, which was very easily missed by white light. So it's very important. In this patient, NBI changed the whole treatment algorithm, because if we had missed that area, it would be R1, and also we would leave the cancer behind. Whereas using NBI on the 290 platform, we were able to find that and performed an en-bloc excision, although it turned out to be SM1. But at the moment, our SM1 patients are being managed endoscopically rather than surgically. It is always difficult to work in retroflexion, but that's where the skill lies. I prefer to change my knife a lot when we do retroflexion. We change to the IT knife because it makes it a lot quicker. Here you can see that's the final stroke, and the entire lesion came off en bloc, about 6 to 7 centimeter lesion, which on histology turned out to be SM1. And we managed to avoid surgery for this patient. This is the area which we almost missed. You see here, this is all cancer. This is where the SM1 cancer was. This all turned out to be intramucosal. It's bizarre, but that's what happened. So that illustrates the role of NBI. Because of the lack of time, I'm going to finish with this last slide. We just published the biggest Barrett's ESD trial between 3 centers from Portsmouth, Milan, and Zurich, showing reasonably good en bloc resection rate, but with Barrett's, R0 remains low because the margins can be very, very deceptive. But with the new platforms, hopefully this will get better. So I'll finish The NBI improves Barrett's neoplasia detection, and it certainly would change your treatment algorithm because it allows you to see a lot more than what you can see with white light. Thank you very much.
Thank you, Dr. Pradeep. As we are short of time, you could have one question, one or two questions.
Pradeep, what is the mechanism of disappearance of esto whitening? Why does it happen?
It's a very interesting question. There's been some lab work done which shows that when you put acetic acid, what happens is the cytoplasm in the Barrett cells takes up the acetic acid, and there's a reversible acetylation. I'm carrying on. Yeah. There's a reversible acetylation reaction that happens. When you have a cancer, what happens is the nucleocytoplasmic ratio changes. So in the normal Barrett's, there's a lot more cytoplasm and smaller nucleus. In a cancerous cell, there's a bigger nucleus, less cytoplasm. So that's why the cancer cells has less cytoplasm, so it takes less acetic acid, so it loses rapidly as compared to a normal cell with a much bigger amount of cytoplasm, so it remains white for longer.
Pradeep, excellent talk. My question is regarding SM1 lesion in esophagus especially. My worry is about the lymph node metastasis in SM1 lesion, especially esophagus. So do you have a strict protocol of follow-up regarding SM1 lesion in esophagus which you endoscopically resect versus you do for gastric lesions?
That's a very good question. I'll address in my next talk because I think the experience here, your experience will be more in squamous as compared to Barrett's, and Barrett's a completely different game. So I'll come to it in my next talk.
Can it be, here, I can offer a different hypothesis for that.
Yeah.
Is it because there are more blood vessels and the acetic acid washed off very fast from cancer cells?
Say that again, is it because?
Is it because there are multiple vessels, the vessels are increasing in cancer, and therefore they're getting washed off very fast?
It's possible, but they've done these experiments in vitro in specimen where there is no blood supply. And so if you don't have a blood supply, it can't wash away the acetic acid. So even in tissue specimen, you see this.
At this point, we may have to conclude. Would you like to ask a question?
Yeah, Dr. Pandali, I have one question. Thank you very much for your lecture. And so when you try to do the biopsy, we try to do the biopsy deep or superficial? Because when I was in Japan, sometime when we do multiple biopsy, try to do biopsy in the biopsy too deep, it's make ESD difficult.
Yeah.
So you suggest superficial biopsy or deep biopsy?
I know in an ideal world, we would not like to do biopsies. That would be the best situation, and it's already happening in Japan. In colorectal lesions, they hardly ever biopsy. Barrett's is a different game. Without biopsy, it's very difficult to operate in Barrett's world. So we still advocate biopsies, but we advocate very targeted 1 or 2 biopsy, and generally a superficial biopsy, not using jumbo forceps, not doing deep biopsies, because you're right, it causes fibrosis. But the fibrosis in Barrett's is less of a problem as compared to fibrosis in colon and in the stomach. We somehow get away with fibrosis a lot more in Barrett's than in colon and in stomach.
Thank you very much.
We may have to conclude this. We thank the chairpersons for chairing this session. We'll have to change our chairpersons before going to the next talk. May we please invite Dr. Vinay Thorat, Dr. Rajesh Dharamsi, Dr. Sunil Mathai, and Dr. Vijay Borgaonkar.
I should give my second talk as well. Yeah.
Dr. Bhandari will continue his talk. He's going to speak on early esophageal cancer endoscopic management so that he could go for the live demonstrations. So there's a slight change in the order.
Sorry, you got a double dose of me. This time, the focus will remain on squamous. In squamous, in the West, we don't get that much experience as we get in Barrett's, but still we see a lot of squamous lesions. They're generally very difficult lesions. And if you come to Portsmouth, you'll find that nobody refers any easy lesion to Portsmouth. Everything we do in Portsmouth is very difficult. The most important thing for squamous is this slide here, that a big meta-analysis which showed more than 6,500 patients who had history of nasopharyngeal cancers or chest cancer or lung cancers. About 0 to 18% of these patients either had a metachronous or a synchronous esophageal squamous cancer. This is a very high-risk group. These patients should be offered screening for esophageal cancer, squamous type cancer, and I don't think this is happening around the world. I know that in Japan they are quite hot on this, but outside that it's very patchy screening program. But that's where the biggest yield is going to be. In Barrett's, the detection of lesion, but detection of Barrett's is very easy. Detection of lesion can be challenged. In squamous, it can be even bigger challenge when it's an early stage. I've shown this picture to a lot of my colleagues and asked them where the cancer is, and nobody could see it because it's very, very subtle, very difficult to find. When you put Lugol, it lights up like a Christmas tree. Look at that. The beauty of Lugol is that this subtle area where we could see on white lights a subtle disturbance in the vascular network becomes very obvious. So you don't need to be a gastroenterologist. Every single endoscopy technician and nurse in my department will tell you that that's a squamous cell cancer of the esophagus. So Lugol does make it very easy to detect, but again, white light is what will make you think about Lugol. So you have to train your eyes to pick up this subtle vessel pattern disturbance to use Lugol. If you're not trained to pick up this subtle disturbance, you will not use Lugol and you will very easily miss it. So again, an example. Yeah. I don't think videos are going to work because I disconnected my laptop. There are issues with Lugol. It's a great dye, excellent for detection, and works almost universally. But some of the patients can get severe pain after using Lugol, so you've got to be very careful with that. If you're not very careful and patient coughs and retches and brings up some Lugol high up, they can get severe laryngospasm. One of my patients had such a severe laryngospasm that we had to do intubation there and then. Otherwise, you could lose your patient. It can be that severe. So be very, very careful when you use Lugol. Of course, you need to be aware about history of allergy to iodine. But the biggest problem I face in my practice is if you use Lugol, it causes desquamation of the epithelium. And if you bring the patient after your diagnostic endoscopy for an ESD within 4 weeks of doing the Lugol assessment, you'll find the lesion looks completely different. And it's been so confusing for us in the past till we began to realize and spoke to a lot of my Japanese colleagues to say, what's going on? And he said, yeah, this is obvious. Lugol causes desquamation. So when you do it again very quickly, the lesion distribution, morphology, everything will look different. So be very, very careful about that. If you want to do an assessment, do it with NBI and then use Lugol for resection, or use Lugol at the time of assessment and then wait for about 6 to 8 weeks and then do the resection when the regeneration would have happened and more or less it will look the same. Or use NBI at the time of resection. It's just very important if you are in this business of doing ESD for squamous. This is a technical fact which is not shared very well. This is what you look for, a red flare sign on white light. And when you switch on to NBI, this brown patches that you see is the area of neoplasia and squamous. So you need to train your eyes to recognize the red flare sign, and then NBI shows you this brown area, makes it easy. So NBI does a lot more than that. For that, you need to understand this IPCL concept, that the vascular network in the squamous, about the muscularis mucosa, these big vessels run, a big network of vessels, and from these perpendicularly, these small capillaries come out, and they form the IPCL, and these can be seen very easily by NBI. You can see these big vessels just sitting above the muscularis mucosa, and these tiny vessels that you see are the IPCLs. It's very difficult to understand the concept of IPCL, but basically as the squamous epithelium becomes more and more neoplastic, the IPCL gets more and more complicated. It becomes more dilated, more tortuous, more branching. So more complex the IPCL you see, worse is the disease. And Dr. Inoue described this very beautiful system of IPCL where you can basically predict the depth of invasion using magnification endoscope and NBI. And if you can master this, you can predict which patient should require what treatment. For me, sometimes it is very difficult, but our Japanese colleagues are really good at it. So I borrowed some of the images from my Japanese colleagues showing these areas. You can see on white light, it's barely visible. On NBI, it's very clear. It's a very complicated, tortuous IPCL, which is an area of invasive cancer. So this is the type 5-1 type of IPCL. You see on NBI, you confirm on Lugol, but by using magnification, you can see it's a type 5-1, which is M1 or high-grade dysplasia. So this is a classic lesion for endoscopic resection. If you change over to this is a complex lesion where you have type 1 and type 5-2 as well. So this area has got a combination of high-grade dysplasia as well as an intramucosal cancer, but still remains within the domain of endoscopic resection. This is looking very complex, tortuous, branching vessels. This is not for endoscopic resection. This is likely to be M3 or SM1. So this is not for us. So this is what we need to master. With NBI, these are the IPCLs that are endoscopically resectable. These are the IPCLs, when it starts branching out, becomes complex, not for endoscopic resection, because the depth of invasion is deep, there's a risk of lymph node metastasis. So Lugol helps you detect, but NBI or SM1 as well as characterization this is not for us. The depth of invasion. So this is what we need to master. With the ESD guidelines for ESD, we talked about ESD in every single organ in the gut. And in this guideline, we've also talked about ESD in the squamous. So I would strongly recommend you using these guidelines as they give you very practical guidance on what technology, what technique to be used. For squamous neoplasia, we say EMR is possible for lesions which are less than 10 millimeter in size because you'll be able to perform an en-bloc excision. For all other lesions, ESD is the technique of choice. So the bottom line is, if you have a squamous neoplasia, you need to perform en-bloc excision. If it's a small lesion, you could do an EMR. If it's a big lesion, you can't do en-bloc with EMR, so it has to be ESD. There's not a lot of data, but the data we have shows that if you do EMR as compared to ESD, there's a low recurrence rate with ESD and a high en-bloc resection rate with ESD. And the complication rate in expert hands is no different. So this is an example. Unfortunately, my videos are not going to work because we need to reboot. I don't think, do we have a time to reboot? Okay, I could reboot and show you just one video. Yeah, let's just see the videos. It's unfortunate that I unplugged it. So while it reboots, what I can do is discuss the management of esophageal neoplasia. So patients with squamous neoplasia are at very high risk of getting lymph node metastasis. So what we say in squamous, if you have the depth of invasion up to M2, then the risk of lymph node metastasis is very low if it is well differentiated with no lymphovascular invasion. So up to M2, all patients are considered as endoscopically curable. When it comes to Barrett's, it's a completely different game. In Barrett's, we say the risk of lymph node metastasis, how do I get rid of this? In Barrett's, the risk of lymph node metastasis in M3 is very low, and even in SM1 lesions in Barrett's with good prognostic cancers, no lymphovascular invasion, and no poor differentiation, you'll find that the risk of lymph node metastasis is very low, and those patients can also be endoscopically curable. So I don't know if that answers your question that you were asking me. We quote a figure of about 1.5% for SM1 Barrett's cancers, whereas for squamous, it's very high. So that's not acceptable for squamous. So that's what you got to remember, what pathology we're talking about. And then also there's some minor differences which I'll address in a second once we get there. So if I just show you a couple of videos, because we're running short on time, we can illustrate the principles. Hopefully. I don't know. So this is for squamous. This is what we quote. M1, M2, the risk of lymph node metastasis is very low. Whereas when it goes beyond M2, so I don't know if that answers your question that you were asking. So that's what you got to remember, illustrate the other important thing for your pathologist to know, well, if you don't know, your pathologist would not know. It's very important how you call SM1 in Barrett, how you call SM1 in squamous. The cutoff so this is for squamous, 200 microns. Anything more than 200 microns for muscularis mucosa is SM2 in squamous. When it comes to Barrett's, you will see it's very different. We use a cutoff of 500 micron. So up to 500 micron is all SM1 in Barrett's, and that's a good prognostic cancer. We do not offer esophagectomy to these patients. I'm sorry, my video has decided not to play. I'll just try one last time and play directly from here. Sorry. I'll just play. Okay, let's play this. Hopefully this can give you an idea. So that's a squamous patient with squamous neoplasia. I don't know if I make it bigger. You can see a very good submucosal plane, blue on the side, but when we come to the left, the plane is already being lost, where I was using the IT knife. This is the most difficult bit of dissection, is doing the oral end. I made a mistake of not doing that first. We should always try and do that first, because that's just what happens. When you are straight on, there's a risk of perforation. So we already have a perforation. If I put a clip there and then, it's the end of the show, so you have to carry on. And once you've resected it completely, it's safe to put the clips. Nowadays, because you do poems, you won't worry about such small breaches. But in the past, look at that in 2013, I used to worry a lot about it because it's very difficult to have a perforation requiring esophagectomy in UK. If you need an emergency esophagectomy, you know the risks are very high. Let me see. The other fact that I want to highlight is there are multiple lesions. I don't know why this doesn't work either. But squamous has got about 20% to 30% risk of having a second lesion in the esophagus. So please look very carefully. We've done patients with 2 or 3 resections in the same case. So always look for that. I think because the videos won't run, there's no point, I'll conclude. This video was going to highlight, if you see a visible nodule in a squamous, it's always not for endoscopic resection. Don't need a biopsy, don't need NBI, don't need anything. If you have a lesion visible like that, a nodule in squamous is always invasive. So it's very important to understand that. So I'll finish saying in squamous neoplasia, endoscopic resection is for low grade, high grade, and M1 and M2. surgery for anything more than that. But recently our ESG guidelines is proposing that if you have an M3 or a low-risk SM1 cancer, you can potentially avoid surgery in those patients who are at high risk for surgery. So this is what we are following currently in our patients, because a lot of these are elderly patients. Surgery can be very high risk in them. I'll finish there. Thank you.
Brief questions from the chair. Anybody in the audience? Any brief questions?
Yeah, Dr. Pradeep, one question. What about circumferential resection of the mucosa en bloc for either Barrett's or for if you're finding a squamous cell carcinoma? How often do you practice that?
That's a very good idea. You know, in the West, we did a lot of circumferential EMR for Barrett's for a long time. And then we found the stricture rates are very high. We found ways of managing those strictures, and somehow we used to manage them. But ever since we got RFA, the whole algorithm has changed. We do not perform, nobody does circumferential EMR for Barrett's. We just do localized EMR of visible lesion and then use RFA. The advantage of that, the stricture rate is very low, complication rate is very low, and if you do get a recurrence, it's very easy to manage. If you do a circumferential EMR, if you get a recurrence in that, managing that is an absolute nightmare. On the other hand, in the squamous side, RFA is still not popular. Majority of these squamous lesions are being treated in the East by our Chinese and Japanese colleagues. They have very good skills in ESD, and they're doing a lot of circumferential ESD in the esophagus and using stents, using steroid injection, all types of things. It's possible, but the data that you have is not robust enough. They're all anecdotal and observational series. So what we need is a randomized trial showing that this is very effective. And I think that's more or less going to happen very soon to give an answer to that question.
With NBI and the magnifying scopes in hand, the real need for the endoscopy now.
Sorry, I didn't get the question.
Having the NBI and the magnifying scopes in hand, what is the need of a chromoendoscopy, or which require chromoendoscopy?
Well, that's a very valid question. Not everybody can afford to have a high definition magnification endoscope, and on top of that, very good knowledge and experience of NBI. Chromoendoscopy is relatively easier, learning curve is short, and it allows you to do with any standard endoscope. That's the reason why you need it. If you have a very good experience, knowledge, and a high definition endoscope with magnification, you don't need chromoendoscopy.
In the interest of time, we probably have to move ahead. Thank you, Dr. Bhandari, and maybe call Dr. Rajesh Puri. He's going to speak on NBI in colonic polyps.
Good morning, Chairman, sir, and dear friends. Pleasure to be here, and I would like to thank Dr. Amol for giving the opportunity. Many of you must be thinking, what is an endosonographer is doing here? But when I visited Japan, and I think this is very close to my heart, visualizing the gut mucosa with the magnification endoscope or with an NBI, it definitely gives a different flavor. And I'm going to talk the role of NBI in the colonic polyp, classification for the routine practice, and their clinical significance. It is not what you look at that matters, it is what you see that matters. So the importance of the image enhancement technique is to get the real-time diagnosis so you can obviate the unnecessarily biopsies. as in the previous talk somebody has asked, would you take the biopsy? So now in Japan and few more places, the biopsy is no more done in many of the situations. If you require biopsies, then you can target the areas, which area you can get the yield, so 1 or 2 biopsy is sufficient. It gives the accurate delineation of the complete resection, and recently the discard of this resected specimen to avoid the unnecessarily histopathological examination is very important. And the most important thing is, with an NBI you can decide, can this patient be treated by endoscopy or he will require a surgical resection. So I'm going to talk the role of NBI in the polyp detection as well as polyp characterization. In the beginning of NBI application, in single center studies, many of the Japanese endoscopists thought that NBI is superior to the white light endoscopy for the polyp detection. But consistently the negative results from the Western countries, initially the Japanese endoscopists think there is a difference of the scope in Japan and the Western countries. But in the multi-center trial as well as in this meta-analysis, they concluded that NBI is not increase the adenoma or the polyp detection rate with the first generation NBI scope. But with an advancement of the NBI, that is a second generation NBI, in the multi-center randomized control trial, they have shown that NBI is superior for detection of the colonic polyp. These are the few examples of the effectiveness of an NBI. If you look at this image, which is a white light endoscopy which shows the veins and the dilated capillaries, but if you apply the NBI, you can see the better microvasculature. Another example, you can see the ill-defined lesion here, but if you put an NBI, you see the well-defined, well-demarcated lesion. So the NBI is very good. There's another example, if you see here, you can presume there is something is going wrong and there is a small polyp here, but if you apply an NBI, you see a well-demarcated lesion. So for the characterization of the pathology in the colon, NBI is very good. Let's talk about the role of NBI in the polyp characterization. So Dr. Sano in 2006, he said that NBI is superior to the white light endoscopy for the characterization of polyp. And it is as good as chromoendoscopy. Like previous, one of the chairperson has asked the presenter that, is the NBI is superior to the white light endoscopy or do you require a chromoendoscopy? So it is as good as chromoendoscopy for the detailed delineation of the pathology. But the advantage is NBI is of course definitely better because with the one switch, you can change from white light to the NBI. While in chromoendoscopy, you require chemical agents. It obscures the surrounding fields. So NBI has an advantage over chromoendoscopy, but at certain situations, especially in the type 3B lesion, where the NBI is not able, as Dr. Bhatt has said, it cannot give the accurate depth of the invasion. In this situation, if you do a chromoendoscopy, and depending upon the pit pattern, you can find out is the patient as a superficial SM1 lesion or an SM2 lesion. So here the role of chromoendoscopy comes. So in 2006, Dr. Sano has given the classification on the basis of subepithelial structure, that is a capillary pattern classification. And this is depend upon the meshed capillary. In type 1, the meshed capillary pattern is absent. Even if it is present, it is circular. While in the type 2, you will see the meshed capillary pattern. The capillaries are dilated and it is surrounding the pits. While in the type 3A, the meshed capillary pattern is characterized by the capillaries are dilated, irregular, and they have a definite end. They are not circular or they are not completely encircling the pits. While in the type 3, nearly an avascular area, or sometimes you may see the dilated veins. So in CP1, which is an hyperplastic polyp, you don't see any capillary pattern. Even if you see a capillary pattern, you will see a rounded capillary pattern. In the CP2, you see the dilated capillaries, which is in the mesh capillary pattern surrounding the pits. In the type 3A, the capillaries are dilated, irregular and the tortuous, while in the type 3, there is a loss of irregular capillary patterns, and that is intramucosal carcinoma is type 3A, and this is a submucosal carcinoma. So this group of the patient can be left alone. These patients require endoscopic removal. Intramucosal carcinoma can undergo an endoscopic removal, but submucosal carcinoma requires a surgical intervention. After the Sino classification, various classification came by the various Japanese authors, and they complicate the issue in the name of Hiroshima, Showa, and Jackies. They talk same surface pattern and the vascular pattern in a different way, and that create a lot of confusion and a situation of traffic jam. So what I suggest, those who are interested to learn the NBI, if you learn the Sino classification, if you learn the NICE classification, that is good enough to characterize the polyp and take the decision, rather than going into these details of the Hiroshima, Showa, or Jackies, which I am not going to discuss because it is unnecessarily going to complicate the talk. So the colon tumor NBI interesting group, they proposed a very simple classification using the non-magnification NBI. This is also very important because in India we don't have a magnify NBI. We have a 190 series, we have a non-NBI magnification. So the NICE classification we can use in our day-to-day practice. The magnification NBI is not available in India, so routinely we are not using the magnification classification. So the NICE is described as a type 1, type 2, and type 3. And in the NICE, they include the color of the mucosa, surrounding mucosa as well as the pathological mucosa, surface pattern, and the vascular pattern, the microvascular pattern. So in the hyperplastic or the serrated polyp, it is same as color of the surrounding mucosa or it is lighter, while in the adenomatous polyp, it is browner related to the background, and in the type 3, it is brown to dark brown in color. So on the basis of color, you can find out, are you dealing with the hyperplastic polyp, or are you dealing with adenoma, or you are dealing with the intramucosal cancer. In the vessels, either there is a no vessel, or you may find the isolated lacy vessel in the hyperplastic polyp. In the type 2, in the adenoma, like in a Sino, you find the brown vessel surrounding the white structure, and the white structure is the pit. In the type 3, there are area of disruption or the missing of the vessel, that is a Sino type 3A and type 3B. In the surface pattern, in the NICE, you will find the dark or the white spot of the uniform size, homogeneous absence of the pattern. In the type 2, you find the oval tubular or branch white structure, that is the pits. And in the type, you find the amorphous or the absent pattern. So this is very simple on the basis of color, vessel, and the surface pattern. So look at the example. This is a polyp on the basis of color, vessel, and the surface pattern. Here the polyp where the background is same as the polyp, or it is lighter than the polyp is lighter than the background mucosa, that is an hyperplastic polyp. But in adenoma, the polyp is more dark or more brownish in comparison to the surrounding mucosa. If you take a vascular pattern, in the hyperplastic polyp, you don't visualize any vessel, or you may find the isolated lacy vessel. There's a one case situation is a serrated polyp, which has not been discussed, which I'm going to talk. But if you talk about the adenoma, you find the thick brown vessels which surround the white structure, that is the pit. So that is a typical of adenoma. If you look at the surface pattern according to the NICE, the dark spots surrounded by the white lines in the hyperplastic polyp, while in the adenoma you find the oval tubular or the branch structure which is surrounded by the brown vessels, which is typical of the adenoma. This is an example of the type 1 NICE classification. The color, microvascular, and the surface pattern is like the surrounding mucosa. In the type 2, the color is more brown. You can see the dilated capillaries and the regularly arranged microcapillary vessels, tubular white surface structure. while in the type 3, you cannot see the microvascular patterns and the vital surface structure is visible. So, if you see the sensitivity and specificity of NICE 1 and NICE 2, it can clearly differentiate in the real time with an accuracy of around 90% and the negative predictive value of 95%. But there are certain practical issues with the NICE classification too. The accuracy of NICE 1 and NICE 2 for the theory of resect and discard or resect and the leave-in is not very well clearly mentioned. It has not discussed about the serrated polyp which looks like a hyperplastic polyp, and here is the confusion: would you leak the hyperplastic polyp or will you resect? The recognition of cancer and the assessment of depth of cancer is not as good as it should be. So if you look at the accuracy in the discard study 2, they included roughly around 1700 patients and 28 endoscopists, and the NBI optical diagnosis was only 83%. So they concluded that NBI optical diagnosis cannot be recommended in the clinical practice except for the expert center. And those who are using the NICE classification, they should have an optimal training, dedication, time and auditing and the feedback of the resected specimen. Now, as NICE has not discussed about the hyperplastic polyp and serrated polyp, on the one hand, hyperplastic polyp can be leave alone, but serrated polyp, sessile serrated adenoma or polyp, they are very important for the colon cancer. Around 15 to 20% of the colon cancer arise from the serrated polyp. So it is very important to differentiate. And these are the few important differentiating points between the sessile serrated polyp versus hyperplastic. The cloudiness of the surface, indistinct border and irregular shape, and the dark spot inside the crypts is characteristics of the serrated polyp, while the smooth surface, sharp demarcated border, symmetrical shape, and no dark spots are typical of adenoma or the hyperplastic polyp. So generally the serrated polyps are proximal in location, they are flat. You see the transparent structure, you see the mucinous cap over the polyp, you find the dark pit. On NBI, you see the groove pattern, and sometimes you find the expanded crypts in the telangiectasia, which is typical of the serrated adenoma. So, how to strategize your, once you have documented either on the SANO classification or on the NICE classification, how to proceed. So, if you find a capillary pattern type 1 or the NICE 1, you can follow up the patient. But if you find a SANO 2 or the NICE 2, in this situation, patient should go for an endoscopic resection. But SANO 3A, patient has to go for an endoscopic resection. In 3B, as I said, it is very difficult to find out the depth of invasion. In that situation, using the crystal violet, you have to find out the pit patterns. If the pit patterns are irregular, patient can be subjected to endoscopy, but if it is an invasive pattern, patient has to go for a surgical resection. The last 1 or 2 slides. So, once you have done the colonic polyps, if you find a type 1 polyp or type 2, try to differentiate between the serrated versus hyperplastic and adenoma. If these features are present, that indicate it is a serrated adenoma or serrated polyp. Otherwise, if patient is a type polyp without these features, it is hyperplastic polyp, patient can be left alone. Here, if the features of serrated is present, patient has to go for endoscopic removal. And in adenoma, that is type 2, if the serrated is present, he has to go for a surgery. So the future is, the random biopsy may be obsolete in few years. The targeted biopsy for the neoplasia, avoidance of the non-neoplastic biopsies, you can leave it. Real-time diagnosis and real-time therapy. And now the Japanese researchers are working on the endo-brain. I think what we are discussing will no matter. There is a set program in the computer, and the computer is going to tell on the basis of NBI characteristics, is it a hyperplastic polyp, is it an adenomatous polyp, or it is an invasive cancer. You don't have to apply the pit pattern or NBI classification. computer is going to give you the answer, and you can take the decision depending upon the final answer by the computer. So I'm thankful to Professor Norio, under whom guidance I have learned and who has given me his slide to present. Thank you. Thank you for the patience hearing.
Due to short lack of time, we'll skip the questions and we'll go to the next lecture.
Dr. Puri, there's just one question. That slide was very good, that confusion slide. But finally, they have brought out this consensus JNET, no? And what do you think about that?
Yeah, now the JNET I have not discussed. I have a slide of JNET classification. JNET classification is mainly the magnified classification. And as in India, we don't have a magnifying scope, I have not discussed the JNET classification.
The JNET classification.
So this is the JNET classification. Somebody can open it. So JNET classification, they have removed the surface. So what the color pattern which was described in the NICE classification, they have removed, and they have talked about the vessel pattern and the surface pattern, and it is based upon the magnifying endoscopy, that is 260 series or 290 series. So this is the difference between the NICE. So JNET type 2B, as I said, here you want a patient needs to be on the crystal violet staining with the chroma endoscopy and to find out the depth of invasion. If it is SM1 endoscopy, it is SM2, then a patient has to go for surgical resection depending upon the type of pit pattern. But this is not, scopes are not available and I have not discussed, that's why.
Rajesh, can we use 190 scope for the JNET classification?
It is not visible.
Can we use 190 series for the JNET?
No, we can. As I said, it is a magnifying scope. It is a 260 series.
Even the 600 scope from the Fuji, it gives a magnification of 130 times.
So I have no experience with the Fuji and the Pentax scope, frankly.
But the 190 series, I think it's a 90 times magnification, and it
yeah,
is,
but,
I think it's as good as the magnification scope available in Japan.
I have used both magnification endoscope 260 series. And the quality of image, the quality of the magnification, what you see with the 260 and 190 is different. You can get the much better view of the magnification endoscopy with the 260 series.
Yeah. Thank you, sir. We cannot take any more questions. We'll move on to the next talk. The next talk is by Dr. Surinder Rana, Strategies to Improve Endoscopic Diagnosis in GI Cancers. Dr. Surinder Rana, please.
Thank you, Chairpersons. Good morning, ladies and gentlemen. At the outset, I would like to thank Dr. Amol Bapai and all his team for inviting me, giving me an opportunity to be on the podium and also learn a lot of things from experts here. So I've been asked to talk about strategies to improve endoscopic diagnosis of GI cancers, and we have heard a lot about image enhancement technology, but as Dr. Naresh was stressing, that it's very important to do a proper, dedicated white light endoscopy. We all know that there is increased incidence of both upper and lower GI cancers. It's partly because of increased availability of diagnostic technologies. And the late presentation is associated with a poor prognosis and higher mortality. And in spite of advancement in various aspects of treatment, the key to the best prognosis is early diagnosis. Because with early diagnosis, you can offer a curative surgery. And if you diagnose very early, as we are discussing whole day today, we can offer an organ-preserving endoscopic therapy. But the most unfortunate part is that in spite of a patient undergoing an endoscopy, we have missed a cancer. And that increases the morbidity and mortality because the second endoscopy, most of these patients will be a delayed presentation. There are no studies from India, but the studies from West have shown that patients who have undergone an endoscopy, 2.3 to 13.9%, it's a substantial figure, they have a missed upper GI cancers. And this studies from Japan have reported much higher incidence because they also look at early cancers. It's almost up to the tune of 25%. And there is substantial amount of data on post-colonoscopy colorectal cancer miss rates, which is again 2.5 to 7.5%. And this table again shows the experience of various authors that the miss rate is about 4 to 25% of cancers have been missed on endoscopy. So how do we avoid this missing cancers? How do we detect early cancers, dysplastic lesions? I think the focus is on two aspects. First is to do a high quality white light endoscopy, and then image enhancement and advanced imaging techniques. So I'll not be talking about the second aspect. I'll be concentrating on the strategies to improve high quality white light endoscopy. There is a lot of improvement in the quality of colonoscopy. A lot of studies have addressed in West, and there has been a demonstrable improvement in the outcomes of colorectal cancer detection as well as treatment in the West over the last 2 decades. However, the quality assessments in upper GI endoscopy is a neglected field even in the West, and the majority of experience in upper GI endoscopy is from Japan, where a high quality endoscopy is routinely practiced as a part of screening for gastric cancers. And hence, there is a need to develop key performance indicators as well as quality assurance process in the process of doing a white light endoscopy if we want to detect cancers early and don't want to miss GI cancers. So let's look at the strategies to optimize lower GI cancer detection rates, because there is ample amount of literature available in this field. So I'll start off with this first. There are a lot of studies, including a landmark study in NEGM, which showed that removal of polyps and adenomas by colonoscopy lowers the colorectal cancer incidence and mortality. And then there has been a substantial improvement in colonoscopy, and colonoscopy is now available at most of centers. But as we started doing colonoscopy more and more, there was an increasing concern about the effectiveness of colonoscopy in detection of adenomas. There was a lot of concern about missed polyps and missed cancers. Early stage colorectal cancer, and especially the right-sided cancers, where Rajesh has just talked about serrated adenomas which were being missed on white light endoscopy, and these patients used to present with cancer later on. And as I had stressed earlier, there are a lot of population-based studies which have shown that 3 to 8% of these patients actually had undergone a colonoscopy within 3 to 5 years, where we missed an opportunity to diagnose an early cancer. And this was mainly attributed to missed lesions or inadequate examination. And if you look at polyps, then overall polyp and adenoma miss rates are quite high, to the tune of 20 to 25%. The main factors which are responsible for missing these lesions, besides the experience of the endoscopist, are, we all know that there is a relative difficulty to visualize polyps, small lesions at the proximal site of the haustral folds and the internal curves of flexures where there are bends. So many times we miss lesions there. Presence of flat lesions, there is increased recognition of flat lesions, and we know that flat lesions are sometimes very, very difficult to pick up even on a very good white light endoscopy. Poor bowel preparation remains a concern, because we are always going to miss lesions whenever the bowel is not well prepared. The right-sided cancers is a separate field because they are often diminutive in size, they are very small. They have a non-polypoid appearance as compared to left-side adenomas, and they have higher propensity to develop malignancy as compared to the left-sided cancers. And then we also should know the limitations of the instruments which we are using. The standard colonoscopes which we use, 140 and 170 degrees, even with the best preparation, with the best endoscopist, it is able to visualize 87 to 92% of the colonic mucosal surface. That means we are missing almost 8 to 13% of colonic mucosal surface. So let's look at the various aspects which we can improve so that the diagnostic yield of white light endoscopy can be improved. And the most important is preparation. We all know, all the guidelines talk that adequate cleansing of colon is a prerequisite for satisfactory screening protocol for colorectal cancers. And number of studies, number of good quality meta-analysis have shown that adequate bowel cleansing is associated with both higher adenoma detection rate, that's ADR, as well as higher polyp detection rate, that is PDR. Unfortunately, the literature provides only very minimal guidelines in choosing among various myriads of formulations available, that which preparation should be used for the best screening results. But whatever guidelines I've talked about, there are 4 basic principles, I think, which all of us would agree. And most of the guidelines also agree on those principles. First and foremost is that at present, the evidence favoring a split dose preparation is overwhelming. So most of the patients who are undergoing a next day colonoscopy should undergo a split dose colonoscopy, where the split dose is not started earlier than 8 hours before the procedure and finished no later than 2 hours before colonoscopy. If it's an afternoon procedure, then a full day preparation day of colonoscopy is acceptable alternative to a split dose alternative. And then we all should make an attempt to individualize. For example, you can use a combination of sodium picosulfate and magnesium citrate for patients who prioritize gentleness in preparations. Similarly, PEG preparation if the speed is a goal, and various other individualizing methods can be used. Low residue diet is recommended to be taken prior to the colonoscopy because there is ample amount of literature which has shown that it improves the visualization rates. And most importantly, the preparation is to be discussed with the patient because compliance is one of the most important aspects of an adequate preparation. So the goal of the preparation should be that it should be a satisfactory ball preparation which allows you to pick up lesions which are more than 5 millimeter in diameter, and it should be achieved in more than 85% of colonoscopy. So whatever strategy you adopt for preparation, this should be your goal. The second aspect of a good colonoscopy is a withdrawal time. When we all were learning colonoscopy, we all thought that the challenge was to reach the cecum quickest. But now, the more challenging is how slowly you withdraw the scope. That's what most of the literature recently talks about, the withdrawal time. We know that most of us will reach cecum quite quickly, but the withdrawal time varies significantly between the endoscopists, which we have seen in our daily practice, as well as the published literature from a lot of good centers have shown that the withdrawal time is actually different between various endoscopists. The withdrawal time needs to be spent productively with alert visualization, rotation of the scope to see entire circumference of the colon, and aggressive wash and suction to remove the debris. There was one first study which reported that a 9-minute withdrawal time had increased adenoma detection rate as compared to withdrawal time of 6 minutes. However, 2 large studies performed subsequently reported that there is no connection between ADR and the withdrawal time. But why this discrepancy? We all should understand that the withdrawal time is a process measurement. In contrast to ADR is an outcome measurement which will depend upon the experience of endoscopist also. But again, to stress, withdrawal time right now should be one component of teaching to help address less successful endoscopists to achieve acceptable adenoma detection rates. And whatever may be the studies, there has been ample evidence to suggest that mucosal visualization is best done on withdrawal, and it takes about 6 to 9 minutes to do it properly. Third important aspect is visualization of the right side of colon. Majority of missed cancers are on the right side of colon. The main reason is they are difficult to recognize even when the ball is well cleaned because they tend to be sessile, serrated, flat, barely discernible, but with potential to evolve to cancer, where the principle of size doesn't hold. So how do you improve that? One of the studies shows that if you visualize the right colon twice, you increase the adenoma detection rate by 10%. There are 2 strategies to do it. One is that you do it in forward view in one go, and the second is retroflexion. But the other study which compared the retroflexion with a second forward view said that the forward view is just as satisfactory as doing a retroflexion. Then there is a lot of talk about changing the patient position also, because we know that in a lot of dependent portions, the fluid residue tend to come and you're not able to visualize those lesions. So there was one study which compared the colonic position on withdrawal. One, there was no change, and another time the position was changed while withdrawal. There were 2 trials which did this with this design, and the benefit was approaching 10%. But again, this benefit was significantly less than if you just visualize that lesion second time again. So rather than changing the position, just revisualize the lesion second time, especially on the right side. There are various other strategies also changing position at various times, but again, nothing helps. So I think the important point to stress is that probably visualizing the same area twice, irrespective of patient position, is the best strategy. Then there is a water-aided colonoscopy. This initially was started to reduce the pain because air insufflation led on to pain, but then subsequently it was recognized that polyp recognition is also enhanced. And however, after an initial result which showed that the polyps are much better seen with water-aided randomized controlled trials have shown conflicting results. Nevertheless, these 2 studies which showed conflicting results have shown that the detection rate of adenomas on the right side is better with a water-aided colonoscopy. So if you have time, you can always put water on the right side of colon to aid in better detection. Anti-motility drugs, again, there are some trials using both hyoscine and menthol. Menthol is used aggressively in Japan. The Japanese study showed that the adenoma detection rate with using antispasmodic agents were much higher, but again, these results have not been reproduced by any other center, so they're mainly used in Japan. Then there are a lot of fold flattening devices like cap-assisted colonoscopy and endocuff, which all have, there are initial studies which have shown that once you flatten the folds, you are better able to detect the polyps, but again, they are cumbersome to use. Then there is a third eye retroscope, which is passed through the scope, and then you do a retroflexion. This is how it looks like. This is the pass through the scope channel, and then you do a retroflexion. Again, the study has shown that it has got a better diagnostic yield, but it is cumbersome to use. So an advancement over that was a third eye panoramic device. Again, this is one feasibility study published in an abstract form, but again, more studies are required to find out whether these increase the yield or not. Then there are new endoscopes which increase the vision from 170 degrees to higher degrees. So this is one fused system in which there are actually three imaging systems, one in the forward and two LEDs on the right side. So you give a better visualization, 330 degrees. Again, one pilot study have shown increased diagnostic yield. And similarly, Olympus is coming out with this wide eye colonoscope, which is based on a principle of total internal reflection, where you see the two different images on the wider angle so that you may be able to visualize the lesions much better. Briefly about strategies to improve the GI cancer detection rates in upper GI. Again, the experience is very, very limited, majority from Japan, and it is basically concentrated on these 5 aspects: indication for endoscopy, training, endoscopy technique, risk stratification, and quality assurance. In areas where there is high prevalence of GI cancers, a population-based screening programs are effective, as it has been shown in Japan for 40 to 60% decrease in mortality because of screening methods. The problem is how to do a screening in a low prevalence countries like ours. There are no definite guidelines. If you do endoscopy only in patients with alarm symptoms, we all know that these patients are the patients who have advanced cancers, and we are not going to detect early GI cancers. A brief word about training. Right now, the endoscopy training is mainly focused on technical skills to examine the GIT and aims for detection of major pathologies. Detection of subtle lesions as well as enhanced imaging techniques are not routinely taught. In Japan, the training in upper GI endoscopy focuses on detection of subtle mucosal changes, and this has led on to improved diagnostic yield for early cancers. As compared to recognition of colorectal cancers, more training is required for early diagnosis of upper GI cancer, as previous speakers have talked about this, have shown images that, for example, early gastric cancer has only minor morphological changes that may be very, very difficult to detect on a background of atrophic gastritis. Again, endoscopic techniques, there are no universally accepted guidelines. Serrated versus unserrated, obviously serrated would be better if you want to spend more time. And mucolytics and deformers, Japanese regularly use, and they have shown that it improves the visualization. The Japanese Society of GI Cancer recommends taking 20 images from various locations. This is what systematic screening protocol is. The aim is not to record the images. The aim is to ensure that you have seen all the lesions of the GI tract so that you are not missing the lesions. And finally, the quality assurance. There are colonoscopy quality indicators like withdrawal time, adenoma detection rate, but there are no performance indicators for upper GI endoscopy. One study from Singapore has shown that there is 3-fold increase in findings on an endoscopy with a mean examination time of 7 minutes as compared to an examination time of less than 7 minutes. And it has been suggested that withdrawal time of at least 1 minute per centimeter is required for adequate examination of Barrett's esophagus. So this is what is the suggestion. This is the last slide. The minimal total gastroscopy procedure time for an adequate screening should be 8 minutes, where 2 minutes should be to reach the second part of duodenum, which includes cleaning, mucolytic, and antispasmodics. The stomach should be systematically examined with image taking so that you don't miss any lesions, especially at the cardia. And then 2 minutes for esophagus, and if there is a Barrett's, then 1 minute per centimeter for adequate examination of Barrett's, including a combination of white light endoscopy as well as image enhancement techniques. So to conclude, we have seen that considerable polyps are missed during colonoscopy due to various anatomical factors, and majority of endoscopic innovations that we have just seen have shown little diagnostic yield, are more time consuming, and are not practical in use. Colonoscopy techniques that provide an optimal view while maintaining optimal washing, suction, and therapeutic capabilities is the need of the time, and probably combination of high definition and improved virtual enhancement technologies incorporated in an ultra-wide colonoscope may be the future. And for an upper GI, high quality training and quality standards with maintenance of key performance indicators will initiate quality assurance in endoscopy and improve detection rates for early upper GI cancers. Thank you for your patient hearing.
Thank you, Dr. Rana. We would need to conclude this session here because we are running 10 minutes over time, and we'll have to move to the live demonstrations. Thank you, chairpersons. We could call the next set of chairpersons, Dr. Rajkumar Wadhwa, Dr. Mayank Kabrawala, Dr. Sandeep Karoke, and Dr. Nitin Pai. there's no formal tea break. You could have tea and coffee on the go while the sessions are going on. It's possibly we may also have lunch going simultaneous with the sessions. But we'll make an announcement to this effect towards the time of the lunch break.
Wait, sir, 1 second, sir. We'll just know if they've gone live. Are we ready to go live, sir?
Yeah, we are ready to go live.
Can we have the moderators for the first session?
We are not getting your images.
No, sir. We are getting you a live image.
Yeah, now, hi,
yeah, Amol, we can see you here.
Morning, Amol.
Okay.
Morning, Naresh.
Morning, everybody. And we welcome you from the Shivanand Desai Center in Dinanath Mangeshkar Hospital. And our team is over here. Harshal, Nachiket, Rajendra is here. And Tarun, Mahesh, the entire team over here. And of course with us is our local friend from Surat, Pankaj Desai, who is always an integral part of all our workshops. So we are ready to go, and we have over here Saichiro, with his first case. So without wasting much time, let's go with the first case.
Okay. So can you hear me? Okay.
Just a short introduction of this case. She's a 65-year-old female who has 6 months history of epigastric burning pain and dysphagia. Gastroscopy and NBI showed irregular nodular mucosa in the mid-esophagus with type 3 IPCL pattern. CT thorax was done, which showed a mucosal thickening in the mid-esophagus with no periesophageal lymph nodes or no nominal narrowing. And the plan here is to demonstrate NBI and ESD for the lesion.
Yes. Hi.
So we hand over the session to Dr. Rebe. Please.
Yes. Hi, namaste.
Hi, namaste. Ohayo gozaimasu.
Thank you so much for the kind invitation. So, okay, time is limited, so I'm going to start my procedure. Now, so I'm going using the endoscope, gastroscope, HQ190. This endoscope has a magnification function and NBI. And I'd like to show you the lesion. So lesion is located on the middle of the esophagus. Here you see the compression of the left main bronchus on the 12 to 9 o'clock position. As you can see, a reddish black mucosa widely spread from 22 centimeter from incisor. Yes, this region widely spread to the distal side. Yeah, here is the distal side, so 27 centimeter from incisor. So this region is about 5 centimeter in size and involving almost complete luminal circumference. Okay, changing to NBI. Yes, so this region could be visualized as a brownish area here. As you can see, this region involves complete luminal circumference. Yes, I heard that somebody else already took biopsy, so this region probably is erosion due to the biopsy. And talking about the invasion depths, this region is very, very flat and no nodule and deep depression. So wall extensibility is very nice. I think it is a very, very superficial esophageal lesion confined to epithelium or lamina propria mucosa.
What measures will you take to assess the depth of lesion in this?
Yeah, so if a lesion invades to the submucosa, a lesion has thickness and nodule on the deep depression. But nowadays we can estimate depth of invasion using NBI magnification. Okay, so this is
the macroscopic characteristics of the lesion, whether it's a raised lesion,
yes,
the distensibility, as well as the NBI thing,
yes,
which will help you estimate the depth.
I think both. So we usually diagnose the lesion using both modality. And moving to the NBI magnification, so here you can see the dot shapes vessel.
We can see ulcer-like lesions on the surface.
They are,
How do you assess that these are not invading submucosa in this situation?
Yeah, so as I told you, we can see the very large nodule and the hardness and irregular surface, we can suspect the submucosal invasion. But our macroscopic diagnosis is not so accurate, so that we sometimes use EUS, endoscopic ultrasound, and nowadays Olympus produce miniature probe to investigate the depth of invasion. So, of course, unfortunately, today I don't have the EUS, so please ask Taro-san in detail. Okay, so moving up back to the NBI magnification, here you can see the dot-shaped vessel with a loop-like structure. So this vascular pattern strongly indicates this region confined to mucosa, and especially the epithelium or lamina propria mucosa.
From the NBI pattern of the IPCLs,
yes,
we can assess the depth of the lesion.
Exactly, exactly. When the tumor invaded to the MM or SM1, loop-like structures elongated and disappeared. And when the tumor invaded to deep submucosa, thick and large vessel can be seen.
Just show them a normal IPCL so that they can sort of appreciate the difference between the neoplastic.
Okay. Yeah, this is a vascular pattern of the non-neoplastic epithelium. So we cannot see the...
You can barely see the IPCLs, and they're pretty small.
Yes.
And in the neoplastic area, there's an area formation, there's well localized, you can make out the brownish thing, and the IPCLs are much bigger and darker.
Exactly, yeah. Thank you. So may I move on to the iodine staining? Maybe time is limited. We are behind the schedule.
You are planning to do a chromoendoscopy also?
Yes, yes, yes. So I'm going to spray the iodine. Iodine spraying is still the gold standard to make determine the margin, delineate the margin of the region.
What concentration of iodine you use?
I like the 2%.
2%?
Yes.
Okay.
That really depends on the situation and the hospital. Okay, spray.
Because I think in India, what commercial preparations are available are 5%.
More.
So
keep on going, keep on going, keep on going.
When we use
More.
With Lugol's iodine, areas which are not necessarily neoplastic can also get the thing with the...
So we can ignore the very, very...
You tend to overestimate the extent?
No. But when we use only NBI, we can sometimes underestimate. So I believe the iodine is necessary, essential. Okay, so here you can see this region can be visualized as iodine avoiding area. Yes, like this. Yes, this is the margin of the proximal side. And then, yes, so this region involves complete luminous circumference here. And this is distal side.
So normal mucosa will take up the brown color.
Yes.
While the one that is not taken up is something more clear?
Yes, exactly. It's correct. So I found another iodine stain area, but today I don't perform the ESD for this area. Okay, so as you can see, this region is a squamous cell carcinoma confined to mucosa, especially in the epithelium and lamina propria mucosa. So I'm going to put some markings on the proximal side and the distal side, and I'm going to change the endoscope to the flexible one.
Flexible. So NBI and chromoendoscopy are complementary when you are planning in US.
Yes, exactly. So we use everything.
Yeah.
Okay, so can I have dual knife?
Dual knife.
Okay, before that, can I change the endoscope? So please go to the other room, if
Yeah,
possible.
he's just changing the endoscope to a more flexible endoscope.
Yes.
Because this HQ endoscope is a little rigid.
Okay, please change. Go to the next room.
Is there any question or anything you can just keep on discussing or asking here? In the meantime, we change the endoscope.
Pankaj, you can ask him what settings of current he would like to start with: marking, cutting, soft coagulation, and the forced coagulation in that.
Okay, so today I'm going to use ESD 100. Of course, I also use always Bio 300, but today I'd like to use this machine.
Pankaj, I think all over India we preferably use Arbe rather than Olympus.
Yeah.
So it will be nice if you can tell equivalent of this in the Arbe settings.
In Arbe,
yes, the setting is almost similar between the Arbe and the Olympus. Yes, so today...
for marking you use a soft coagulation current.
So I think either is fine, forced coagulation, soft coagulation, either is fine, but I personally like the forced coagulation.
We are just shifting to the other room for 5 minutes, and this is the normal 190?
Normal 190, yes, this is a flexible H190.
H190 scope.
Yeah, very flexible endoscope.
It is a flexible one.
Yes.
Yeah.
So I think, I believe this is a very reasonable endoscope in narrow lumen of the esophagus.
Yeah, okay. So we'll just shift
Dr.
to the...
Yuri, we'll be leaving you for a few minutes.
Yeah, okay.
Okay. Thank you.
Patient, 17-year male who presented with dysphagia since 1 year. OGD scopy was suggestive of achalasia cardia. Barium swallow was suggestive of lower esophageal pressurization and achalasia cardia. Manometry was done which suggested type 2 achalasia. The plan is to proceed for poem. Over to Michael, sir.
Okay, can I have the knife?
Yeah, we can hear you.
Okay, can you guys hear us?
Yeah. Yes, we can hear you.
All right, so I'm really excited to be here. I want to thank Amol for inviting me to this outstanding course, first class, and we have this very nice young patient with typical achalasia type 2. And so what we're going to try to offer to this patient is a posterior approach form. So we literally just intubated the patient. And as you can see, I like the position that Inoue used to do the myotomy. So basically the patient is on his back and the operator comes from behind. It gives an impression of working from top to bottom. So the EG junction is located at approximately 41. So I typically pull back by 15 centimeters. So like this, I'm really comfortable to create a tunnel, because you're going to lose at least 2 centimeters once you do the tunneling.
Can you tell us why you have chosen posterior approach and what are the advantages and disadvantages of anterior versus posterior approach?
So I don't think there's enough data to decide that posterior is more advantageous than anterior. Most Chinese use the posterior approach. Inoue team use the anterior approach. It's just I've kind of settled for using more and more posterior when the patient in this position is very comfortable. So I'm going to start the injection. I'm going to use the Haberjet knife, T version. The T version allows us to grasp the fiber during the myotomy. So I have a GIF 1T 190, 3.7 millimeter diameter for the working channel. And here I am getting slowly started here. So I'm going to first inject into the center of the lumen to kind of see where is the 6 o'clock. And then I'm going to try to inject very gently here to create a little bleb around 5 p.m. typically. once I have the bleb, I'm going to start opening, a window to create the tunnel. So the mistake would be to make a window a little bit too small. So you have to find the right balance between a window that is big enough.
How much will be the size you will recommend at this time?
I think a 2 centimeter window is nice, typically. So you see here, we start finally, have a decent access. So the next point is very important. We're going to try to cut all the conjunctive tissue to facilitate entrance into the tunnel. So that actually is done typically with pure cut. Here it is. That's really a very important part of the procedure, to basically open yourself, a nice little window to facilitate entrance. And it's really key to do that, because that really spreads your entrance and facilitates the tunneling.
What type of current you are using now?
So once you are into the tunnel, you can switch to a spray coag at this stage. So we're using the Vio 3rd generation. Just literally came onto the market. We ordered it, but we haven't acquired yet in my unit. And as you can see here, to facilitate mobilization of the scope, typically when you're using an anterior position at the beginning, you start laterally. So on the right side, I have the muscularis, the muscle layer, and on the left side, I have the epithelium. So the game now is going to be to using pure spray coag to gently dissect our way into the tunnel. I'm taking my time.
I think we have to wait for, they want to go into the second room.
And I'm really trying to stay as close as I can from the muscle.
Sir, this is to the auditorium. You're going to get both the rooms as a picture-in-picture, and you can tell us when to switch across. And then we'll switch on the audio, sir.
Okay. So we're going to keep on going. You see, at this stage, I can put myself into the dedicated position where the muscularis can be posterior, like that, and anteriorly is the epithelium. So this is the classic, palm approach when you do a posterior approach. But you can see that you can, as an endoscopist, adjust the scope to whatever is needed to achieve a nice dissection. And that is a very important message that I always try to teach my fellow. You need to get the scope into the most comfortable position to do your dissection. Because you never know how tortuous the esophagus will be, you never know how much scarring you're going to see. So it's very, very important to understand that it's all about what makes your cutting the most efficient.
How do you make the direction, like whether you are in the right direction?
So when you have a very tortuous esophagus, typically, it's very hard to keep, the muscularis posterior, the posterior approach, the muscularis anterior, the anterior approach. So you really have to find yourself into a compromise where you can very easily...
Distinction between... can we shift to the other room as
Dr. Kale, we'll just leave you on the sound for a few minutes.
Okay.
Thank you. Yeah, Dr. Yuri, you're on again.
Okay. So now I put markings from the proximal side and distal side like this. So this region really involves a complete luminal circumference.
Yes.
So first, I'm going to make the incision from the proximal side circumferentially, and then move on to the distal side. Similarly, I'm going to make the circumferential mucosal incision. in order to make the end point of submucosal dissection.
How much is the distance you have taken between the end of the lesion and the markings you have put?
Yeah, so good question. So for the esophageal squamous cell carcinoma, the margin of the lesion is very, very distinct and clear. So we don't have to keep the very, very long margin, enough margin. So I believe only the 5 and 1 centimeter margin is good enough. Only 5 millimeter is good enough.
Saichiro?
Yes?
Would you, since this is a circumferential lesion,
yes,
would you want to do a tunneling kind of an ESD, or what is your plan?
Yeah, very good question. So I'm going to make the one tunnel to the left side. Now I'm performing the procedure the left lateral position. So the left side is the area water pools.
Okay.
Okay. And then I expand the tunnel using the IT knife nano. And finally, I'm going to use a clip line traction to get good traction.
Okay. Because the multiple gateway tunnel approach is also being described.
How much is the distance you have taken?
Yeah, I know. It keeps a very, very long margin. I know. See, enough margin. So I believe only the 5 and 1 centimeter margin is good enough.
Because
only
I
one.
use IT knife. So what is your plan?
Yeah.
Okay.
You use normal.
And then I expand the tunnel using the IT knife nano. And finally, I'm going to use a clip line traction to get good traction from Japan.
Yeah,
Okay.
sodium hyaluronate.
Because
so this is
he is using sodium hyaluronate.
Yeah.
Yes.
But we don't have hyaluronic acid in India.
Yes.
So for those who want to do this procedure, gelofuscin works pretty well.
Yes,
it works pretty well.
Yeah, I think so. I believe this is a good alternative.
Yes.
Amol, you would like to add methylene blue to gelofuscin or just plain gelofuscin will do?
We add a little methylene
hyaluronate. So this is
he is using sodium hyaluronate.
Either methylene blue
Yes.
or indigo carbonate. But we don't have hyaluronic acid in India.
Yes.
So easily available in India. For those who want to do this procedure to dissolve it, and sometimes if the solution is not good, you end up blocking your needle. So we use the methylene blue often.
I just wanted to know what current settings Dr. Uri has kept to take this incision.
Yes, so I use a pulse cut throw, 30 watt.
This is a 30 watt setting. I think on Urbe we use a 50 watt setting.
Yes, exactly. I think so.
Yeah.
Thank you. This patient probably has a chronic esophagitis because the mucosal layer is so thick compared with our standard normal patient.
So when it is a circumferential lesion and extending around 5 centimeters, to prevent stricture,
so
would you do anything?
Good question. So in Japan, the steroid treatment is mainstream. We have two methods. One is oral medication, and the other one is local injection, local triamcinolone injection. So so far, nobody knows which is better. So we have a randomized control trial to compare these two methods.
He prefers to start from the proximal side.
Yes.
Yeah. Any advantage over the cutting of the distal side here?
Yeah, so if we start from the proximal side, here you can see the very, very loose and clear submucosal layer. So we can adjust the depth at first.
Yeah.
This is a tick and trick. Of course, somebody prefer to start from the distal side. This really depends on the endoscopist, I think. I think either is fine.
Are you using the standard dual knife or a dual knife with jet function?
This is a dual knife J, so we can inject. Okay, so injection. So we have a water jet pump probably. It's okay.
Pull the tip back.
Okay, injection. Yes, so this is a dual knife J. So
this is dual knife J?
Yes, so we can easily inject using the tip of knife.
So you need not have multiple exchanges of your instrument.
Yes.
And how much is the tip of the knife outside the catheter? 1.5 millimeter?
1.5, yes. I prefer the 1.5.
Want to shift?
Is the bleeding looking more than normal, Pankaj here?
No, no, no. I don't think so. This is regular. As he told, this appears to be a little inflammation which is there around.
Yeah.
Which is causing a lot of
okay, injection please.
thickness of the mucosa and
mucosal layer is so thick.
No, injection.
Okay, so before that, can I do hemostasis?
Need a
coag grasper.
It's always advisable to do hemostasis before you do any further dissection, because that field will continuously be blurred with the blood which is coming.
Exactly.
And especially in esophagus, it fills up very fast.
Okay.
This is a coag grasper which he is using.
Yes. I use
soft coag.
coagulation 80 watt close. Okay, open. And the patient is actually very, very small female, so the working space is unfortunately very, very small.
Very less, yeah.
Close. Open. Close. Okay, open. Yes, okay, so hemostasis is successfully done. I'm going to continue the mucosal injection, please.
I think in the other room the tunnel is nearly getting complete,
Okay,
so we can shift over there for some time and then come back again.
No problem.
Okay,
We'll
thank you.
continue the dissection there.
Thank you.
You have to be careful. This is the area where you can have issues. You have to make sure that you stay very
Dr. Kale? Dr. Nile?
Yes.
Yeah, we are back with you, sir.
Good.
Okay.
So we have done some decent progress here. I'm almost crossing this junction. I'm not there yet. So I'm going to show you a tunnel. There is a decent tunnel. You see, anytime you debate about where to go, you go to the muscle, so it's okay to burn a little bit of fiber. You see, so this is the opening right here. I'm going to show you where we are. Here. So we're really very, very close from crossing. You see that? Actually, we are really about to cross.
Yep, we are just at the G. Probably.
Like 1 or 2 more centimeters. And we can start the myotomy. So it's very important to cross, because the benefit of your procedure will be highlighted by your ability to cross. So here I am, I'm advancing into the tunnel. Here I'm going to make sure that I stay close to the muscularis. You see, that's muscularis. And you see, intentionally here, I'm burning a little bit of muscularis, so I don't touch the epithelium. I'm going to inject here, injecting, making sure that I'm really, really close to the muscle layer. The mistake here will be to move the muscle layer, and then you have an issue. You see there's some a little bit harder here. So I think the plan is here. I'm going to advance some more here. Inject, coagulate.
There is a big vessel there, yeah.
So when you see a big vessel like this, the very first thing you do is you switch for a coag grasper. Can I have a coag grasper? And then we're going to need some water. Can we have some water, please?
So how do you decide whether this vessel needs coag grasper or you can just burn it like?
Anytime you have a significant bleeding, you need to, do we have some water flush? That'd be really good. That's great. That's just fantastic. So here, what I'm going to try to do, use the cap to kind of see, just by doing this, I'm a little bit delaying the bleed, and I'm going to try to grasp. No, actually, this is a big one, so just keep it close, keep it close. I'm going to keep it close here.
What current you are using right now?
FX5 80 watts.
So we want soft, so for hemostasis what we use is soft coag or a swift coag. So this is soft coag, effect 4 or 5. Right now we are using effect 5 and 80 watts.
Water. Very important to do that, because your coag grasper is coagulated to the vessel, right? And if you remove that after coagulating, you can actually remove the coagulation that you've done. So I'm going to remove. So it's still quite a bleeding. Open gently. Open gently.
So you did not open the coag grasper. Why was it like, you just...
Anytime you have a big vessel, you really need to do a coag grasper.
No, you just did not open the coag grasper. You did...
Well, I was hoping to actually with the tip of it to get it. Now,
Okay.
water, open, close. Okay, we control it. So what I'm going to do now, unfortunately we're really close from the epithelium. I'm going to go around and make sure that the integrity of the mucosa is respected. Okay, so we better find out early if you have any issue or not. So it seems that we are fine.
There is some burn,
We are
but otherwise it's okay.
Yeah, this is fine. So I'm going to flex to see exactly. So I think we have crossed. You see that?
Yep.
You see a nice little bleb here,
Yep.
which means we are in the stomach. That's the most accurate sign that you actually get into the stomach. When you start meeting this big bleb of blue, and then the other side is actually seeing big vessels that are basically gastric vessels.
Yep.
So this is nice. So I think at this stage it's safe to start the myotomy. I'm going to go back just to assess the site. Here it is.
Are there any internal signs which would tell you whether you are near the GE junction or you've crossed GE junction?
I mean sometimes you can see the change in the muscularis. I mean, if you pay a lot of attention between this type of muscularis here and the muscularis down there, well, now it's a bit coagulated. It's not as thick. It's much smoother because you change the type of muscularis. That's really the biggest change you can have. So I think at this stage, I'm actually comfortable starting the myotomy. We saw the bleb.
And do you see any noticeable difference of muscle thickness at GE junction?
Oh yeah. So the lower you get, the less and less,
Thinner.
difference there is between the longitudinal and the circularis. They kind of melt together. But it doesn't really matter because most experts now recommend
Full thickness.
Full thickness in the lower. So what I'm going to do, can I have the knife? What I'm going to do now, I'm going to start by the myotomy using basically a cleavage plan between the circularis and the longitudinalis. I'm going to cut the longitudinal layer. I'm going to leave the longitudinal intact, and the last 5 centimeters will be full thickness.
Okay.
It's very important to do this. So,
And you would be starting myotomy like 3 centimeter, 4 centimeter.
So one thing at this stage I want to do is check the belly of the patient because our threshold in my institution is to do more and more decompression early on. We've noticed that the patient feels better. Yeah, he's very tense. The patient feels better. The parameters of the patient are better, and also the anesthesiologist became much more comfortable. So actually, his belly is quite tense. So at this stage, actually, I am going to decompress him.
And how are you going to do it? Just
Can I have a 15 gauge needle, IV?
Okay.
Dr. Kale,
Yes.
we're going to leave you for a few minutes.
Yeah, we would just arrange the things and you come back.
Yes, yes,
you
yes,
come
sir.
back because we want to show this thing.
Dr. Nile,
Yeah.
we'll come back to you, Dr.
Yeah,
Nile.
yeah.
Thank you. We're now
Yeah, we'll
going
just
in-
prepare everything and then
Thank you.
they-
Cut. Case history.
This is a 61-year-old gentleman, known case of hereditary hemorrhagic telangiectasia with the history of recurrent GI bleed, which was secondary to the gastric and the small bowel telangiectasia. History of multiple APC done in the past. On routine evaluation, found to have gastric fundic sessile adenoma. Histopathology was suggestive of adenoma with high-grade dysplasia. Plan is to characterize the lesion with the help of NBI and ESD. Over to Bhatt sir and Dr. Bhandari sir.
Oh, they're with us.
Are we on? Can you hear us?
Yes, we can hear you, Dr.
Right.
Naresh.
We have Pradeep here doing the endoscopy. This is a gentleman with portal hypertension. We found a couple of small varices, grade 2, Pradeep?
Grade 2, I would say.
Grade 2, and fortunately we have no fundal varices.
Yeah. You carry on if you tell them the history.
And so while we went down to the stomach and we found a lesion there in the fundus, a flattish looking lesion, little elevation, so it's being fortunately 2A, 2A, it's what would be the size, about 2.53 centimeters? And
I'd say about 4 centimeters.
4?
Once
Yeah,
it
we went
extends.
down to the scope is about, found a lesion there in the fundus, about flattish
3-4 times that.
yeah, between 3 and 4 centimeters.
Little
elevation, so it's you can see the color is a little pale. to it, and it's little irregular and bumpy. And that's what making Pratik feel that it's a little more sinister than what we'd be happy with.
I think the histology has been only an adenoma, but if you look at the lesion, it's quite a big lesion, and depending on where you biopsy, you'll get your histology. So on white light, various things we need to do. One is assessing the background. This stomach doesn't look that atrophic, and it's a proximal lesion, so you need to start thinking about poorly differentiated or signet ring type of lesions, which are generally proximal, they are pale, and they don't have that much atrophic gastritis. So that's a very important thing to keep in mind. Second thing is about the lesion and assessment. So on white light, we see slight depression there, which could potentially be a 2C area. I've been trying to wash it, but it's very difficult to get rid of the mucus. If you wash too aggressively, you'll make it bleed, and then NBI has no role. So you've got to be very, very careful about that. I'm going to switch over to NBI. And you gave an excellent talk this morning, Dr. Mishra, about NBI. Yeah, you want to talk to them about NBI, this lesion.
What you see, look at what's happening looking around the lesion and saying, you gave an excellent talk this morning. What you see, not like a body, looking at the rich, and then suddenly finds this so there is a criteria of demarcation, if one may say so.
Yeah, there's very clear demarcation line. So that's the beauty of NBI, is you can demarcate the lesion very well. And somebody asked me a question earlier, that nowadays with NBI, is it possible to get rid of the dyes? And when you have a demarcation like that, I think you can see everything with NBI. Yeah?
Okay, so what we're seeing on the surface actually is that the surface pattern is looking different from what is in the periphery.
Yeah.
And it's looking more almost villous, if I may say so.
Yeah. So if you look at this area here.
Dr. Naresh, if you can elaborate more, if you look at the lesion towards the edge, while the surface pattern has more regularity, if you look near the mucus where it is, the vascular pattern there is pretty irregular.
Yeah, I've not come to the vascular, I've just first...
Dr. Bhatt, sorry to interrupt, and Dr. Wadla,
yeah.
They just want us to cut across to room number 5 for just a second.
Yeah.
We'll just get back to you. Sure. Thank you, sir.
Are we back?
Yes, sir, you're back on.
No, we are still, now we are back here in the room number 5.
I'm about to do a needle decompression of the peritoneum. Can we show that on the screen, please? Okay, you see? So
No, we have an audio and video dissociation here.
So this is an area where there's a little bit of tympanism. So it's very important.
Sir, Wadla sir.
Yeah.
This is from room number 5.
And then
that is for the poem group.
You leave the
Yes, sir.
in.
Yes, sir.
You leave it in.
Just keep it in, right.
Open circuit. Okay? And now you check with the anesthesiologist and you're going to slowly see the parameters of CO2 retention getting improved. Where's my anesthesiologist? Okay.
Yeah.
So what do you think? What's happening here in terms of...
Initially we are requiring high rate of ventilation. Now I think we are able to control the issue.
While this reduces the carbon dioxide, we still can see it more visibly if we attach a syringe with water in it.
So the threshold of doing a needle decompression should be very low, because there's only benefit. There's really no real adverse event if you do a nice, in all the country, it will allow you, to proceed more comfortably with your myotomy. In this case, and the patient actually symptom will be better after. Can I have the needle out, please? Out?
Yeah, just take it out.
Okay, we're going to start the myotomy now. So my job now is to find the space between the longitudinal and the circular. So I'm trying to expose. You see, I still have a lot of circular here. Okay, so I'm going to gently get in until I get the longitudinal exposed.
And you are using endocut.
I'm using endocut, here it is. We can see now the difference between the longitudinal here and the circular right here. This is my plane. So I'm going to now gently take this down and into the center of the lumen. Here we go. Here it is. You can see the difference between the two layers. Now really I'm introducing the knife between those two layers right here, and I'm going to proceed to dissection.
Instead of type 2, if this was a type 3 achalasia, would you like to do a complete myotomy instead of circular myotomy here?
I think that the data on complete myotomy, except when you have like a jackhammer or a nutcracker, is still out there. So I think if you have a nice 12 to 13 centimeter length myotomy, you should be fine.
No. Dr. Maidev is here. He would like to make a comment over here.
Versus full thickness. Just give this.
That's the question.
Here it is.
What was your question, Raju?
I said if it was instead of type 2 or type 3 achalasia, would you prefer a complete myotomy over a circular muscle myotomy here?
Yeah.
Esophagus.
See, basically, type 2 and type 3 achalasia, the difference will not be in whether it is circular or full thickness. Difference is going to be the length of myotomy. In type 3 achalasia, you need to do a long myotomy, whereas in type 2, you need to do a medium length myotomy. Whereas in type 1, you should do a very short esophageal length myotomy, because already there is a inadequate peristalsis in the body. Now circular and longitudinal, full thickness and partial thickness, there have been number of studies to show that there is actually no difference between the two. The only advantage is when you do full thickness, it takes faster. The time taken is faster, because you don't have to keep on dissecting between the two layers.
Well, we are about to get to the place where we're going to be full thickness. So the last half centimeter has to be full thickness. So, there we go. So at this stage here, you can see a difference between the two layers. I'm going to, on purpose,
See now, he's doing a full thickness here.
Now I'm going to be full thickness.
Yeah, my question will again go back to it. If we are not, there's not much of a difference, why we are so apprehensive about full thickness in esophagus? Why not to go straight away and do full thickness right in the beginning?
Well, it's a good question. I mean, it is faster,
yeah,
but you will have a little bit more normal, obviously. And I think the Chinese have demonstrated there's not much difference in terms of efficacy. So I think, if you have an anesthesiologist that is comfortable and able to deal with a high CO2 pressure, if you accept that you're going to have a little bit more pneumomediastinum and a little bit more pneumoperitoneum, and you're going to probably have to decompress systematically, that's fine. I mean, I recently did a jackhammer, and we were like a 25 centimeter myotomy. I mean, we had to decompress like almost immediately because we were so high up that the retention of CO2 was pretty intense from the get-go.
Raju, for example, I do all full thickness right from the beginning, right from up to down.
Correct.
Now this issue of CO2 causing capnomediastinum and capnoperitoneum, more than the full thickness and circular thickness, it depends upon the flow of CO2.
Okay.
So what is extremely crucial in a POEM procedure is to reduce the flow of CO2 beforehand itself to such a level that the bubble size also has to be small, and the amount of bubbles coming per minute are also very low. And if you can adjust that, many times you will not have any capnomediastinum or capnoperitoneum.
Do you have any rate flow per minute, something like that?
Yes.
What are the settings you use?
For that, unfortunately, we do not have such a highly accurate machine. We have developed a Indian machine for CO2 insufflation, which is called as a accusufflator or a nanosufflator. where you can actually control the size of the bubbles and the number of bubbles. It is a digital microprocessor controlled machine. And instead of depending only on the tubing size and the flow of gas from the cylinder, you should use such a microprocessor machine.
Okay, Dr. Amit, we'll just get back to you, sir.
Yes.
Thank you.
Hi.
Dr. Abe?
Yes.
Dr. Abe, we are with you, sir.
Yes, okay.
Yeah.
Open.
Dr. Pankaj, you're on.
Yes, yes. So what we have done is just put an incision in the proximal side,
in the proximal area.
dissected a little, and then we put an incision at the distal end, just distal to the markers. And now he has changed the working knife to a IT nano knife.
Yes.
And he is dissecting with the IT nano knife. And this is now the circumferential dissection in the tunnel. We have not applied a clip so far. I don't think he may require it the way things are going here.
Pankaj, any advantage of IT nano over a conventional IT?
Yeah, IT knife nano is very helpful to make a tunnel. Okay, let me show you. Okay, IT
We'll
knife.
just ask him because the same thing I think we can do with dual knife also with the jet function.
Yeah, of course.
Yeah.
So actually, I mainly use IT knife for all organ. So I really use.
Maybe the dissection is faster when the lateral.
Yeah, exactly. And also the tip of the IT knife, of course, insulated. So it can prevent the perforation. So the southern course of the esophagus very, very smooth and loose. So that we can insert the tip of knife like this, and then.
So it is just for the safety purpose that he is using it to not to injure the muscle below.
Yeah, like this. We can easily extend the tunnel. And also the esophagus is very absolutely straight, so it is a very, very safe procedure. And then we can extend the tunnel like this. Advance the endoscope little by little like this, and turn the endoscope.
You can see that he is keeping the instrument in a stable position, and the only thing which is moving is his endoscope. You can see the way he is holding the scope and doing it. And the way the vessels have been tackled.
Yeah, of course, we can coagulate.
Yeah, they can intermittently keeps on coagulating so that they don't start bleeding in the tunnel.
Yes, exactly, yes. Thank you, so kind comment. Very fast and safe. Yes. So now you can see the tunnel like this. And we can coagulate a small vessel at the same time.
So this picture is exactly like what we see in the poem procedure.
Yeah, I think so.
You are actually in that tunnel. There are two incisions above and downwards. We have to make them communicate.
Yes. Well, hopefully.
Dr. Abe and Dr. Pankaj will leave you for a few minutes.
Yeah, sure, no problem.
Thank you. Dr. Bandari and Dr. Bhatt.
Yeah, so as we were discussing earlier, we've got a irregular lesion between 3 to 4 centimeters in the fundus. Looks pale, not much of surrounding atrophy. So we felt that it was possibly an undifferentiated lesion. And Pradeep has found a slightly depressed lesion here, more proximally towards us. That means more distally actually as far as the anatomical thing of the lesion. It is depressed, and if you look closely at the NBI, I think maybe you can go to near focus.
Yeah.
Can see the...
So if I show you the boundaries of this lesion, so if you look at this pattern, it's like a villous pattern, which is non-invasive pattern. But if you come to this area, all this is very complex vessels, very complex surface pattern. This is suggestive of invasion. And the best way to look at it would be to use near focus. Again with near focus, if you first look at this, this is very reassuring. This is what we want to see everywhere. But look at this.
So bang center there, you can see the villus pattern is almost gone, destroyed, and suggesting that they actually maybe might have moved on from adenoma to carcinoma. The other thing is that if you look at this lesion from a distance, you can find that it's not distending too well. And because it's not distending too well, and it's possibly undifferentiated type of malignancy, gastric cancer, the chances that there's a deep invasion would be very high.
Yeah, I agree. My suspicion here is this is probably SM massive or more than SM1 cancer in this area, starting from here to all this. When you go to this side, it's okay again. This is all fine. Do you see that villus pattern? So this is very reassuring. So this will be not a problem. Our problem is here. So we just done the marking. As you can see outside the lesion, all around. That few things you need to do before you resect these lesions. One is I always flush water and see which way it's going. So you see water is not pooling on it. The water is running away from it here, which is good, which means this area is very vascular. Whenever we work in cardia, we get a lot of bleeding. So water is moving away. So if it does bleed, then if the blood will be moving away from the lesion, which is very reassuring to know right at the start. The second was to distend and suck and distend, and we've done that a few times. You can see there is distensibility, but when you suck, it doesn't really retract as well as the folds on the other side. That again tells you that this is likely to be deep invasion. But we've done the marking. We intend to resect, mainly because he's got portal hypertension, varices. So doing a total gastrectomy is going to be very high risk in this guy. So the decision is to see if we can resect or not. Do you agree with that?
Yeah, I agree. Pradeep, though, if it did not have that, I think he would be primarily a candidate for surgery.
I completely agree. We would do a biopsy and then send him off for surgery.
Would you like to do an endoscopic ultrasound before doing that?
Well, endoscopic ultrasound in gastric lesions has never been that rewarding. And when it comes to a lesion up here in the fundus, it gets even more complicated and difficult to make any sense of it. But there are lots of enthusiasts of EUS, and they say they can see everything that you need to see. I'm not one of those, and I generally can get all the information I need by just endoscopic assessment. But I'm sure EUS in expert hands will definitely add value to it, but not in my hands. Would you consider doing EUS?
No, not really. I mean, I think one must understand that there are so many other ways that one can get the same information that it's not necessary to do an EUS. And it seldom changes your management strategy.
Without dye will manage. Just gel effusion de do mere ko, I will just spray that.
Pradeep, would you consider using any kind of chromo endoscopy in this patient?
I mean, traditionally it's a custom to use indigo calm and dye spray for gastric cancer. That's how I've been trained. So you feel the urge to do that. I'm not sure how much value it adds, but it will certainly show the morphology a lot better. So those depressed areas will become very obvious. So that's the reason. And the other thing I use it for is these white markings that I've done. If you put dye on it, you can see them a lot better. They'll take the dye and they're so easy to make out. So that's why, although we don't have indigo carmine dye spray, I'm just going to use some gel effusion with indigo carmine to see if it will take the dye or not. It just helps stain those marks. With the contrast, it becomes easier to see your markings.
How useful is the elevation?
Dr. Bhatt?
Yes?
We'll just leave you for a few minutes.
Okay.
Thank you. Dr. Kale?
Yeah, so we spent some time adjusting the catheter to drain the peritoneum. You know, so like this, the numbers of the patient are better in terms of CO2 retention. And now I'm about to finish the myectomy here. I'm at the last centimeters of it. Very gently here. I'm advancing. This is an area where you have to be very careful, obviously, because there's a lot of vessel. You're very close from the epithelium. So you see, I use a little bit more chloride here. I don't cut. So not only I call it and cut. You see here, There's definitely a few vessels here maybe hidden. So I coagulate a little bit here. There it is. Okay, and then I finish with the cut. Really at the end, this is the moment where actually I like to revert the position of my knife. That's a little trick that I'm going to show you here to make sure that you don't touch the epithelium. You see, I revert my knife and I'm cutting the other way around. Now we're really at the end here. Okay, so here is epithelium. I'm going to inject a little bit here just to make sure that I split the epithelium from the muscularis. Okay, right there, here. Here I'm going to inject a little bit more, here, and I'm going to cut the last fibers. Here it is. That's it. So that's now a full anatomy. Over here is going to be the peritoneum. Over there is going to be the mediastinum. So the ultimate test of the efficacy of our myotomy is to basically get out from the tunnel and try to see how easy it is to cross the EG junction. Here it is, and you can see actually there's like zero resistance here.
Yep.
So that's the ultimate sign. I have kept still the habit of going back one last time, make sure there is no flow left down into the tunnel. And the other habit that I kept, you see there's definitely no fiber. You only see some vessels and some conjunctive tissue. So here there's really no need anymore to dissect. And what I'm going to do here, I kept the habit of doing a gentamicin wash before closing the tunnel. So here it is, some gentamicin wash. I take 1 ampula of gentamicin wash, typically in 50 cc. Here it is. Okay, here. Where's the cap? The cap, sorry. So now that we have the gentamicin wash, what we're going to do, we're going to get out of the tunnel and we're going to close it. Okay, so it's not such a big opening, but the technique of closing a posterior palm is a little bit different from the technique of closing an anterior palm. Which clip is that?
This is Olympus.
Okay, so we're going to use a rotatable generation 2
No, this is
from Olympus.
This is
The very
Olympus, right?
first
This is Cook.
Open.
Olympus, no?
Open. Open. Okay, so the very first, can you rotate a little bit here? Rotate a little bit. Towards you. Towards you, rotate. Okay, open now. Open. Okay, so very important to put the very first tip outside of the tunnel. Is not so good. Okay, we need to better let's work together here, very important. Okay, I'm going to ask it, go, close, all the way. Here, there you go. There you go, okay. You see, very important because when you do that, you have the gravity that's going to help you. So you see, just by doing that, there's approximation of 2 lips of the opening. So now what I'm going to do is, using still the technique to close the posterior palm, is try to get each lips anchored by the clips before closing them, and then use suction, open here. Okay, so very gentle, a little bit of rotation here. Here, a little bit of rotation. Okay, here, suction, close, all the way, here it is. Let it go, open it. You have to feel it. Very important to
Open it. Just
close
no.
and then open it. Because once you do that,
No, it's stuck. Get to me.
Get to
me. Yeah, nice.
Okay, good. Can I have another one? You see, it's going around maybe 2 or maybe maximum 3 more clips, we'll see. And the gap is between 0.5 centimeter to 1 centimeter. Not too close, not too far. We have to remember, we are approximating. That's the technique. Here it is.
So, Dr. Nene, we'll keep watching you, sir.
Okay.
We'll just move on.
Yeah. We are done.
Right. Thank you.
Thank you.
Dr. Beck?
Yes.
We are with you?
Yes. So I already extend the tunnel and continue the submucosal dissection like this. So I'm going to show you the clip line traction to get a good retraction.
So he is going to show you how we apply that clip-in line.
Yes.
Can you focus on Taro's hand and the clip here?
Okay, so first I insert
switch off the light.
catheter also seats of the clip to the accessory channel. Okay, so now you can see the tip of seats. And open bit
Slowly.
So it's too much.
Only a little.
No, that's too much. Oh, we can try again.
Fire.
Okay, we'll throw something. Okay, so let's try again. Can I see the tip of catheter? Yes, okay. So open clip a bit.
It has to be opened only a little. Don't take that hinge out.
And then, please. Okay, apply the line between the two braids like this, and
this is the dental floss.
Yes, this is dental floss. Okay, and cut the remaining one.
Dr. Abe, we'll just get back to you in a minute.
Yes.
Thank you. Yes, Dr. Nilay, you're on.
Yeah, just to show you the last clip.
The last clip here, in place. Okay, suction, close, all the way. There it is, last clip in place here. So very important to make sure that everything is closed. So we're going to go on the left side of the opening. You see everything is completely sealed. Now we're going to go on the right side of the opening. Everything seems to be sealed. Here it is. So at this stage, really, we're very happy. And we're going to leave. Voila!
Can we go back?
Thank you, Dr. Kale.
Can we go back to the?
Yes, sir. We're going back to room 3. Dr. Pankaj, we're with you.
Yeah, he's just showing the clip in line. Yeah.
Okay.
So what they have done is we have tried the dental floss to one of the open ends of the clip and cutting off the extra length of the thread there.
Okay, so close.
And we'll take the clip back inside. Just a little.
Yes, okay, so please turn the light on. Yes, I'm insert the endoscope again. Oh, so please turn the. It's okay, sorry. So now you can see the exposed submucosal layer. But hopefully I'm going to apply the endoclip to the backside of the specimen because I don't want to injure the specimen.
Okay.
Okay.
So he is not going to put the clip on the specimen but just behind it. So
Yes.
he doesn't want to injure the specimen. That is what his rationale is.
Okay, so pull the light a bit.
Now
Okay.
it's like
Open. Open a bit.
आता क्लिप लावायची आहे खोल.
Okay.
Traction.
And turn the clips to 3 to 9 o'clock position.
Okay.
Rotate. 10, 3 and 9.
Okay.
Okay, so now definitely you see the submucosal layer. Okay, so fire. Okay, so now we successfully apply the endoclip to the backside of the specimen. So here you see the lifted
The submucosa has been
yes.
detected. You can detect the
So definitely the following procedure is very, very easy. Okay, injection please.
Now we'll apply a little traction to the thread which is hanging out of the mouth.
Yes. Here you can see the very, very nicely seen. Submucosal layer is nicely seen.
Okay, needle out. Injection. Okay, keep on going, keep on going. Once again. Okay, loose submucosal.
Can you see the distal end of the tunnel?
Yes, we can see that.
Yeah, only this area is remaining now to dissect.
Okay, please.
Pankaj,
Yeah.
is this applicable only for a circumferential lesion, or I think we can use this for almost
Anything, yes,
anything?
yes. Yeah, you can use it for anything. There is a good method of retraction and giving a counter traction. Makes your life much easier.
At this point, we will thank the chairpersons for chairing the session, and we'll have a change of chairpersons coming on.
I would like to invite chairpersons for the continuation of the live demonstrations. Dr. B.D. Goswami, Dr. Ajay Jain, Dr. Vivekananda Kulkarni, and Dr. Meghraj Inge.
You can. This is going to get over in 5 minutes.
May I invite the chairpersons for the live demonstration?
Okay, injection please.
Okay, you can.
Dr. B.D. Goswami, Dr. Ajay Jain, Dr. Vivekananda Kulkarni, and Dr. Meghraj Inge.
Okay, inject. Okay, good. Keep on going, keep on going.
Okay, Dr. Abhay, we'll just get back to you, sir.
Okay.
Dr. Bhatt,
Yeah.
we are with you, sir.
Okay,
And
thank
Dr.
you.
Bhatt.
Thank you. What Pradeep has done is he showed you the markings. He injected gelfusin with some indigo carmine, and surprisingly it raised quite well. That is in the distal part, that's proximal close to the scope. And then he made the cut. And then we had a little nasty vessel there, which he successfully
Core grasp, right?
did use a core grasper, and
It's likely
then
to bleed
you can
again.
see it there in the center. So Pradeep, when would you use a coag grasper? When would you just use your
Yeah, so big vessels you can't do anything with the knife. But small vessels, we try to coagulate on either side of the vessel using forced coagulation current at very low effect. And then,
So what is big and what is small?
the one that we saw was a big vessel. So anything
Now,
which
any
is
kind of guideline as to the diameter of your knife, this is the thing?
more than 2 millimeter vessel,
Okay.
it cannot be treated with a knife. That always requires coag grasper. Less than 2 millimeter vessel, you can easily coagulate slowly from both sides, and then you can cook it.
So what's the tricks to using the coag grasper? Any special tricks?
Yes, that's very important inject. So for coag grasper, the most important thing is very, very precise grasping. As you saw here, if we don't get the precise area, we will introduce burn current everywhere but the vessel, so you increase the risk of perforation.
So do you actually grasp it and make sure that it doesn't bleed?
Absolutely.
And then you apply the
Needle.
coagulation current.
So the most important thing is grasp, then I flush to make sure that there's no bleeding, and if there's no bleeding, you cook. That's why the water jet scopes like this are very useful. Once you grasp the vessel, just a small spurt tells you that the bleeding is stopped, and then you coagulate it. And we always use forced coagulation, soft coagulation, because forced coagulation will cause problem.
What setting is there for forced coagulation for in airway?
So that's very different for different machines. We're using this ESG 300. This is a new Olympus product, which is a step up from ESG 100. In this, I use pulse cut for ESD for cutting, and for dissection of the tissue, they produce a new setting called power coagulation, which is very much like swift coagulation on an RB machine, which we set it up around 25. And then for hemostasis, we use soft coagulation on this machine is around 50 watts. On an RB, I use 80 watts. Needle out.
So for your marking also you use soft coag?
I use forced coagulation without getting my knife out.
Okay.
If I get the knife out, I would use soft coagulation, inject. I'm just trying to inject and see and reassure myself that that area that we are worried is still lifting. So I want you to have a look and tell me.
Is it gel fusion or?
Yeah, gel fusion.
Yeah, okay.
What do you think? I think there's a lift there.
I think there's some areolar tissue that you can see there that you can
needle out.
be able to. Of course, there is.
Inject. And stop. One more injection at the top and then needle out. Inject. And stop. So you've seen my exercise of flushing the water was very useful at night when we had the bleed.
Correct.
Because the blood was drooling away and we still had access to that vessel. That's very important, very small trick, but that can make a huge difference to your outcome of ESD.
So what do? You change positions otherwise?
Yeah.
So you do it in other positions.
Then I immediately know the blood will be drooling on me. I would have figured out before I started what will be the best position. Otherwise, when there's blood there everywhere, you can't see anything and you just do silly things then. Access is everything in this game. Knife out. I'll just try and do a bit more dissection.
Would you tell us something about this accessory that you're using?
Yeah, change to power coagulation.
Pradeep?
Yeah.
What is this accessory?
This is very important question. So power coagulation? Yeah. No, power coagulation for ESD. Yeah. So this is another Olympus's new invention. You've all seen dual knife before. This is called dual knife J. The beauty of this knife is they've slimmed it down. So this is very slim. So one of the big problems, we published a paper on ESD timings where we spend most of our time. 60% of the time during ESD is spent in non-cutting time.
Okay.
You only inflating and sucking. So normally with the dual knife, you'll have to take this knife out. I can keep this knife in and see I can still suck this fluid there.
Okay.
That makes ESD faster. So this is a huge advance in the ESD. I think this knife is going to make us a lot quicker. Otherwise, it's just an ordinary ESD knife. The dual knife was already there. Knife out, yeah. So now I'm going to use power coagulation, which is another new mode from Olympus. You see, it's very powerful. It's very much like the swift coagulation mode of
Can I
RB.
request Dr. S.P. Mishra to please chair the session?
And very soon we're going to change our cap to a 4mm cap so we can get access to this area much better. But you can see we are in the right plane.
Able to lift it. Yes.
Yeah.
And see how Pradeep is using the cap to sort of separate out the two layers.
And just keep watching for bleeding, oozing before it becomes a nuisance. So there's a little bit of ooze there. I think we might be able to control that with the knife. That's good, that's stopped. That type of oozing doesn't require the coagrasper. We can generally control that. So I think this area is becoming a bit tight, so I'm going to increase our incision now.
So what's your usual pattern that you use? You make a cut off about 20% of the...
Yeah, well, 25-30% on one side only, and try and do as much dissection as I can before we change over to the other side. This area is still oozing a little bit.
Dr. Bhatt, we'll just get back to you, sir.
Okay.
Dr. Bay?
Yes. So I already expand the tunnel on the both lateral side of well dissected. This is the center. So here you can see the very nice good edge of submucosal edge to be hooked. Yes. Now I can hook the IT knife to edge of exposed submucosa.
So first he has dissected both the lateral sides in the tunnel, and now he is injecting the central area.
Yes. So we can prove up.
He is applying a little traction to that thread which he has already there.
Yes.
Some big vessels are there.
Yeah, yeah.
You can see that artery which is spurting there.
So many vessels. I was so surprised. This is the edge. So, what's... Okay, coag grasper, please. Here you see the vessel.
We'll use the coag grasper here.
So, lumen of the esophagus is very, very narrow and small. So, working space is very small. So, it is very important to identify the vessel in detail like this. This is coag grasper. Okay, so here you can see the large vessel.
Yeah, you can see the vessel
yes,
which is spurting.
Center of the screen. Okay. Close. So flash again to make sure it's also breathing. Is that okay? Yes. Okay, that is good enough. So esophageal wall is good, very thin. So it is very important to lift up the device like this and coagulate the vessel in short time. Okay, open.
So there is no charring, and the transmitted current would not go to the muscle there.
Any comments from the audience?
Can
Any
you
queries?
coagulate that vessel also, which is the big vessel on the side of it?
Oh, clip is out.
This one?
Yes.
There's a big vessel there.
So may I... This is a clip. Clips out, so we can try again. Okay, once again, I'd like to show you the clip interaction.
We'll just get back to you, sir.
Yeah,
Okay,
you
okay.
can.
Dr. Nareshbhat, we are back to you, sir. And Dr. Pandey.
I think you can use some other room. We are changing scopes now, so you can move.
We only have you, sir.
We're not doing anything exciting. Anyway.
We can show you what we've achieved so far. As I said, one of the things with ESD is planning the whole, it's like planning a war strategy. What's your escape strategy? What's going to be your area where you get caught out? So that's why we did all this. And we knew this area is very invasive. Likely it would not lift. If you come to this area right towards the end of your procedure, then you spend 3 hours doing the easy bit. Then you come here, it doesn't lift, and then you go to abort. So that's why you have to think all these things through. And we decided this is the worst area. If this doesn't lift, we can't proceed. And we'll abort here. So that's what we did. We managed to get a good lift. We managed to dissect. See, the tissue is peeling off. It's very vascular, but it's progressing well. So my intention is to dissect a lot more, maybe up till here. If I can dissect this much lesion, I'll be a lot more confident that we'll be able to remove this lesion. Once I do that, then we'll go to the easy area. Now here the access is difficult in retroflexion, but I know that we can get to this lesion with a straight scope. See, so I can extend this with a straight scope, and this area can be approached. It's a little bit tricky, but we can be approached with a straight scope. So we can go this way. So we should be able to get this. And the gravity is also helping me. As we dissect more, that's the other thing to keep in mind. They use gravity to your advantage. Once I've dissected a little bit more, this flap will begin to open up. The planes will open up, or hopefully make my life a bit easier. But before you dissect too much, you'll have to cut here. Otherwise, the flap falls on this area, and then you don't have access to this area. So you have to keep all these things in your mind and not get carried away. So that's our plan. And now this scope, which is beautiful scope to assess, but sometimes it can be very rigid scope for getting access to difficult area. So we'll be changing from this HQ 290 to 190 to our ordinary 190 scope, which is slimmer and hopefully gives us a better access in retroflexion. So that's what we're planning to do. But before I do any changes or anything, another golden principle of ESD is
suck out all your mess all the time. Never leave any fluid, rubbish, blood, anything behind, because you just don't know when things will go wrong. When things go wrong, you don't want all this mess to add to your mess. So I want to remove this cloth.
In using the gravity, do you change the posture of the patient also?
Yes, we do change posture. In colon, that's very common because we do under sedation. When we're using GA, it's not that common. So we really change when it's essential, but we do change.
Do you also use clip and thread to pull the...
So in the meantime, we will shift our next slide and come back to you, sir.
Hello, do you use the clip and thread to pull the tumor for easy dissection?
That's a very good idea. Yes, we do use clip and thread, and maybe that we might end up using that technique here of using clip and thread to open up the planes. For that, you need a little bit more dissection to make the flap bigger. Otherwise, you end up pinning your flap to the muscle when you deploy the clip. So I'll dissect a little bit more, make the flap a little bit bigger, and then maybe we'll put a clip on it. Have you used that technique of using?
No, we've not, but I've seen the...
Yeah, so we might do that. That's a very useful technique.
Anybody in the management, we are getting endoscopic pictures from somewhere else and the endoscopy room pictures from somebody else.
Yes, sir.
So the audience is getting
No,
confused.
no, one second, sorry.
Okay,
We're just going to Dr. Abe.
Sure.
So yes, I apply that clip line traction again. Okay, injection. So now you see the submucosal layer very well. Once again. Okay. So needle back. ITNF, please. So I successfully entered the endoscope to the submucosa. This is the edge of submucosa. So IT knife is very, very good at the dissecting submucosa, both lateral side. Now the muscle direction is from 8 to 2 o'clock position. Okay, so here you see this is the edge will expose submucosa and dissect slowly. So esophageal lumen is very small, so it is very important to use a small wheel as well. I continue the submucosal dissection like this. This is the next edge. Okay, this is the edge. You see the lucent submucosa.
You always go to the edge and then come back in the center and then go ahead.
Yes, each other. Okay, so I'm going to pull back the line once again. Here you can see the edge of exposed submucosa. Okay, injection please. So now I already dissected the most of the submucosa layer like this. And it is a little difficult to identify the edge of submucosa this side. But I can do that. Okay, needle out, injection. This is muco up, well lift. Okay, injection once again. Very nice, very nice. Okay, stop. So let me try to enter this side. A little bit difficult. Okay. Once again. Okay, IT knife please.
Again to the audience, any questions, comments?
Yes, if there are any questions,
you can use the mic, please.
Definitely use the mic.
Just a small announcement. The mics that are in the hall, can only be heard within the hall and the question would have to be rephrased or answered by the chairperson.
Okay then, fine.
Sorry, I couldn't hear.
I'll encourage you all to come and to the mic and ask questions. Amsi?
Our working space is very small.
Yeah, it is a very small working space,
Okay,
and that is
so-
why we can see the reason which we are using the IT knife and not the
this
dual
is
knife here.
I successfully identify the edge. This is the edge.
So in the esophagus, I think you have to see these small areas which are a little blind in dissection.
Yeah, but the esophageal wall is very
Yeah.
straight, so it is quite safe.
Yeah, absolutely, it is quite safe.
Dr. Abe, we'll just get back to you.
Okay.
Yeah,
Thank
sure.
you. Okay, Dr. Bhandari, we are live with you.
Oh, okay. So what we've done is change the endoscope and we just injected. I've just noticed there's massive vessels here. Do you see that?
Yes. Yeah, yes, you can see that.
This big blood vessels.
Huge.
So this is going to cause more bleeding and problems. So I'm going to prophylactically coagulate this. So can I have the coagulus propeller? Can you change to soft coagulation? Because this vessel, if it opens up, it'll be really big bleed. It's already opened up
There are
once.
two vessels there.
Yes.
Big ones.
Now ideally we should have dissected a bit more of the submucosa around it to improve access to it. But my ESD skills are not as good as my Japanese colleagues. Open. Close, please. Open once more. Yeah, close. Open, yeah.
Dr. Bhandari, why did you open it again?
Open. I thought I had too much submucosa in there.
Okay.
I normally prefer using the colonic graspers. They have a smaller cup. They grasp less tissue. Makes me less nervous. This makes me very nervous. Yeah. Close.
There's a query.
Close. Yeah.
Can't hear you. The mic is on.
Open. Close.
Mahesh, check mics, please.
Open.
How we can make sure that it's completely coagulated?
Yeah, this will go all white. You shouldn't be able to see any red stuff in there.
Okay.
And sometimes I just use
Dr. Bhandari, there's a question. Why can't we put a laparoscope, a hybrid procedure, and use a harmonic scalpel?
I'm not a surgeon. It could be done. I thought the surgeons tell me, vapas injection. Surgeons tell me that access to this area high up is very challenging for a laparoscope and to do any resection because you're so close to cardia. You don't know where your staple will fire. But it is getting tricky now.
The audience is happy.
That's good. They can't see me sweating, so that's very good. Needle out. Inject.
We can conjecture that.
Stop. Needle out. Inject. Getting very tough here, getting the lift, which tells me there's a lot of fibrosis here.
Go ahead.
Stop. Needle out. And a big vessel there. Inject.
So you think it's a biopsy artifact?
Stop. Yeah.
Dr. Bhandari, there's a query from the audience that there's a depressed area. Is that a biopsy artifact?
Well, we've seen all that. You see, you can see this was the depressed area where we worried, but the pattern is very healthy. It's this.
This area.
Yeah, all this is invasive pattern on the vessels. So it is concerning.
Was a biopsy taken from here?
We don't know where the biopsy was taken, but it's a very big area. Can't be just biopsy. You see the demarcation line there? Biopsy doesn't produce demarcation line like that.
No, was a biopsy taken, and if it was taken, was the histopath?
Oh, there is a biopsy taken.
And was the histopathology?
Adenoma. You see the demarcation line? So biopsy will never produce this demarcation line. So this is not biopsy artifact. This is the invasive nature of it. There.
And how confident are you that you won't be missing something deep?
I'm very confident that this is deep. Because we said this patient has got portal hypertension and the consequences of total gastrectomy is very high here. So that's why we're trying our best to see if we can peel it off.
But the consequence of ESD also, the bleed is very high.
It is, yeah. But the surgeons tell me, that they face a bigger challenge than what we face down the endoscope. I don't know, I'm not a surgeon, but I just believe them.
So the basic question is it worth doing it?
Open. It's worth doing it if you can manage to resect. It comes out to be SM2. There's still only about 8 to 10% chance of lymph node metastasis. So there's still a 90% chance of no lymph node metastasis. Otherwise, you're not offering any option to this guy.
And did we have an endoscopic ultrasound on this guy?
No. Soft से वापस power coagulation. Just keep an eye, man. जैसे ही मैं hemostasis बंद करता हूँ, you change it, yeah. Open. Another thing to remember, ESD is a team game. It's not about you. If you haven't trained your nurses properly, then your outcome will be very poor. Open. And when we come to events like this, it's not easy because you don't have your usual nurse with you. So you have to rely on people.
You're very close to the tethered area. This is a deep area, I believe.
Yeah. So IT knife allows you to do some blind dissection. You saw there. I had no access to that area. I'm just controlling the way my scope is moving, which should be away from the muscle.
Can we focus the hands of Dr. Bhandari, please? That's more important than the image. So just see the technique. Again, he's
knife out.
That's better, much better now. Just focus his hands. That's much better. Thank you.
Knife out.
In presence of portal hypertension, whether ESD is more safe or open surgery is more safe?
Answer that.
So this is getting more and more tricky now. So here we have to do more and more injection as you lose your planes. You want a lot more buffer.
And when will you call it a day?
When do I call it a day? When you lose your plane and you can't differentiate muscle from submucosa.
Okay.
I don't think you can then resect safely. So then you have two options, which a lot of people are doing, is go for full thickness excision. Needle, knife out.
Laparoscopic?
Or laparoscopic, yeah. I'll have to call Amol. Being a surgeon, he'll know exactly what the challenge of laparoscopic is.
So that's the message for the audience. You don't have to be you can be brave but not foolish.
See, this is looking a bit messy here with not much of a lift. So I'm going to inject again.
This is the tethered area basically.
Yeah.
You can see. And had you preferred endoscopic ultrasound on this patient?
No, I honestly don't believe the endoscopic ultrasound will give you the differentiation between SM1 and SM2 and SM3.
But
I don't think this is...
You could have got lymph nodes and sampled them.
Yeah, lymph node, of course, yeah, if you're worried about that. I don't think this is something you would worry too much about lymph nodes. This is a local challenge.
But if it is invasive and the lymph nodes are involved, what are we getting from here?
Well, then it's a different game. But so far, their imaging hasn't shown any lymph nodes.
Okay.
One other thing I wanted to make a point is, when you want to use clip and line, you need roughly this much of a margin. Do you see the lesion is there and you have all this normal mucosa. So your clip goes into this normal mucosa, not into the lesion. So that will be very helpful when we change over to that technique. Let me see what happens now.
We need to show his hands basically. We have gone to the other room, endoscopic image. That's better.
Needle up.
Can you blow up the endoscopy? Yeah, that's better.
So I'm just using the needle to inject, and as you inject, you always pull the needle back to allow for the elevation to come up and stop. Thank you.
You said you were sweating. I don't see a drop of sweat on you.
That's my mind which is sweating at the moment. Physically, I'll start sweating a little bit later.
How about combining ESD with EMR at this particular stage?
This is very, very tough.
This is tough. No elevation at all. And you're not able to penetrate basically.
Inject.
So we also have the next room ready.
Sure.
Okay.
So we'll just get back to you, sir.
No problem.
Thank you.
By the time he injects over time. Good. Thank
you. A 59-year-old gentleman, a known case of NASH-related cirrhosis, had pain in abdomen. Gastroscopy showed gastric antral ulcer and ulcerated duodenal submucosal tumor. The EUS showed 2 by 2 centimeter lesion arising from the muscularis propria layer. Plan is to demonstrate the NBI features of the ulcer and duodenal lesion. Over to sir.
Dr. Nilay and Dr. Bhatt, you're on.
Hi.
Hi Nilay. Hi Nilay.
What we are seeing right now is a bit of stomach. I'll just show you some aspects of evaluation of stomach here.
Yeah, you want NBI? What do you want? Oh, it's high.
So Naresh, you're using air, not carbon dioxide.
So what's the technique normally of NBI is you can put on the air filters.
Yeah.
No, they want to know if you're using air or carbon dioxide.
Yeah. What do they want to know?
No,
air or carbon dioxide.
See, routine endoscopy we use air, we're quite happy. Only when the procedure is prolonged, are we likely to move to carbon dioxide if you're doing a therapeutic endoscopy. Now here, I have tried to focus on part of the body, and what you can see is these little bumpy localized areas which we call sulci formation, and you can appreciate that the pits are dilated. And if you remember what I told you in the morning, the collecting venues or those dark starfish-like structures are missing. So what you can make out here, that this patient has got chronic gastritis and possibly it is HP positive. So we have a background of H. pylori gastritis. Okay, now we move further. And here on right line itself you can make out that there is a kind of elevated lesion here just short of the pyloric opening. Also give some Buscopan. Give some Buscopan, please. Here you can make out that definitely something, and you can make out that there is a fairly deep ulcer here.
So what is your impression on white light endoscopy, Dr. Bhatt?
See, at white light endoscopy, this area is definitely either very edematous or there is an infiltrating lesion there. So both of them could look very similar. So what I'm going to try and do is see if there are any features of malignancy, at least in the surrounding thing is HB positive. So let's see if the surrounding mucosa.
There's an ulcer there.
Yeah, there's a deep ulcer, no doubt about it. So what you're seeing is features of what I call the jalebi formation. This is the MC, the medial crypt epithelium is dilated but they're regular.
Okay.
They're not irregular.
And this is like enteral mucosa only.
There's an announcement.
Except for some dilation.
We won't have a formal lunch break. Lunch is on from 12 to 2. Those who want to have lunch can go and bring their lunch boxes here or have lunch and come back. So it will be over by 2.
Fairly regular looking areas here. So we are not finding anything sinister. But as I said, if it is subepithelial and is ulcerated, you could misinterpret it and say it's benign. So when you have a lesion like this, it is imperative that you biopsy. You can't take a decision based on NBI alone. What do you think, Nilay?
Yeah, I agree with you. Like the main lesion is submucosal. So whatever the mucosa is showing some inflammation, that's it, nothing else on NBI.
And there's an ulcer too.
Yeah, there's a deep ulcer. Now the question is this ulcer neoplastic or can NBI help you tell you whether it's malignant? But what we are seeing is basically only features, no clear features of malignancy, but it could be a subepithelial malignancy like lymphoma, which you cannot exclude of this.
The screen
here on the duodenum.
The screen on the right side, we can freeze the image. So in case you have any questions, we can convey it to the operating room.
Naresh, what is this?
This is a lesion there in the duodenum, just beyond the pylorus post-bulbar, with a little
depression
and ulceration there actually.
Yes.
So basically, do you really need NBI in this kind of lesion? Where it's in duodenum, it's elevated lesion with a central ulcer or pitting?
Really no, I don't think it makes a big deal of difference. It doesn't help too much. You can make out whether it's epithelial or subepithelial. That much you can make out. I just put the NBI and show you. See, if you look, there is no line of demarcation. That tells me that perhaps this is not epithelial lesion, it's possibly subepithelial lesion. This may well be another a lymphoma or a cyst.
Even the pit pot patterns
or
are
a carcinoid.
This
looks.
The pit pattern
Yes,
is
here a
regular.
carcinoid could look much the same. But since I'm seeing another lesion there,
But both could be carcinoid.
yes, it could both be carcinoid.
Nile,
Though the one in the stomach looks
to
a
diagnose
little.
the carcinoid, the endoscopic ultrasound will be helpful then.
Yes, a carcinoid would not differentiate between endoscopic ultrasound would not be differentiating carcinoid versus gist. Carcinoid can occur in second layer, in third layer, so it would not differentiate actually.
Most of the endocrine tumors are bright.
Endocrine tumors?
Are bright on endoscopic ultrasound.
On EUS, I can't get you. Like what is saying?
They are bright.
Most neuroendocrine tumors are bright.
Hyperechoic.
Carcinoid can be hypoechoic. Yeah.
It is only more hypervascular. Most of the time it is
Patient had
Yeah.
bleeding.
Amol, we can only hear faint voice of yours.
Yes, sir, we'll just give Dr. Amol a mic. No, sir, you hold on, Dr. Nilay.
So, actually what this case demonstrates the limitations of NBI. When you have ulceration, you can't depend too much of NBI to give you an answer. For a subepithelial lesion like this, again NBI doesn't give an answer. NBI is good for epithelial lesions, preferably more for flat lesions where it's more informative. So this possibly may be any of the ones that we thought, maybe a cyst, maybe a neuroendocrine tumor, maybe even a lymphoma.
Yeah, but two lymphoma usually one lymphoma in stomach, the other lymphoma in duodenum. Of course it can occur, but
but it's more likely to be multicentric than thick.
So what does the gastric lesion look like?
To me, the gastric lesion perhaps still may be a benign gastric ulcer with a lot of edema, or maybe an infiltrative thing, maybe a lymphomatous infiltrate with an ulcer. Those are the two things.
Amol is with us. Amol, did you do EUS of that gastric lesion? What is it showing?
Yeah, it actually shows only mucosal thickening.
Okay.
It doesn't show any invasion into the mucosa.
No, can it just be because of portal hypertension?
Yeah, possibly. Dr. Mishra, to answer your question about the neuroendocrine.
Amol, I'll request you to use the mic, please.
Yeah, I am using the mic.
Okay, now you're.
Yes, sir, now you're on.
Yeah. Okay. So to answer your question about the neuroendocrine lesions, EOS, most lesions would be hypervascular on Doppler, but otherwise the appearance can be hyper or hypo both. In fact, if it's cystic, you can even have an anechoic lesion. So neuroendocrine tumors can be very deceptive on EOS.
Yeah, neuroendocrine tumors can have cystic degeneration. But neuroendocrine of the intestine and neuroendocrine of the pancreas, let us not club them together as far as EUS is concerned. Because when you are saying hyperechoic, they are more into pancreas. If we see carcinoid, most of the times what we see is hypoechoic, not hyperechoic.
Yeah, that is.
So the only way out is to do a biopsy.
Yes.
Another case of a duodenal neuroendocrine tumor, actually a carcinoid, just coming up next probably in one of the rooms. So that time we'll continue the discussion about the neuroendocrine tumors. And I think we can move to Dr. Saichiro Abe. Saichiro
Right,
room.
sir.
Yeah.
Let's go there, sir.
Yeah.
Amol?
Sir, we actually moved off. You want Dr. Amol 1 second, sir. Dr. Amol, they want you.
Yeah.
There are so many cases running simultaneously, the audience will get confused.
See, sir, that's the reason you are there, to reduce the confusion and make sure that the discussion goes the right way.
So the picture in picture you are saying is Dr. Bhandari.
Yes, sir.
Yeah,
And
picture in
the main
Bhandari.
picture you are saying Dr. Sachiro.
Yes, sir.
Yeah.
And Dr. Sajiro, you're on.
Okay, so I'm now continuing the submucosal dissection. Here you can see the mostly done, but the working space is still very, very small.
You have to just check it from here.
Yes. Now we can go ahead to the distal side. Or maybe I made a tunnel distal side. So let me make sure it is where is the tunnel. So
I think this is all dissected.
I think so.
Only this part has to be.
Just only this part.
But this.
Yes, this is probably the last final touch. Okay.
Yeah. I think that is through.
So please, thank you so much. Successfully continue the circumferential dissection.
Congratulations.
Thank you so much.
Hiro-san?
Yes?
Arigato gozaimasu.
ありがとうございました。Thank you. Ah, ちょっと作っておこうかね。Okay. Okay, it's okay.
Just put it with that.
Put it back. Oh, still, sorry. Yeah, that's true. Where's the remaining one? Sorry, very, very small tissue still remain, maybe. Oh, yes. Sorry.
Still stuck up there.
Still stuck.
Just to remind you that the picture in picture is Dr. Bhandari's case. Stomach, and this is the esophagus. Main frame. हंसने की बात नहीं, it's just like राम and श्याम, कौन सा क्या है समझ नहीं आता.
Okay.
Okay, now you're done.
Thank you so much. So after resection, the discussion point is how to prevent the stricture. In Japan, as I told you, steroid treatment is a standard. Oral medication and local triamcinolone injection. And then in the West and India, stent replacement is one option.
Just pull the thread.
So far, there are little evidence which is the best method to prevent the stricture. So, of course, further prospective study is warranted to establish the standard. Okay. Anyway, I'm going to remove
just to remind the audience that lunch is on.
Saichiro,
yes,
to prevent stricture formation, would you want to inject some steroid?
He is injecting. Already
okay, this is a syringe shaped specimen.
Can you focus the tumor? Yes.
Yeah, syringe shaped specimen.
And we will mount it on a syringe.
Yes. Thank you.
Couple of things that can be done to prevent stricture formation or at least minimize.
Yes.
One is injection of steroid and stent placement, placing a removable stent fully covered and also work.
Yes. So
place it for about 4 weeks.
Yes, as you can see, complete circumferential ESD was successfully done.
A big round of applause for Dr. Saichiro, please.
Yes.
Total long segment.
Yes, about from 30, 22.
8 centimeters long. Wow.
Yes. So just do 8 more centimeters and the entire esophagus is off.
Right. Okay, Dr. Pankaji, please prevent the stricture after that. Thank you.
Yeah, so we are going to inject
okay.
triamcinolone.
Okay,
maybe you do a hemostasis
And
first.
Pankaj?
Yes, sir.
How many quadrants do you inject the triamcinolone?
He will inject at how many centimeters? 2 centimeters?
About 2 centimeters, yes.
No, circumferentially.
Circumferentially, at least every 2 centimeters in all the quadrants.
Quadral spot, hemostasis? Yes. A small vessel still remains before injection triamcinolone, so maybe do hemostasis.
And do you repeat the injection?
Yes.
After how many days? That's an obvious next question.
How many days do you repeat the injection?
Yes, so there is no standard, but this is a very large region, so I'm going to inject a total 100 milligram on triamcinolone. Okay, open.
Yeah. Okay, you can shift to the other room. Excellent, Dr. Saichiro.
Pankaj, we didn't get an answer.
Yes.
How many days? Repeat.
How many days you are going to repeat the triamcinolone injection?
Yeah, that really depends on the institution and policy.
What would you
in Japan,
do?
the one-time injection is standard, but sometimes some institutions inject 2 times, 3 times. There is no standard.
And after how many days do they repeat?
Usually, I think what we would do is go in and see after 3 weeks, not before that.
Right. Thank you, Dr. Abhay and Dr. Pankaj.
Yeah. Okay.
Thank you, sir.
Thank
we
you.
are moving to Dr. Bhandari. And now Dr. Rajesh has joined up. You're on.
Okay. So I was struggling a lot because of fibrosis. I couldn't get the planes, and there are a lot of vessels, and they start bleeding. So you don't want bleeding with poor access. So what we want to do is improve our access to see if we can get good planes before we decide whether we're going to proceed or not. So we're using this clip and line technique. I think you've already seen it.
Yes.
You put the clip in through the scope, very important first. Once the clip is out, open the jaw, tie the dental floss to it, and now we close the clip, pull it back in, and now I'll intubate the patient. It's very useful technique. I think it's CO2 band ho gaya. It's very good technique for people like me whose ESD skills are not as good as our Japanese colleagues. It does improve our access. It makes ESD a bit faster and safer. And it's quite cheap. Olympus has developed a device called Endolifter, which is more or less on similar principles, but it's a very cumbersome device, I'm sorry to say. The challenge is that if you have to deploy it in retroflexion, opening the clip, deploying all those things can become very challenging. I'll try and see what access we get.
Go to the antrum, push it out, and then retroflex, and then deploy it.
Yeah, no, we will push it out there, but I just want to see whether we will be able to do it this way. If I have access, yeah, looks like we should be able to get it.
We'll be able to do it, yeah, you can see it very well.
So, first, I just want to clear the mess.
The part of the floss is below it.
So, थोड़ा वो धागा को पीछे खींचना थोड़ा. Just pull it back a little bit.
Pull the floss.
Yeah. Pull it back tiny bit. वो screen को देके, yeah. Good. Okay. That's good. So I'll use this flap here, making sure I don't clip the muscle with it, because that will be a disaster. There. That's the flap I want. So open, please.
Very nice.
Can you rotate it? I want it like that. Yeah. That's good. Yeah. एक twist वापस करो और opposite direction में. Otherwise this will just flip.
घुमाना है इसको.
उधर opposite direction. Opposite. Oh, okay. Carry on. Okay.
Got the other flag.
Okay, stay there.
So your thread should be on the upper side?
Oh, it doesn't matter. Okay, start close slowly.
Got it, perfect.
Okay, now I want to make sure I haven't got a muscle. No, it doesn't look like I have muscle. So we'll deploy the clip now. Close, please. Deploy. Pura. Be careful. Don't pull. Just push the yellow forward. Karo thoda. Yellow. Yeah.
Sheet ढकेलना है.
धीरे. Very slow movement. So yellow को वापस पीछे करो, आगे करो. Yeah, that's it. Thank you.
Done.
See, there we go. You have to be very, very careful here. If you just pull it back, you'll just rip it off. So now, our assistant should pull this thread.
Can you focus the hands, please?
Can you
blow up the bend? That's better. Thank you.
Pull थोड़ा सा, धीरे. So this shows the severe fibrosis that we were facing. Here, you can see the planes are really terrible. Dhire, it's come off. That's it. No, that's very gentle. See, you see what can happen. If you just little bit forceful, the tissues are very friable and it can come off. So the clip has come off. It's ripped through here, which is very annoying, but that does happen during this game. So we'll have to put another clip here and pull, but to me it looks like very bad access there. This is where we're struggling to open up access. So either we go sort of full thickness, and I'll ask Amol if he's happy for that. Because the planes are not opening up at all here. Yeah, I think there must have been an ulceration here to start with. So it could be just fibrosis because of that. But for us, it doesn't really matter what it is. If there's no plane, we are risking perforation. So needle, injection killing. So it's ESD is such a team game. Understanding each other is so important. My assistant here is fantastic. He's technically very, very clever. Without telling him, he's doing most of the things. But it's just that I have never worked with him. So our coordination is not as good as what it would be when you work with your own nurse. And this is something we just have to develop. Issue is beginning to sort of fall apart. We should invite our Japanese colleagues to come and cut through this fibrosis needle out.
Rajesh?
Yes, sir.
Inject.
You're also very comfortable with your own nurse?
Yeah, I'm comfortable. Dr. Pradeep, do you think should we do a little bit more deeper dissection because still the muscle layer is not visible?
Yeah. No,
we are still in the submucosa. If we go a little bit more in the deeper side, it might going to help. We can cut off this.
I agree. Needle out.
This is a vessel.
Yeah, inject that.
Yes. If we can separate, it might shrink more and can give us the space to work on.
Yeah. The issue is the access to it.
The tissue is tethered over there. It's going deep.
This is the submucosa.
Yeah, needle out.
It's not lifting basically.
Yeah. So this area is okay. See, you got the lift here. When we go up there.
Just to 2 o'clock, 12 o'clock. It's very difficult.
I get the dual knife again.
Is that the concept that you should remove from the periphery so it can shrink towards the center?
Yeah.
So rather than dissecting in the superficial plane, if you dissect deep into the submucosa at the periphery, the tumor area will shrink and it will give a better space to work on it.
Yeah, I agree. There. So it's just that when you twist your scope, you are now going towards the muscle, and that's what makes you worry. But we can do very gentle dissection at the periphery and try and release the tension from the sides.
Anyone in the audience has any different ideas?
But my feeling is I joined quite late, but when I was in the hall towards Dr. S.P. Mishra, my feeling it is not possible to remove endoscopically because
that's
it is a central depression.
Dr. Kulkarni and myself were deliberating on that.
I know. We did say right at the start, but I'm sure there's a surgeon who will be happy to operate and take the risk of the portal hypertension. Are there surgeons in the audience who can explain the challenges of operating with portal hypertension?
All the surgeons have gone for lunch.
So the surgical risk will depend upon the child status.
Okay, but in technical challenge in terms of vascular network all around here, that's what will be the technical challenge for them. Outcome, I agree, will depend on the child status. But the surgeons say technically it's very challenging. The surgeons know what to prioritize. It's lunchtime, lunch comes first. Patient with portal hypertension, they don't want to mess around, so they give it to an endoscopist.
So we have another master in the room and we will hand over the mic to him.
Yes.
He can give his comment.
Can we have the endoscopic room image please? PIP of endoscopy room image. This is the tissue removed by Dr. Sujay.
Okay, let's get a second opinion from our Japanese expert.
Did they already finish the circumferential mucosa issue?
No.
Okay, so you should complete the circumferential.
So if I show you the lesion first,
yes,
you tell us.
Yeah, because unless you can complete the circumferential mucosa incision, you cannot see the end point. So hopefully.
So what we were discussing is that is this a deep invasive lesion?
Yeah.
Or is this, so on this side it looks good.
Yes.
This is all good.
Yes.
When we come here,
Right.
CO2 check करना?
Also, did you apply the creep prime fraction?
Here.
Did you use?
So do you see this?
Where is the creep? Detached. Okay.
Ah.
So hopefully, could you please try it again?
Yeah, we could. So do you see? So we got the normal margin here.
Yeah.
And this is the area
Yes.
which we worried about. What do you think about this?
In this case, I think so it is very important to decide the endpoint, define the endpoint. So that you should do a circumferential mucosal incision at first.
But you think this will lift and come off? Or you don't? You will not know till we do circumferential incision?
Of course, I know.
I understood circumferential.
Yes.
You prevent the migration of this fluid.
Yeah.
Or it is going to help to decide on endoscopically that by doing the or not. The main advantage is you prevent the dispersion of the surrounding.
But once if you can use a creep prime fraction.
Yes. Then you require.
Yeah. So I believe the submucosal layer will visualize.
Okay.
PI morphology reason is possible to remove.
Dr. Bandari, we'll just get back to you, sir. We have the next room ready.
Okay.
Thank you. Case history on.
This is a 40-year female. A 40-year female with the GERD symptoms and intermittent difficulty in swallowing since 1 year. The UGScopy showed a submucosal tumor at G junction, and US showed 1.7 by 1.7 centimeter hypoechoic lesion arising from the MP layer at G junction. The plan is to go advance for STIR. Over to ma'am.
What is the diagnosis? Working diagnosis?
The working diagnosis is
Submucosal
leiomyoma.
Yeah, Dr. Amrita, you're on, ma'am.
Hi.
Hello.
I wanted to say that thank you to the directors of this course. It's really a privilege for me to be here. This is actually my first time in India in a professional capacity. So I practice this. I'm just going to try. मैं बहुत धन्यवाद है पर अमोल की मैं बुलाया है.
Thank you so much, Amrita.
That was like the most nervous part of the entire thing.
Amrita is a second generation American Indian. She was born and brought up in the US. She can hear the Hindi with the American accent.
So that took a lot of practice for me. But
हिंदी में अमोल अमूल्य है.
Yes, sir.
अमोल अमूल्य है.
Thank you very much, sir.
So we're going to be doing a STIR today. Here's the lesion. I'm just going to insufflate a little bit so we can see. And I'll show you in a forward viewing where the location is. It's just below the GE junction. From here, forward view. The GE junction is at about 35 centimeters, and it's just below.
Yeah, you can just see it peeping out from that area. So that's how it's looking. Yeah, so just across the G junction. It starts at the G junction and goes across, I believe.
And it dips down. So what we'll do is we'll take the two approaches, and we'll talk about it a little in the lecture, is to do either a full thickness resection and then close, or to do a non-exposed full thickness resection or a tunneling procedure like the STIR. And this is a perfect case for that because surgically this would require, it's a very difficult area to get to. The surgeons would normally do like a wedge resection, but this high up at the GE junction would practically require a total gastrectomy. And so the tunneling procedure is nice. We just will make a 5 centimeter tunnel and then excavate the lesion and then just close the tunnel up, much like we saw in the poem earlier today, and we'll see later again. So I think we'll come. So one of the things we're trying to figure out is which orientation to keep the scope. I like doing my poems, for example, in a posterior position. And so I'm going to try to turn the scope so that I can
Can you please focus the hands?
Do that.
Yeah, so the difference between a poem and a STIR is sometimes if the lesion is located anteriorly or in the lateral direction, then the tunnel also needs to be in that direction, because otherwise you're going to miss the lesion.
So you agree that this is a lesion here? So I'm going to try to keep this orientation.
Yeah.
Right.
Sometimes what I do, Amrita, is we would inject in retroflexion and bring the lesion in view from the esophagus.
But how do you stabilize the scope then? It will derotate.
So
you just rotate the scope and then.
Take the needle.
No, but it will come back again once you move the hands. So you have to fix your hands basically.
Yeah, basically turn your body around so that, like, you take a little bit of an ERCP position.
You can see her hands over there.
Yeah.
That's not a normal routine procedure we do. That's just to keep the lesion in.
So right now I'm just going to go in and inject distally. The other way to keep your orientation and the stability of the scope during the procedure is just maintaining your orientation with regards to the muscle. For example, in a poem, the way that you always keep the muscle in view if it's posterior, below you, and the mucosa above. So I am finding a little out.
So the tumor is in the cardia basically.
Yeah, it's very high up here. Just going to come to the base of it, and we're going to inject a little bit. Inject. Inject. Needle's out, right? Okay.
Yeah.
Up.
On the lesion.
I'm going to inject on the lesion.
Yeah, that's. The idea is just to try and get some staining on the esophageal side so that you can maintain your direction. So.
I'm going to first inject just at the base here so we can. Okay.
So the injections are being made on the stomach side.
The injections are made on the distal side. So now you want to go a little bit sustain the esophageal side. Let me just see what it looks like.
But why did you do that?
You're not seeing the lesion very well from the esophageal side.
Okay,
so sometimes if you inject, you'll get a little bit of a bulge and also some staining so that you'll get a better visualization over there.
So we'll just go and inject right on to see if we can reach up there though. I am having a hard time.
The problem is a bit of bleed will mess up.
Almost do like when we come up into the esophagus, but do it from afar. Here, how about that? That works better. Feel out. Let's see if we can see that a little bit better.
Just a faint bit.
Yeah, just a faint. I'd like to actually get the other side too.
Can we inject on the esophageal side where you are seeing the tumor so that you can know where to go? Injecting over here, just above the tumor.
Top of here.
Yep.
Yeah. Very tangential. See if that worked. I mean, I think we can inject a little bit more on this side so that bleb comes up.
The other side?
Well, the side where we successfully injected. Yeah, how about right here? How about right here? Lots to get to. Very distal injection. Try there, inject there.
Just on top of the tumor.
Yeah,
just on top of the lesion. Yeah.
Just trying to see if it helps us visualize it from the esophageal side. Okay, how much is that?
Check a little bit more.
A little bit more than.
I think you're in a good position.
Now you can see the tumor a bit. It's bulged a bit.
Yeah.
What this also does sometimes is it will help to separate the lesion from the mucosa. So when you're going around the lesion,
Would have separated.
minimizes the risk of your.
Expands our tunnel a little bit.
I think that's pretty much okay now.
Yeah, okay.
I think you should inject here now.
You want us to inject right here?
Yep. So that you can see from the esophagus.
Okay. I think we're actually just going to start the tunnel.
Okay.
That's okay.
This is going to.
How far?
A little bit on the left.
So how many centimeters proximal will you start the tunnel?
I'm going to start, I want the tunnel to actually be about 5 centimeters proximal. So I'll start the actual incision at about 8 to hope for about a 3 centimeter mucosal incision in order to get the scope in.
Amol, what do you prefer, Amol?
Yeah, about a 5 to 6 centimeter tunnel is what you need.
And how much
the difference is that for a stir, you also need to understand that the lesion you need to deliver from through the mucosal incision.
So it has to be big.
Yeah, so the mucosal incision has to be longer as compared to the poem.
So you how many? You prefer 10, 12 centimeters?
No, that depends on. See, you need a 5 centimeter of a tunnel, and then add to that the size of the lesion. That's how it is. You have
here 8 centimeters should be fine then.
No, I agree. I mean, 5 centimeters is the minimum, and a lot of experts actually are advising to do an horizontal opening because, as Amol was saying, you need to deliver the lesion. So here, the purpose is not to create a tunnel for myotomy, but to deliver. So a lot of people recommend actually a horizontal opening.
Yeah. The other way to do it is you can do a mucosal incision like you do in a poem, go in, get the lesion out, and then when you pull it out, you can extend the mucosal incision a little bit more to, just to make sure that you can deliver it out. So that way you're not cutting more than what is needed.
Yes, not only that, but you're going for a deep tunnel then, long tunnel.
Yeah.
Yeah. So I missed your comment about the incision, whether you normally do the horizontal or the longitudinal.
I prefer to do the longitudinal incision. What about you?
I do the longitudinal still because of the closure more than anything else. So, but I think it's also important to remember that the tunnel has to be a little bit wider than you would normally do for a poem because you've got to keep the thing out. So we're here at about 28 centimeters at G junction, or the tumor is at about 35. So I've come up to about 27 or so there. And now we're going to use the TTJ knife. This is the Olympus knife. Yeah. So I'm going to first try it out. Can I have the injection pedal?
The first injection you'll probably need to use a...
No. Yeah. This is a TTJ.
No, the first injection with the TTJ, you'll need to use a needle.
Oh,
Once you get in, then you can use the TTJ.
Okay.
Yeah.
So this is the first time I'm using this knife, which is why I'm a little unfamiliar with that. But even for poems, I do inject first with a regular needle. So.
Yeah, because the first mucosal incision injection is always tough, even sometimes with the Irby knife, especially if the mucosa is thick.
If it's thick mucosa, it's very difficult. So we will just inject here first.
So back home you use a regular needle.
Back home, I use a regular needle for the first injection, and then I use the Irby T-type, for example, for a tunneling procedure.
So now you're using a regular needle here?
Yes, this is a regular needle inject.
So we made you feel at home?
I feel at home, that's right. Okay, so it's a nice lift. I feel confident with that cushion. How much is that? 10. Okay, stop, needle in. And now I'll take the knife. So this is the TTJ, like I said, it's the triangle tip. We don't have this available to us in the US yet, so it's a little bit of a treat. But it's essentially the jet version of the regular triangle tip knife. And just like the poem that you saw earlier, the key part will be making the incision and getting into the tunnel. So now can I have the injection pedal? This is now I can inject.
With the hand.
Oh, I see. Okay. All right. I understand. Okay, so I'm going to, just like a poem, I'm going to cut. I want to make sure with my first cut that I've gotten deep enough so I'm not fighting myself with the mucosa side. I think we're knife out. I'm changing the scope angle a little bit.
Can we have only one image, please? We are getting two images from different endoscopy suites, and they are very similar.
The other one?
Finally, it's endoscopy both sides, sir. So they have to be similar.
No, but they're really exactly similar, so everybody will get confused.
No.
Dr. Bhandari and Amrita.
Yeah, Pradeep is on his job with that ESD. It's a very tricky location.
So now you're using a tri knife.
Yeah, this is the triangle tip knife. And I just want to make a long enough incision so I can comfortably get the scope in.
So Amrita, what's the solution you're using? Methylene blue with what? Glycerol?
Saline.
Saline. You don't add glycerol to it?
So for tunneling procedures, I typically just use saline. Because I don't think we need the lift for that long, so. Keep the knife out. Just a little bit longer here. It's interesting to use this.
Can we have the endoscopy room image with Amol and Amrita?
Yes, sir, sure.
And we just don't need the PIP because both procedures are looking similar. No, now we are getting PIP from, I know, but we could decipher, but for the audience.
Okay. And again,
can you show her hands, please? Blow up. See the hand movements. This is important. And
just trying to see if I can edge my way a little bit in. And similar to what Michelle was showing earlier, even when I do posterior, sometimes I orient the scope in an anterior position in the beginning. Knife out, please.
Yeah, getting in is a little bit easier if you turn the scope around.
Easier with what, Amol?
After turning the scope around. So
okay,
you just
sure.
turn the scope around.
I know.
So getting into the tunnel, initially I'll keep the
now,
scope.
Amrita, just show us for the audience who are doing for the first time where the mucosa is and where the submucosa
sure.
is.
So
once you're in the tunnel.
Okay, Amrita, just since you're using this knife for the first time, whenever you need to inject, he needs to pull the knife back and you need to push the catheter against the tissue and then it will inject and it will elevate better.
Okay, inject here. Show me. Okay, perfect. Great, that's fine. Thank you. And knife out now. So we're going to just cut away. And again, this is a little, no, keep the knife out, please.
Can we move to the next room by the time she's doing the tunneling?
Yeah. So just to finish what we were saying, I'm going to do the initial dissection here, anterior, enter the tunnel, and then turn my orientation around a little bit, like to bring myself into the more posterior position. See, like this. So I'm in the tunnel. I'm actually turning the scope and bringing my mucosa to the anterior side. So it's a little bit of easier way to get into the tunnel.
So that's the danger area anteriorly.
What's that?
That's the danger area anteriorly. Don't go there.
Okay. Okay. So if you want, you can come back to us whenever, and we'll hopefully be a little bit further in this tunnel.
Can we move to the next room, please?
Yes, sir.
Thank you.
But there is a mic on.
What we've done so far. So if you inflate, but there's no inflation.
So the images are again from the room. Yeah, now we are there. So
are you back with us?
Yes.
So we're doing a true hybrid of West and East. I passed the endoscope to our Japanese experts to do the oral side of the lesion, where the access was very difficult. So Ichiro is just almost finished the oral side. Do you see that? So I started doing that, and I started struggling towards the end of it. So he's just taken over, and you can see there's almost a circumferential incision.
Yeah, we can see it.
It's complete now. So we're just going to extend the dissection a little bit more.
Yes, from the...
I would have loved to see how he did it, because going posteriorly was very difficult.
Yeah,
on the other side.
So we did it with the straight scope rather than retroflex.
Okay.
Is the patient okay?
Okay. Yes, this is a bouncing. So this patient has frequent bouncing, so we cannot insufflate.
One of the problems we're facing is the insufflation is poor. So I'm pressing on the trachea to put pressure on the esophagus to close the esophagus down, so that we can get some decent views. So in this setting, generally you put an overtube. So hopefully we'll get an overtube soon. And we'll put an overtube which will...
Dr. Bhandari, we didn't get you. You're pressing on the trachea for?
I'm just pressing on his neck to compress the esophagus, to hold the air. Because as soon as I take my hand off, the air leaks and we don't have any views and access. So what we're planning to do is put a short overtube, and hopefully that will retain some air. Do you see the views now? As soon as I take my hand off, these views will disappear completely, because he brings all the air out. This is where we had a lot of vessels that are coagulated already.
Okay.
No, the problem is the tethering over there, not the vessels.
Yeah.
It appears that it's attached to deeper tissue.
Okay, so I'm going to dissect the submucosa using the IT knife.
Yeah.
Again, those who have not had lunch, please go for lunch. We'll close by 2 o'clock. We have special arrangements for ourselves.
That's why.
Yeah.
Okay, nice. IT knife, okay.
So you'll see now the IT knife requires completely different skill from a needle type knife, which is a dual knife, flush knife. So with IT you hook it in, and then it rotates in the plane away from the muscle.
Now is on your throat, so increase to the 35.
35. Coagulation को बढ़ा दो.
Out.
Is that good?
Yes.
Or do you want it higher? You see, so IT allows us to do sort of not blind dissection, we know exactly where we're going, but without seeing. So he's cutting the fibrosis along with those vessels. Oh, इससे छोटा नहीं? But maybe we'll use this. If the scope, no.
Okay, so and also now we are using the endoscope H190. This is a flexible endoscope. So I think it is difficult to approach this difficult location.
Yeah.
Maybe it's better to change the endoscope to the thick.
Thick one.
Thick one, yeah. This is a flexible endoscope.
Yeah.
So this is good for the proximal side,
Yeah.
narrow portion, but this is a anterior wall of the upper gastric valley.
Yeah.
So it's better.
So HQ290, 190, yeah.
HQ290. Otherwise, 1T, 190. 1T, 190.
Yeah.
Yeah. I think it might be better.
Yeah, better scope.
Yes.
What do you think? This is all fibrosis?
I don't think so, but I'm not sure.
Just vessels.
Anyway, not so severe.
Yeah.
Okay, so can I have IP next?
Our Japanese colleague thinks this is probably at the best SM2 maybe, which is what we were thinking. So he feels technically this is all resectable. Yeah, you agree?
Yes,
this is technically resectable.
Yeah, I think so, but this might be very challenging.
It's just access is very bad, yeah, that's what I felt. Wow. This just vessels.
It's really difficult to approach the patient using this endoscope. On belting. Okay, so we change the condition.
Change the endoscope?
Change the endoscope and insert the overtube.
Yeah. So will this overtube work for us? It's a different overtube.
I'm not sure, but let's try.
Yeah. So we're just going to put an overtube down and a stiffer endoscope. And then hopefully access will improve and we'll be able to dissect underneath it.
So can we go to the next room?
Yes, sir.
Yeah.
Come here, mic on, man.
Hello, Anand.
Amol, we are with you.
Okay.
Yeah. Can you just let us know at what stage we are?
No, we are proceeding with the tunnel.
Yeah.
Amita is doing the tunnel and she's trying to widen the tunnel.
Yeah.
Now, for poem you don't need a very wide tunnel, but still you need a little bit wider tunnel.
Yeah.
So that you can deliver the lesion out.
So we also just came out to check our orientation, and we're kind of making some adjustments a little bit more laterally in the tunnel here, because I feel like we might have.
Because it's very important that you maintain the direction in the proper direction, because otherwise the tunnel will go in one direction and the lesion is elsewhere.
How long is the tunnel? What is the length?
So the goal is for it to be 5, but we're not quite there yet.
Yeah.
So inject. So we're just going to inject, so I can widen this a little bit. But as long as I stay with hug the muscle, I can feel confident that I'm not going to be on the mucosal side. And I'll turn the scope a little bit this way.
How do you make it sure that you are in close contact with the lesion in the same direction?
I think it takes coming in and out of the tunnel a little bit, which is what we just did. And that's why I'm adjusting slightly here.
Keep on checking.
Yeah, keep on checking. Similar to sometimes when you're doing like a sigmoid poem, you have to keep checking for orientation. You can also use blunt dissection of the caps to a certain extent to help. Here you can see we're getting close to GE junction. Actually, underneath there's the muscle fibers are crossing a little bit. One thing I'm not seeing here, which I do tend to see in untreated mucosa for a poem, I think the lesion might be right there actually underneath, is the small palisading vessels.
Yes.
So I'm not seeing that here, but
That'd be a little bit
further down.
Yeah,
I think the lesion's right there, yeah.
You can see the palisading vessels.
Yeah, so right at the, you can see the crossing muscles here. So how close we are.
Yeah,
that's the lesion right there.
Yeah.
So I'm going to try to make my way over a little bit here. Actually, can you inject a little, please? So one of the differences with the Irby knife and the Olympus knife is that the injection is something I control with the Irby knife. And so
here you can control it if you attach one more flushing pump, and then you can use a foot switch to, you can do that.
Sure.
You have an additional flushing pump?
You're injecting?
Maybe you can arrange that, yeah. Till then we continue the hand.
So when I do that, it's a little bit sort of faster in terms of cutting and injecting. I feel safer about how I'm in proceeding. But we're just injecting here now. Okay, that's good. Knife out. Knife comes out a little bit more on the cap than the Irby does. Yeah. Up here, right, the white capsule is there. Yeah. It's right underneath here. Actually, let's just inject here. I just want to see. It's right underneath these fibers. Inject, please.
Okay. Amita, they just shift to the other room and come back here.
Okay, great. Yeah. Hopefully we'll have exposed the tumor when inject here.
Yeah. Which is, okay.
Yeah, so it's actually not injecting, which means it's right underneath. That's not so because of, okay.
Right. We're now presenting the next case. 27-year male with no comorbidities, presented with recurrent GERD symptoms since 2 years. PA dependent since 6 months. On endoscopy, he had grade B esophageal reflux disease. Manometry showed LES is hypertensive and relaxes in response to weight swallows. Normal esophageal motility. 24-hour pH metry shows Demester score of 32. Plan is arms. Over to you. Dr. Amit, you're on.
Hello. Dr. Amit, you're on.
Am I audible? Is my mic working?
Yes, we can hear you.
Okay. Okay, now see, this is a new type of procedure which I am going to demonstrate, and this is called anti-reflux mucosectomy. This procedure is basically meant for patients who have GERD and who are on long-term PPIs. It is initially thought that this procedure was meant for refractory GERD patients, but I feel that instead of calling it refractory, it should be called as patients who are dependent on PPIs rather than refractory to PPIs. Now here the principle of the procedure is basically tightening of the OG junction. Okay, and this procedure is meant not for the patients who have got hiatus hernia. In our clinical practice, there is a large percentage of patients of GERD who have got symptomatic GERD in whom the Demester score is very high. If you do a pH metry, you can find an abnormal acid exposure in standing, predominantly in supine. But all that you find on endoscopy is a loose GE junction, what we call as lax cardia. So this procedure was devised for patients who have lax cardia, which form the majority of the patients of GERD. Now this was actually accidentally discovered by Professor Inouye, who discovered or invented the POEM procedure. because when Professor Inouye started performing resection, endoscopic mucosal resection for Barrett's in the esophagus, he found that in some of his patients who had symptomatic GERD, and he did a circumferential resection of the Barrett's at the lower end of the esophagus, because of the constriction which happened, these patients had a reduction in their GERD symptoms. So he thought that this is going to be a good idea, that if you do a mucosal resection of the lower end and it causes a circumferential constriction, it will cause a prevention of the acid coming in the esophagus. But the problem is, when he did these patients of circumferential resection of the esophageal mucosa, he found that almost everybody developed strictures. And then you had to dilate these patients with balloon dilators. So therefore, this technique got modified. And then Inouye described in his first publication, which was published in 2014 in Annals of Gastroenterology, his first case series of 12 patients of anti-reflux mucosectomy. He showed that in 2 of these patients he did circumferential, and in the remaining patients he did a crescentic mucosal resection. This technique has evolved over the last 3 years now, because 2014 it was described. In our own center we have done 35 patients of arms till now, and we have analyzed our data on the first 12 patients with the longest follow-up of 1 year. Now what basic principle is, look at this. This is an endoscopic picture in a retroverted position, and you are seeing a loose OG junction. Now it is important that this loose OG junction has to be graded. There is a grading system which is called as mucosal flap valve gradient. This grading, if it is grade 1, then on retroversion you only see a very little laxity around the endoscope. Grade 2 is something like this, where you can start seeing the esophageal mucosa also. Can you see the esophageal mucosa? You can see esophageal mucosa and gastric mucosa. So normally when you take a U-turn, you are not supposed to see esophageal mucosa. You only see the OG junction constriction. Grade 3 and grade 4 is actually hiatus hernia. So arms procedure is only meant for grade 1 and grade 2 mucosal flap gradient. Now this falls in grade 2, almost going to grade 3. So if you ask me personally, this patient has got a 70%, 60-70% chance that he will do well with the arms. Now if you see over here, this side is the greater curvature of the stomach, because this is the fundus. Now greater curvature of the stomach, you see this here, this is the angle of His. Now angle of His itself plays a very important part in the anti-reflux mechanism in physiology. So during arms procedure, the technique is to resect the mucosa in a crescentic fashion of the stomach and partly of the esophagus, only on the lesser curvature side, from here to here. But this portion we are going to leave intact. So approximately the diameter of the scope, or 1.5 or 2 times the scope distance, we are going to leave intact, and remaining all mucosa we resect. And then immediately you will not see the result. The result is evident 1 month later, once the healing takes place of the mucosa, because the healing occurs by secondary intention. We are not suturing it, we are just making a mucosal defect. And when it heals, when you do an endoscopy 1 month later, the entire area on the lesser curvature cicatrizes, and it almost looks as if you have done fundoplication. From the 12 patients which we have done so far, 8 of the patients have completely stopped their PPIs. Remaining have reduced their dose of PPIs. Demister score has normalized in 10, but it has reduced in 2. And especially this was in those patients who had a very high Demister score. Now how do we do it? First and foremost is, once again like POEM procedure, patient is in a supine position or left lateral, patient is intubated, then we have switched off the air pump, the patient, we are only insufflating carbon dioxide, and the first is we are going to do some markings, because we want to know from where to start and from where to end. Okay, so for markings it's like a ESD. For here I am going to use, we are using a dual knife for marking. So now I am going to do some marking here of the two margins. Okay, so I am going to mark not by pushing the knife, but I am pushing the knife little bit, but I am now going to bring this in the front. Here. Okay, so this is one margin. Now we are going to go to the other margin. Somewhere here, hold the scope. Because in this, because it is a little bit lax, very wide, we may have to do a little more resection. Okay, clean it please. You see here, from here to here, little more marking. Wait, hold on. Keep it here. Hold it. Now this marking is done by closing the dual knife. You're not going to open it because you're not going to do any cutting with the knife. This is only to touch and mark. Right? Here. Now, see, this is our resection margin. From here to here is going to be intact. So resection starts from here. And we are using the classical EMR cap technique. So this is the suck, then close, catch the mucosa inside this snare, inside the cap, and then close it with a crescentic snare. Okay, so that is the technique. Now, if you directly suck, what will happen is the mucosa will come along with the submucosa and the muscle layer, and then we may create a perforation. So therefore, as we do in POEM procedure, the first thing I am going to do is to inject a solution of normal saline, which is containing also some dye, because we have to raise a submucosal cushion. Now we have to understand that this area is very vascular. So every time I cut, there is likely to be bleeding. So as he is injecting, I am gently pulling the knife back, pulling the needle back.
Amit, good afternoon. Amit?
There is indigo carmine.
Hello, can you hear me?
Yes, we can hear you.
Amit, why did you pull the needle back?
Pardon?
Why did you pull the needle back when you was injecting?
Oh, so that it goes in the submucosal layer, otherwise it will go deeper into the muscle layer.
Okay.
Because here it is a very thin wall of the stomach.
Again, mind you are seeing two different images from two different endoscopic suites. Don't
Okay.
confuse them.
Okay, now this is that special crescentic knife, crescent shaped knife from Olympus. We are going to gently try to rotate it now. Rotate the knife. Okay, wait. Why is it not catching? What? Okay, you want to change it? Okay, give me some more injection.
Did you show them the orientation of the snare?
Okay. Yeah, because the orientation of the snare has to be proper. Flush little saline, irrigate. Irrigate more. Okay, so let me inject a little more. You know, because this tightening you have to do very, very crucial. If you catch too much of tissue, you can directly make a hole.
inject more.
I think it's important to have a nice bleb, and re-injecting is going to allow us to get that nice little cushion, safety cushion.
Wait, needle, check. Back. This snare is not so simple and it keeps on rotating, and every time it does not come always in the right position. Sometimes you have to use one snare for one cut. See now, it has gone up there. Get it? See what is happening to the snare? You want to change the snare?
Amit, the snare has to fit in the groove there.
Yeah, but for that you have to rotate it, every time the snare doesn't go in the groove.
Okay.
Change the snare.
Amit has one of the largest experience, so he'll be able to tell you much better.
Yeah, the snare needs to be retired.
Yeah. Retired.
It's a retired snare.
Actually, it was a new one. Basically, this is EMR of the normal mucosa. As simple as that. That is arms.
Making a polyp and doing a polypectomy, basically.
Have you caught it? Why is it not catching?
Suck more, suck. The suction is
Okay.
the suction good?
Yeah, suction is good. Close it.
Now you got it.
Has it caught?
Now you got it. Now you got it. Close.
No, because, see?
Slipping out.
Why is it slipping?
Suction has to be very good.
No. Suction is good.
That's what I'm saying. It has to be very good.
Unless it catches, properly we can't cut.
Audience, you have to be proactive.
Okay.
Please, questions, comments, queries.
Sometimes
Otherwise it becomes
an asymmetric snare or a snare with barb can help.
Okay, one more here. Okay, one more here.
Did you see he poked somewhere and injected? See, he's injecting that it's coming out through this hole. So Amit,
Let's try once more. It's not coming sufficiently inside the cap.
no, the entire fluid was coming out through the other hole.
Yeah, the fluid, no?
The fluid, yep. So it's not lifting basically.
And now you are also going to see that once we do the cut, actually, I hope I can do it, because so far at least the snare is not catching. Once I do the cut, you will realize that it is a vascular thing.
That's it.
You got it now.
Not too much, no?
That you'll be able to. It's slipping.
This is too much coagulation here. What is this current? Huh? Too much coag, no? See? It's a very thick mucosa, no wonder. Okay, but at least one cut we have done. And see, the funny part is here it looks small, but once we start making the cuts, the whole thing starts separating and it will become bigger. Is the setting proper? It's very thick.
Oh, you dropped it. There.
Okay. Water.
The tissue is held up there.
Yeah.
In the groove.
Then I have to release it.
Otherwise your snare will not fit. The nerve is gone.
Little bit of esophageal mucosa. And then we are going to refashion it afterwards. Initially I am going to make a excision. Yet
Amit, how about doing a large endoscopic submucosal dissection in this area?
What?
Submucosal dissection in this.
Yeah,
normal.
but this is like, instead of submucosal dissection, this is EMR.
Okay.
Because see, we are going to go crescentic. So doing a submucosal dissection at this angle, just below the OG junction, is not going to be easy.
Very difficult.
You can do band EMR also, but this is faster.
Band will have very small areas of mucosa.
Okay, got?
Sucking as he closes.
Yes.
And simultaneously you are pulling?
Right.
Now see this. You are going to see these vessels now. See that?
Yep.
It has to be quick, huh? The instrumentation.
Quick.
You cannot waste time. Take out the instruments and keep ready. Don't open packets now. So see what I am doing? I am stabilizing that area with the cap. You can actually see the vessel.
Yes.
So as we keep on cutting, no, you have to keep on coagulating. Because we are bound to keep on seeing these vessels. So rotate.
Right.
Flush please. Open.
Thoda aur.
Touch. Open.
What are the chances of thermal injury depth?
No. Because there is a fluid cushion there.
Any chance of using a clip over here if the bleeding doesn't stop?
No clip. Okay, open. Flush.
No.
You know, there is a little gap, island in between. That island we will take out later. Open. SB knife handle? SB knife? Huh? Sumitomo. Handle? Okay. What about here? Flush here.
How many of you have done this procedure? Anybody in the audience? Mohan, we all know you are doing it.
Yeah. Sometimes little more, depending upon how much we can remove at one time.
Any modification to technique, Mohan? Any modification to technique?
it's all about a nice lift. You see, we finally started to get a better lift. Probably the mucosa is less thick in this area. You gotta get it started. You know, once you get it started.
Have you used bands? What about stabilizing the snare?
There, that's a nice grasp. Yeah, that's very nice. It's communicating with the first EMR on the left.
The left.
Nicely done.
See, this is our marking. So here we have to get cut now.
So we're almost there.
Is this area?
Yeah, no. Once we inject, it becomes bulging.
But you see how important it is to mark your territory, because otherwise, in retroflexion, when you start doing the resection, you can very easily get lost.
Okay.
So this marking is very important, I think.
Marking is important. Then the scope U-turn should be important. Make sure that the scope is taking a complete U-turn beforehand itself. Otherwise, you will not be able to do this. Just 1 minute, let me take out that water. The trick is suck it properly.
The idea is to be able to aspirate the lesion and then very gently, shimmy the snare around the site of resection.
The vessel there. Mind you, it looks easy, but it's difficult because it's normal tissue, healthy tissue.
Very thick mucosa, I think, that's the key here.
There is a bleed.
Catch. Oops. Rotate, right side. Catch. Okay, open. Catch. Okay, open. Take out the water. Stop there.
See it now.
Okay, open. Open. Catch. Stop there. Okay, open. Wait. Open. Catch. Okay, open. What I'm going to suck the fluid a bit. So for that, give me the snare. No, no, give me the snare. I leave the snare inside the channel and then suck the fluid, so that the tissues which we have cut don't block the normal scope. Snare prevents the thing from clogging. No, this is a good powerful suction. These are all those specimens of normal mucosa. Okay. Now inflation a bit, and I'll show you how to make it look neat and tidy. Okay, flush here. There's some oozing still going on. Okay.
Dr. Amit, we just switch over to another room and come back to you, sir.
Yes.
Thank you, sir. Dr. Amrita.
Yes.
Ma'am, we're back with you.
Hi. So we've been tunneling down, and we've been having a lot of difficulty actually figuring out where the lesion is. So here's our tunnel. Now I think I'm going to CO2.
CO2.
I'll just wait so I'm not pushing. So here we're following the muscle down. Following the muscle, and right about here is where we think we cross GE junction. It opens up quite a bit. And then now we're just trying to locate where this lesion is. We thought we had glimpsed it, but now I'm not so convinced. Why here? Okay. Can I have the knife again? It's been a little bit of a tricky lesion, I think partly because the scope is twisting in the tunnel, but it's a little bit, yeah, it's a little bit mobile, and at some point we looked at retroflexion, it disappeared. Knife out, actually, yeah, knife out. Shortless injection. Just to confirm, this is submucosa. Okay. Okay, knife out. So I confirmed that by injecting that's submucosa, so I'm just going to widen this tunnel. We had some vessels when we got down below GE junction, so we switched over to our coag graspers to...
Just a moment. Change it. Hybrid knife.
Having some issues with our generator.
Fine.
Okay? Okay. We're just widening this tunnel to try to see if we can locate. I think we're definitely on the gastric side of things. You can see the much larger vessels, and it's quite open. And actually, my scope is acting the way it does when you get to GE junction. I have difficulty in that position getting to those submucosal fibers, so I'm going to change the orientation of it here. I think this is a bit of mucosa that's stuck to each other, so I could just open that up a little bit and inject. Yeah, I'll just see if I need coag graspers. No, I think I can get this.
that's the lesion. This
This
is the
right,
tumor.
oh yeah,
That's
that's
the
the
tumor,
tumor
I
right
think.
there. Yeah.
Hope so. Appears like a tumor there.
And it's small, so it's really hard to. We think this right here. Hard to tell. So I can see how that could be the lesion, although it's really not presenting itself as like a capsule. I'm going to try to clean this a little bit. Inject. I'm going to inject.
No, he is got it.
Huh?
Needle back.
I'm injecting. So it's a little bit of a learning curve for me with this this knife because the motions are slightly different when you inject. You have to keep the needle in, and you actually push the knife against. There's a large vessel here, which sometimes makes you feel like it's feeding the lesion as a suggestion that. See the yellow color there? I think that might be the lesion, although it doesn't. It's very continuous, so it doesn't really look like. So our suspicion is that this is the lesion under here. What, do we have a vote? Anyone want to? Here's our bleeder. We have a flush. Of course, we want to take care of any bleeding as we go along. Yeah. You think this is part of the mucosa?
Yeah.
This side?
We'll just rotate it and see, I think. Where the muscle is there.
Beyond the lesion, but in terms of which direction? You think this is a lesion? So I'll go around this side of it.
I think that's a mucosa.
Back up. This right here is mucosa, but I think the lesion might be right there.
No, that appears to be the mucosa. It has to be to the muscular side. The muscle is right there on the top.
Muscle is there. Kind of big vessel. Might want to take with coag vascular. Yeah. Actually, I think I can get that with this knife.
Too big vessel.
You think that's it?
No.
I don't think so.
No. See, my contemplation, no, but that is the mucosal part, I think.
Yeah.
No, that's the muscle is up. This is the mucosa. We have to.
Look here. Here's the muscle. Right up there.
Yeah. That's the mucosa only.
Like up.
We have to just come up and.
Dr. Amritsar, we'll just get back to you, ma'am.
Yep, sure.
Thank
no
you.
problem.
Dr. Amit, we are back with you.
You're back?
Yes, sir, we are with you. We have been always watching you.
Yeah, I have done the last cut now. Can you flush, please? That was the last resection. Open it. Catch. I setting a cartridge. Open. Take it. Flush here. Okay, catch. Okay, open. Open it. Open forceps. Open the forceps. Okay, open. Rotate. Catch. Okay, open. Rotate. Okay. Here. Needle. See here, I'm going to take out this portion and this central portion. That I'll show you.
Amit, how do you decide how long the lesion will be?
That depends upon how loose the OG junction was.
Okay.
Because if it is mucosal flap gradient 2, usually we do a little bit more resection. See here, if you see, we have resected up to here. So this is the intact area left.
So
everything else is resected.
So it will be 2/3 of the circumference? Or
yes. But now this area is still not. So now refashioning has to be done. First injection. So now over here, this inner middle bridge has to be removed and some more from this area has to be removed. Then the resection is complete. Because the first resection what we did was too small. See this. It is not separated out.
What happens if you don't remove this bridge?
What if you don't remove? You will not get a good result. Because the whole idea is to create as much defect as possible which will heal by secondary intention. See what I am doing, huh? See that? Okay, now.
No gap, basically.
No gap, no gap. No, this is a special forceps called as Sumitomo forceps for dissection. It is also used for dissection.
Who supplies it?
There is a bleeder here, huh, somewhere.
Amit?
This is also a Japanese company called Sumitomo Bakelite.
In India, who supplies it? In India?
Yeah. No.
Or the audience has to go to Japan to get it?
This process can be used very effectively for cutting, for dissection. And there have been some articles, I think Mohan is sitting there, Mohan Ramchandani.
Mohan is there. Mohan
He has published an article of using this process for Zenker septotomy.
But where do you get it from?
There are some dealers in India. Inject fluoro irrigation. See here. You have to achieve a proper hemostasis here. You know, the more I do coagulation, the more fibrosis there will be now. Okay. Now this one area you have to resect. And then we are done. Then I will show you the complete 2/3 circumference. How the resection has taken place.
Nice. Nice.
Even this can be resected, this much, this island. The only danger in doing this procedure is you can create a full thickness perforation.
How to avoid that?
You don't suck too much.
Good lifting.
Good lifting and not to suck too much inside the cap. Here the mucosa is very thick, huh? See that?
Yeah, very thick.
It's not even lifting properly.
No.
Okay. Okay. Huh? I'm extremely honored that Michelle is helping me out.
Oh,
standing next to me.
I'm actually learning
one of the best interventional endoscopies of the world.
Thank you, Amit. I've seen a few, but this is nice because this is a very complex case because you have to inject a lot, you have to make sure it lifts a lot to be able to do an elliptical, mucosal resection that will make the anti-reflux efficient.
Yeah.
That's the challenge. Is if you don't have that elliptical, mucosal resection in continuity without any gap.
No.
Then
The snare is not catching.
And Amit?
Huh? Yes?
In the unfortunate event that you get a perforation, what do you do? Surgery?
We clip it.
Clip it, that's all.
That is not a big problem.
Okay.
You got it? Sure? Very thick.
Yeah.
That one small island left. Okay, one more injection.
The knife or the?
No, I'll use the forceps, but I will raise it up first. Or even you can use a normal snare for this. You have small one?
Vivekanand Kulkarni. Missing person report has been filed over here.
Okay. Dr. Amit, we'll just get back to you, sir. So we're going to Dr. Mohit Bandari.
Need a habeas corpus petition?
Dr. Mohit.
For the first time.
Dr. Mohit and Abe.
Okay.
Abe?
Yes.
We are with you.
Hey.
Are you with us?
Yes, we are.
So do you want to explain what we've done so far?
Yeah, actually, we completed circumferential mucosal incision and then use a clip line traction. We apply a clip to the greater curvature side and retract the lesion towards the cardia. And in this patient, actually, the belting is so frequent, so we insert the overtube to insufflate well.
Yes, so we want to show that very clever innovation. I don't know, can you show the overtube? So we got a overtube which allows in much better inflation that gave us some access, but that was not enough. So this is another innovation of using the glove. One of the finger of the glove is fitted on top of it and made a little hole on it, and that has given us another airtight compartment on top of the overtube, and that improved the access. Once the access was improved, I think he's done most of it with the IT knife.
Yes.
I think National Cancer Center is famous for IT. Everybody coming from National Cancer Center are very good with IT knife. Once the access is improved, I think we managed to dissect with the IT. So we're almost towards the end of it. You can see this is where we were worried. All this area has come off. It was very vascular. There was a lot of bleeding, but that's the nature in most cardiac lesion and greater curvature. You think are very vascular?
Yeah, there were so many vessels originate from
not only that, the patient is having portal hypertension too.
It's complicated by portal hypertension also.
Yes.
So everything put together made this very challenging. So we are on our last run now to dissect this bit here, which will continue with the IT again. And now this is not taking much of injection. What do you think, we should dissect or inject again?
Inject again, and hopefully use the creep-line traction again.
Yeah. So now this again becomes challenging because of the access gone down, lift is very poor.
Yes.
So we use the clip and line again to improve access. So it's a very slow process. I'm involved in writing some guidelines for UK ESD user group, and one of the criteria I proposed is that we should introduce psychometric testing of the endoscopist, because this really tests your personality. When you continuously get oozing, fibrosis, poor access, you can't have a person who loses his temper or gets frustrated. You agree?
Yes,
You need to have a Japanese personality.
Yes, I think so.
Very calm, carry on, stay focused.
Yes, thank you. Okay. And we now
you need gene transfer from the Japanese?
Yes. Sorry, say that again?
You need a gene transfer from the Japanese.
Gene transfer, yes.
Inject. And now we are using the new electrocortical unit, ESD 300. Actually, I used it for the first time, but because mucosal defect, very, very clean and less coagulation. So I believe this is a good new project. In the near future, of course, we have to establish a good setting and quarterly setting. But I believe it's a good project.
Need luck. As you can see, inject. The lift now again is very poor. Stop. And there's still big vessels in there. Needle out.
Yeah, so now you can see the exposed submucosa,
Yeah.
the 8 o'clock position. But a large vessel is also here, so please take care.
Yeah. So we're very scared of this large vessel sitting right there.
Yeah.
Do you think it's on the lesion side? So, or is
you
it
can access below the vessel.
below?
Yes. Otherwise, the precoagulation.
Needle up. A little bit more. Yeah. Inject. Yeah. Inject. 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 And stop. Right. IT. One of the other things that I've observed my own learning curve, that when you are early, you try to dissect more superficial.
Yes.
And you cause more bleeding.
It's better to see the submucosa directly and identify the vessel in detail.
As you get more and more experience, you do ESD in a deeper plane.
Yes.
And that's when you get less bleeding because you coagulate the main vessels.
Exactly.
So should we go from top downwards, or it's a lot of fluid,
Before submucosal dissection, it is very important to make sure muscle direction.
Yeah.
Now the muscle direction is about say 1 to 7.
Yeah.
From 1 to 7.
Yeah.
So please try to move the IT knife parallel to the muscular layer.
1 to 7.
Yes, yes. Here is HO's.
That's the edge there, so we hook it in there. And IT knife, again, the other technique is that you stay quite away from the lesion, isn't it?
Yes.
As compared to the dual knife.
Yeah, of course. Some people with IT knife is of course insulated. So this is little risk of perforation.
Yeah. Okay, knife out.
You hook some mucosa. Take care. You're now hooking some mucosa.
Ah, you think so? So we need to get into the submucosa there.
Yes, yes, yes.
There.
Yes. So get close and identify the edge of submucosa.
There.
It's okay. It's okay. So this area was coagulated too much, so it's better to use the cutting mode rather than
okay. That's why it won't go through.
Yes.
I'm so scared of bleeding. So much bleeding today.
It's okay. No, this area was almost mostly
burnt.
exposed. And exposed. Let's see.
Cut, go close, watch again. Yeah.
Yes.
That little bit more superficial. Should I cut a little bit deeper, you think? Are you okay with that?
I cannot
Yeah?
see. I cannot see muscle direction.
So
right
how many
now.
in the audience have the personality of doing this? So basically a personality test now.
What do you think?
Anybody?
There? So if I hook it there.
Yes.
Dr. Bhandari?
Yeah, say that again.
Nobody in the audience wants to get the case like this.
This is a special treat just for me from Amol. He wanted me to.
And are you still perspiring?
Too superficial? Too superficial?
Yeah. It is, see, that's again a sign of less experienced endoscopists is that we go more superficial. Is that better?
Okay. 6. Let's see. Let's see.
Hey, that's looking better.
Okay.
I can finally see a plane.
Yes.
Oh my God. Knife out.
Okay. Dr. Bandaka, we'll just leave you for a few minutes.
Okay, sure.
Thank you.
Amit has done.
We are now with Dr. Amit. Back with Dr. Amit.
To the final product.
Oh, you're back with me?
Yes, sir, all the way.
Okay, see, I have completed the procedure. I'm going to show you. Okay, look at this. I'm going to inflate the stomach now. We have also achieved hemostasis. Now look at this resection.
Very nice.
Entire 2/3 of the mucosa of the OG junction is resected. Starting from here, 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 up to here.
A big round of applause for Amit, please. Thank you. Fantastic.
A little bit of...
Amit, you always get so much of bleeding in every
Pardon?
patient? Do you get so much of bleeding in every patient?
Oh yeah, this is a less. When you do EMR of this area, every cut there is going to be oozing, and not only oozing, spurting. So after every cut you should be able to achieve a hemostasis, then go ahead. Don't leave it. Otherwise your whole field becomes completely...
Any chance of secondary bleeding?
No. That's why what we are doing now, I'll just show you what I do. See, even these small vessels on the floor, I think what I need to do is to take out that fluid.
There's a palisade of vessels over there.
See this?
There's a palisade of vessels.
Yeah. So I'm going to take out the scope, take out the
without
cap.
NBI you can see.
And I'm going to go inside without the cap. There you will get a completely different picture now.
Very nice.
Now inflation.
Patient is a big problem for the government.
Nothing is bleeding. It's perfect.
See that now, SP?
That's very nice.
Just joking.
Can you see how much is the resection? And this much is the normal area of the greater curvature.
Very nice, very nice.
Now if you see the same patient 1 month later, this will appear exactly like a fundoplication. Now this is arms.
So Amol, we are coming back in 1 month's time.
Okay. Bye.
Beautiful.
Thank you.
Fantastic.
Thank you,
Thank you, Amit.
Thank you.
Right. So now we're going to Dr. Amit and we will be with Madam all the way. Ma'am, you're on.
That right
Hi. Well, we are still in the process of trying to locate this lesion.
Can we have the endoscopic room
We've
images,
had a
please?
couple of different ideas.
Yes.
Amol thinks that perhaps it could be this tubular structure.
So tell me again.
What happened? You saw a tumor over there and then...
Well, at various points we feel like we've seen something that could be the tumor. However, it ends up not being the tumor. So you see this, there's a structure here that is elongated.
Yeah, that's elongated.
And Amol has speculated that maybe this is the tumor, although we feel like it might not be.
Not be.
So we're just going to clean this to try to see if we expose that. I think that's a fold.
Yeah, that's fold.
So we've really been hunting for this tumor and we can't find it anywhere.
Can you put a hemoclip on the tumor?
Yes.
And then under the C-arm, can you locate it?
Sorry? I didn't hear.
But it will be to inject some...
Just distal to it somewhere here.
Here?
Just to locate.
Yeah, what is that bulge? This bulge here. No, no?
No. Yeah, we're well along the gastric wall.
Yeah, we have already crossed the G junction. And this is the muscular part, that's the muscle here.
We also changed the position of the patient to see if perhaps that would help bring the lesion a little bit more into view, like fall toward us, but that didn't make any difference, and it was a little bit not stable for the patient, so we put her back on the back. I'm just going to dissect this out here. But I don't think that is a lesion. So we're a bit confused, to be honest. No. So I'm going to come out, I'll show you the tunnel, and actually we'll go back and show you in retroflexion.
We have already dissected out.
We've gone. There is where we originally seen the lesion. Here.
Yeah, we had already crossed that by injecting and all, yeah.
We were trying to think if perhaps maybe the lesion was on the serosal surface, and that's why we're not running into it, but by EUS it really looked like it was
EUS it was
submucosal, from the muscle layer. So if you come here, we follow the muscle down. Here's GE junction. You can tell here the palisading vessels I mentioned, and also it opens up and it drops off just the way it does when you are scoping in the stomach. And that's muscle there, and we're still not seeing the lesion. Let's see what's happening here. Just make sure we don't have a bleeder. Okay, we do have a little bit of a bleeder. Knife out. Let me just take care of that.
Is that the one?
Huh?
The one below. Just because this what is there, yeah?
Knife in, knife in. You want me to probe it?
Is that a tumor? No, or muscle. This yellow thing.
This yellow thing here, I think that's a mucosal fold. Knife out? Okay, let me dissect that out.
It appears to be the, yeah, I think it is. I think it is it.
Yeah, that's perfect.
That is quite down.
I think the tumor is not that big and is in the wrong plane, I believe. Looks like a thick band, doesn't look rounded.
I can't hear the commentary.
No, that's the posterior.
No, it is posterior. No, it's here.
That's the one.
I think that.
Yeah, that's the one. Perfect.
I think that could be the lesion. It's bleeding.
Almost says he's 100% sure this is the lesion. I'm not so sure.
How many in the audience are sure this is a tumor? How many will go with Amol? Amol?
Yes, sir.
No one votes for you. Jamana Japt.
No worry, I agree.
No, sometimes you may be right and you may be right and every.
No worry, but I think that's where the.
No, you may be right and everybody else may be wrong.
I think finding the lesion is more important than proving anyone right or wrong.
Doesn't seem to be the upper margin, that is the problem.
It doesn't look like a capsule, right?
And it's just
soft.
soft.
And it's very continuous, so.
It's continuing, yeah, it's continuing down.
Like that?
It's to be somewhere here.
On the other side as well. You need to try and dissect it from the other side.
Just in that area, not this. The proximate, yeah, here. In this area,
try and inject and
bulge. There is some bulge here. Can you just needle back?
Inject.
Pankaj, on endoscopy, it was very close to the G junction.
Yeah, we are already across the G junction.
I know, you're way down here.
Yeah, just around 2-3 centimeters just distal. And
Amita, maybe you can inject on the undersurface over there, down. Yeah.
Here?
There. Yeah. Where the strand
don't take out the needle. Bulge lag raha hai. Can you focus that? Do you see that? It's a bulge.
Here?
What do you see that? No, no. Just.
I don't see a bulge.
So even if you go lateral by a centimeter or two, the tumor is not that big.
Guys, where is
I think that bulge is the lesion.
You think this thing right
Yeah,
here?
this is.
Get those strands off.
Yeah, knife up. Alright.
Yeah, this one, yes.
Hello. Swas?
That could be the lesion. Right thing coming out? Probably. Doesn't turn out to be a new muscle.
Again, we are in the same plane.
Yeah, it is again in the
Back
same
to square
plane.
one.
It doesn't come back. Yeah.
Yeah. The thing is, if it's
Stop.
You want me to come all the way back?
The muscle.
that.
Not that anechoic for it. One of the things that you can probably do is, if
Knife in? Knife out. Sorry, yeah, knife out. I just want to take care of this bleeder. Actually, let me inject. One thing we could do is put an EOS scope down and try to put a needle into the lesion and inject a little bit.
If it's a leiomyoma, it's not going to take up much.
But why do you need an endoscopic ultrasound?
No, I'm just trying to localize where exactly.
Visually, it's there. You can inject.
But with the air and the gas over there, you're not going to get a good image and EOS now.
That's the whole fold. Just come back.
You think it's like right under here?
No, not there. On this side, to the right. There is a lot of bleeding there.
Where is the bleeding?
Just
Semi-closed
erosion,
bleeding.
yeah. You have to go beneath this muscle here and towards this. Up.
But this is all muscle. You don't think this is muscle though? This is pretty close.
This is muscle.
This is muscle, so there's
This
nothing.
thing inside. Yeah, this one, this yellow. 3 o'clock. I think that is the one.
No, that was the fold that we were seeing though.
No, but this is the other side.
Anybody has some ideas?
No, again, that's the fold.
No, that's the fold that we were seeing, the elongated one.
Okay.
Let's try to control this bleeding a little bit here.
Yeah, we can have the coagrasper and just stop
Come here,
it.
through the tunnel. Through the tunnel. Then do what?
Can we just have the coagraspers for a moment?
Coagrasper.
A little bit of hemostasis.
Because there's an idea that you can pass a mini probe through the tunnel and locate the tumor.
Do we have that available?
We'll just have to ask.
It won't be that easy.
Do we have a mini probe here? Do we have a mini probe here?
I don't think so. We'll have to ask. No, mini probe.
How that's behaving? How that is behaving?
Yeah.
It's definitely mucosa. We're switched over on the settings to the coagrasper. Where we're bleeding from now.
It's the
Okay. So keep it closed. Keep it closed.
close it.
What happened to Dr. Bhandari's case? Still going on there.
Ma'am, we'll just get back to you. Dr. Bhandari, we'll get back to you.
2-3 minutes, they can come. We are on our final stage.
Dr. Bhandari, we are right now with you.
Oh, okay. So we made a lot of progress. You can see the difficulty and challenges. So we done the clip and knife technique again. There's a little bit of oozing, but I think we can ignore that for the time being.
Okay, it's okay.
So here you can see the traction, which has allowed us to open up these planes. I'm just going to inject a little bit, and then we'll be able to dissect this again. I think IT knife has been invaluable here. Yeah, without IT knife, it would be very difficult to dissect this lesion.
But now you only have a very small few millimeters of the pedicle left.
Hello. finish line is so close. And needle out. Inject.
Wonderful job.
It's not taking much of injection, but
There's hardly any space
that's
there.
enough. Yeah. IT. It's just maintaining the inflation, the planes, controlling the bleeding, and not losing your focus and direction of muscle. That's all it requires and nothing else. So do you do a lot of yoga to maintain your focus and orientation with this?
Yeah, so it is very important to get close and get away repeatedly.
Dr. Bhandari?
Yeah?
Now can we pass in a snare and do a polypectomy of sort of a thing?
Yes, I'll be very tempted, but I've got a Japanese colleague next to me. They don't like it. He's saying, can we use a snare now?
No, it's okay, but...
That's below their dignity. But I think we're almost there. You think, yeah? With a knife?
You can.
Knife out?
You can complete.
But it can be. I think that's a very realistic and practical option because this is again.
Okay.
Yeah.
Okay. No, he's got it. Got it.
Two supervision. 6, 6, 6, 6.
Yeah.
6 o'clock position. 5, 5, 5, 5, 5, 5. 5 o'clock position.
There.
No, this is 7.
Nearly there.
There. You think I'm too superficial there?
Okay. Let's see.
Let's see. See, I have an inherent tendency to stay a bit more superficial, and sometimes that can cause a problem. I think that worked all right. We need to go a little bit deeper there.
Oh, it's okay.
There, open, and hook into that. Yeah?
It's okay.
Very tough, not cutting that much.
हिंदुस्तानी का पेट है भाई.
Knife out. Almost there. Been saying that for last 1 hour. Almost there.
Done. Congratulations.
Finally there.
Finally.
Oh my God. So we had a lot of skepticism. We had a lot of questions and issues, whether it's doable, whether it's invasive. I think at the end of the day, it's all about technically whether it's feasible or not. Talking to our Japanese colleague, he feels this is maybe SM invasive cancer, nothing more. Yeah?
Yes.
I think it's just the vascularity and fibrosis, and access was the main problem.
Yes,
What does he think? Will there be a residual tumor there?
You think there's residual this? Yes. No, these are fibrosis and vessels. You can see how close we are to the muscle there.
What's the opinion of Dr. Abe?
This is just a fibrosis, not some...
They think, is this a residual tumor?
No. This is
not tumor.
And fibrosis.
Fibrosis in the submucosa where we struggled a lot.
Otherwise, corrugation after the vessel.
Yeah. So now, would you coagulate vessels? We look for it and coagulate, but yes. I think we coagulated everything.
No bleeding.
Yeah, it's better to coagulate vessel.
More? Is that no vessel is left? I think we've killed all the vessels.
Yeah, but
still,
definitely the prophylactic coagulation allows us to reduce
the risk of delayed bleeding.
Yes.
Yeah.
We should do that.
Okay. So can I have the coag grasp, please? Or shall we take the specimen out first?
Either fine.
Yeah.
After you.
I'll take the specimen out.
Okay.
Big. Let me inflate again.
Did you catch the lesion?
No, it slipped out.
Okay.
Maybe there. Okay. I'll see if I can suck it in.
Okay.
It slips. Can we use the rope net, you think?
Close net.
In my department, the nurses say when the bile starts coming into the stomach, it's time to stop, which means you would spend too much time trying to remove and you're not making progress, so just stop.
Anyway, you complete it.
Let's see if it comes out. Yeah. Yeah.
Okay.
Excellent. That's a big boy. That's why it was a difficult delivery. I can see that.
Congratulations.
Thank you very much. So do we still use our clamping mechanism?
Okay.
Or is it not going to work anymore? This is where a little bit of innovation can make your life so much easier by improving the inflation and access. So just putting the glove on top of this really improved the access. Do you see that? So this is glove is making it airtight, and that holds the air and improves the access.
Where have you put the glove?
It's on, if you look at it, so there is an over tube. Let me show you. So there is an over tube that we've inserted, and then on top of the over tube we put this glove, and we're going through that.
Okay.
So over tube improves your insufflation, and then the glove improves it even more. In Japan, you would do this under sedation.
Yes.
See, so they would do it under sedation because Japanese patients listen to the doctors.
No.
Western patients don't listen to doctors.
Yes, that's true. That's absolutely true. they won't even wince if they have pain.
Yeah, the doctor just says stop breathing and they stop breathing.
Yeah, I can vouch for that. Wincing is considered bad manners.
Yeah.
Yeah, definitely the mucosa defect is very clean.
Yeah.
So probably you could use a new product from Olympus, ESD 300.
Yeah. So one of the things is that we use this new Olympus diathermy machine called ESG 300. Both of us are new to it, but after some adjustment, we managed to figure out the settings that work. And what you can see in the base is quite clean. The margins are clean.
Yes.
There's less diathermy artifact.
Yes.
So, which means it's very clean cutting, which is a good thing. Now, I don't see any vessels here.
Yeah, but
do you still want to coagulate anything?
Yeah. Look at in detail. There are some vessels, very small vessels. Yes.
Or even these small ones we coagulate?
And also the 3 o'clock portion.
Or these?
Yes.
We coagulate?
This is a vessel.
This is sitting right on top of the muscle.
Yes.
It's still okay.
Yes, it's okay.
Let's see. These things worry me, but it doesn't worry him. But in long run, that's what's going to pay you, because I wouldn't coagulate that, but then maybe my patient will come back with delayed bleeding. But the problem is we don't have very good randomized trials, and that's one of the drawbacks of this area. We got soft coagulation? No, soft coagulation. Soft. Oh, he doesn't know. We have to change it.
Okay.
The diathermy person is hungry. He's gone for food. Olympus will have to better train their staff next time. Close.
Not to feel hungry?
So, would you still grab it, or can I just touch it with the tip?
You can,
grab?
It's better to grasp the vessel.
Grasp with the vessel? Close.
You can grasp more.
I'm just so worried. Open. I know. This is very superficial, but done the job.
You can coagulate more.
I know.
Dr. Bandari?
Yeah.
Back home in Portsmouth, you have coagulated these vessels or left it?
No, I would have left these small ones, but maybe that would be a mistake. But I think in stomach, the Japanese data shows that it's very important to coagulate the vessel.
Yes.
Outside the stomach, not so important.
Yeah, because the incidence of delayed breathing is quite low.
Yeah.
In the colon and esophagus, we don't have any data
Open.
to reduce
Yeah.
delayed
Open.
breathing.
Close.
But the stomach prophylactic coagulation is definitely reduce the risk of delayed breathing.
Yeah.
So we usually do that.
So you're very, very meticulous. Not these, they are tiny. Where else? Even this little one here?
Yeah.
Do that?
Small.
This?
Small vessel.
These?
Yes, this.
Open. Close. Open. Close. Open.
Sometimes a large vessel will be behind,
Ah.
underneath this.
The small vessels, yeah.
So you should coagulate.
So that one as well, there?
Yes.
What's he saying? Dr. Bhandari?
He's saying sometimes behind these small vessels there's a large vessel.
But you're not catching hold of those.
No, once you coagulate this, you'll see the other one.
So basically,
So, to me, I think everything is coagulated. But can you see anything else?
It's okay.
Yeah? We're done. So that's our morning marathon is over finally.
thank you. Congratulations.
Thank you very much.
Thank you. Big round of applause for Dr. Bhandari and Dr. Abe, please. Did anybody time your procedure? 6 hours 31 minutes.
I don't think so, but maybe not too far from that. I need to go and lie down now. Yes, this is a very difficult case for me.
Ma'am, are you back with you, ma'am?
Yes.
So we're tempted. Well, probably we're going to stop, but we keep seeing something that we think might be it. So we tried almost going after almost target, but we really are not finding it there. We're just debating right now if we see something in front of us here. Not kind of probe it and see. Here.
Doesn't appear to be a.
You want me to dissect this out here? Except that it's not really
just
lifting
a
very
little
much
bit of
anymore.
separation here.
Huh?
This fibers.
Knife out? So I just want to inject knife in. I want to inject.
What is that? I think we are going out mucosa.
I think this is that mucosal bulge that you're thinking. Knife out. A little bit hesitant to dissect this out because I think it's very close to the mucosa.
I think
You
we
think
should
this
just
is
leave it.
submucosal?
Yeah. Just leave it for now, I think.
So I think what we're talking about doing is basically just achieving hemostasis, and then we'll come back and repeat the EUS at some point. Oh, unless it's here. It could be that. I don't think this is it. So I think that we're going to stop and just make sure there's no bleeding and then close the tunnel
probably what I think is it's probably all intramuscular. There is no submucosal component. That is why we cannot
Yeah,
find
that's
it.
another possibility, that it's completely within the muscle, and that's why we're really not
No, but
seeing it.
Pankaj,
Yeah.
I find it hard to swallow because two things. You saw it on endoscopy, number one, and the patient complains of dysphagia.
The patient complaining of dysphagia?
Yes.
What? We didn't get you, sir.
No, you saw the tumor on endoscopy.
Yeah.
And you are still seeing it on endoscopy. And patient complains of dysphagia.
No, but here inside we don't see any bulge in spite of such extensive dissection.
That we appreciate.
Yeah.
That is, dissection has been fantastic. Congratulations.
Well, are there any thoughts from the audience about
No,
where...
they were all, we were all lost.
Yeah, it is a pity that could not...
This is
the only
right
idea
here,
which came-
here is... Oh, what about this?
You see a bulge.
It's all the mucosal aspect which is just coming in.
This is what we were thinking was more of a fold,
Yes.
because it's so long, it's so continuous. Unless it's right, unless it's this.
No, it's the same thing which is just continuing up.
Every time we think that, then we follow it, and
Yeah.
it continues all the way. So I think hemostasis has been achieved. So we should just close the tunnel now.
Yeah.
Well, a lot dissatisfying.
Thank you. Wonderful dissection, Otto. Thank you.
Yeah, thanks.
Can I get clips, please?
Clips. There's a mucosal lesion there.
This is where where we were doing the suctioning. I don't think it's broken, but I think it's a little bit.
So maybe apply clips that.
Let's first close the tunnel, and then we'll go back and do that.
What was that?
Yeah, we're just looking. So when I was inside the tunnel, there was an area where I was suctioning fairly aggressively. And so I think this is that. We're just trying to see if there's an actual defect in the mucosa.
I don't think so.
I don't
It
think
is
there's
just
a defect, but...
That you'll see better from the mucosal side.
It's like a diverticuli, yeah.
Okay. So we'll just close with clips. Clips. So same principle as with the poem, we'll put the first clip on distally to act as our anchor. I don't think this incision is quite as long as the clip is attached. Clip out. Where is it? Okay. And is this a rotatable clip or? Wait, just wait. Just wait.
Auditorium.
Open?
Yeah.
Dr. Pankaj will be leaving you for a few minutes.
Yeah.
We are starting a series of lectures.
Okay.
Right?
So we'll be starting with the first talk by Dr. Michel Calais.
Dr. Amol?
Like all this work, I mean.
Dr. Amol?
They need to this is like the
Dr. Michel?
about to be delivered. You know? She's
I would
about
like-
to be still, let's do C-section.
Yeah. I would like to thank the chairpersons and would call upon the new set of chairpersons. I will request Dr. Jaising Sinde, Dr. K.K. Rawal, Dr. Sunil Jain, and Dr. Gajanan Wagolikar to chair the next session.
Michael running. Just a second, sir. We're just waiting for the set of chairpersons to take over.
Ready.
Okay.
Yeah.
Sir, you're on.
Okay. So it's a pleasure and honor, as I said. You know, I want to thank Amol again to organize this fantastic conference. So I've been asked to talk about POEM complication and management. So there's a talk on POEM, so I'm not going to spend too much time on the technique, and you've seen one live case. I cannot emphasize enough, all accessories need to be ready and available before starting the POEM. The number one issue is you need to have CO2 available. Without CO2, the rate of pneumothorax increased by 30%. You need to have the right endoscope, an endoscope of approximately 10 millimeter diameter to decrease the risk of injury, obviously, but you need to have a decent working channel to be able to operate. A lot of people, you're still using overtube. I don't use it systematically, specifically when you have people that have short neck. I try to stay away from the overtube. So the cap is crucial. It allows you to dissect into the tunnel to see where you're going, so you really have to choose your cap very well. In terms of instruments, in a way, as you know, like the triangular tip knife, Amrita was working on that during that tunnel. And the coag grasper is your best friend if you have a big vessel that is bleeding. Also, we can use clips or available. The setting are quite crucial. As you can see during the POEM that we did, like 2 hours ago, approximately, you need to have the right settings, the Endoscopic effect 2, break coag or kind of force coag can be used also 50 watt effect 2 or 3, depending. When you're dealing with the bleeding, you need to shift to effect 580 watts with the coag grasper. That's a very important thing. When we talk about adverse events, we have to remember there's a lot of adverse events that have been described, and really it goes from very rare, such as aspiration, capnothorax, full thickness incision in the mediastinum, that's really, really rare, bleeding, bleeding that you cannot control, because bleeding happened during the procedure, but at the end of the day, is one of the things that we're going to deal in a lot. CO2 retention, capnoperitoneum, and mediastinal exposure. So exposing the mediastinum itself is not an issue as long as you close the tunnel. So this is a very nice study that comes from Norio Fukami team, where they decided to look at all the POEM that were published within the last 7 to 8 years. We're talking about 115 publications. They focused specifically on complications. They really ended up, with a very small amount of study that dedicated their education on complication. So the adverse events that we're talking about that have been described are basically all the complications related to the mediastinum or the peritoneal cavity. Number one being pneumo or capnoperitoneum. Number two will be pneumo capnomediastinum. Very rare pneumo with capnothorax that can lead obviously to pneumothorax. Very rare aspiration pneumonia, and of course all the cardiovascular complications. Bleeding arriving was described in up to 7.2%. AFib was described in 5.5%. And there is, of course, the post-operative pain. So Norio Fukami team was actually very smart into trying to understand how bad the pain was, when was it, and how can we treat it. So if you can see, based on their data, the pain is mild to moderate. It's never really severe. The number one time that it happens is right after the point. And that as soon as they are in the PACU, it kind of decreases and it kind of stabilizes for 24 hours on the hospital floor. And what they recommend, obviously, is a combination of narcotic. Try to cut down as much as you can on the NSAID because you're always scared about bleeding. So really, it's narcotic, short-acting narcotic, until you get through that very tough phase. Now, if you compare, for instance, this is one of those studies from China looking at comparing POEM to Heller. This is nothing to do with the amount of pain medication that is required when you do Heller. So yes, there is pain. Yes, the pain is mild to moderate, but it's nothing compared to the pain of Heller,
We have to remember that. So this is the settings in our unit here at Cornell. You can see that we work just like Inoue. We come from behind the patient, above it. And so we work from above all the way down to the EJ. Another thing that we've been using in the United States, this is a combined study which includes both New York Presbyterian Hospital, Cornell in Columbia, but also our friend from Latin America, where we started using optical coherence tomography to look where the vessels are to try to avoid large vessels, and we really decide on going anterior versus posterior based on the vasculature. Although I have a preference to go posterior, if optical coherence tomography show me a lot of vessels posteriorly, I will actually still go anterior. And this is really our GPS that we have now in our unit. Optical coherence tomography really allow you to speed up the procedure, because if you can avoid the area where there's a lot of vessels to coagulate, you can do the procedure faster. So talking about complication, I wanna go over this video here. If you just start. Starting. Video is not starting. I want to show the video because it shows you all the things you can do when you're dealing with a complex case. We can actually just fire it from here directly. Yeah, but I want to talk about how the closure. So basically here, this is a case that I wanted to show you, because not only it goes over the technique of stir, but also it shows you what to do when you have a very complex mucosal closure to deal with. Okay. So you can see here by EOS that the bump that you see in the lower esophagus is a gist. This one was actually easier than the one that Rita was doing, was right above the AG junction. The biopsy came back positive, some for spindle cell and CKIT positive. And the patient declined surgery, and to be honest with you, the location was really horrible for surgery. So we decided to offer the patient a stir technique. It's one of the largest lesion resected using stir technique. I think that the largest one right after that is the one from Amit Mateo. That was close to 6 centimeters. This is close to 7 centimeters. So going over the different techniques that you can use, obviously, we decided to do stir. The position is perfect for that, above the junction. You can see the bump very nicely, confirmed by EOS, confirmed by OCT, and then, just like Amita was saying, 5 centimeters above the lesion, we start a tunnel. As I said, we try to do a wide opening, and then you're going to slide into the tunnel, and you're gonna try to stay as close as possible. I think that the hybrid knife is a great instrument for this. Coagulation is crucial. Just like Amita was showing you, you have to make sure the vessels are dealt with. And then as you advance, you can see a bump that comes from the muscularis. This is really the way you can detect where the lesion is. Sometimes the bump is not as obvious. So what we're going to do is we're going to use a succession of instruments. You know, we use the dual knife, we use the cryo grasper to expose, but in this case, the gist was adherent to the mucosa. So it was impossible to do this without a mucosal defect. So what we decided to do actually is to use the mucosal defect to our advantage. We push the lesion into the stomach. We cut it from the rest of the mucosa and we get it out. As you can see, it's a pretty extensive lesion. And now one more time, the purpose of this talk is to talk about how we deal with complication. So when you have a large defect, like the defect that I just showed you, it is imperative to close it. So we decided to go with suturing. The suture actually goes all the way across the ED junction. But one more time, you have to think about how can you get the patient out fast. There's only one way I think you can do this safely. is to actually put a stent. So in this case, we decide to stent the patient across the EG junction, and just to make sure the stent doesn't migrate, we actually suture the stent, and that really allows us to send the patient home faster. That's really key. So that's basically the key technique. And if I go back to my talk here it is. The general rule to deal with complication, number one, avoid the complication. Prep before the case. Make sure you have CO2. Get your settings straight. Have a team that know what they're doing. Use the right accessories. You need to have very strong anesthesia that will be able to do rapid sequence intubation. Aspiration pneumonia is a reality in those patients that have achalasia. Be very, very aggressive in providing needle decompression. We needle decompress now in the majority of our patients. It makes the patient more comfortable doing the procedure, even after the procedure. It makes the procedure smoother, and it makes the anesthesiologist much better. Actually, the heart rate of the anesthesiologist decreases with decompression of the patient. So if there is any bleeding, you don't close the tunnel. You only close the tunnel while all the bleeding is under control. Any mucosal breach should be clipped. When there is large defect, you can either use clips, suture, or the Ovesco clip or the Aponos clip. You need to have something that will really close. I like suturing whenever it's posterior, because the needle of the suturing device comes out posteriorly. I prefer a clip when it's anterior. And of course, combine with stenting if needed. My conclusion when you're dealing with foaming complication, foam is clearly one of the most attractive options for treatment of achalasia. It requires a dedicated team. It's becoming an alternative to lap heller, and I truly believe it will replace lap heller. Most complications can be held endoscopically, and if you have the occasion to use optical coherence tomography, I will highly recommend this because it helps reducing bleeding. And this is my advanced fellow who's just reached her first poem. As you can see, she's very, very proud. That is probably one of the most exciting things in our field, to be able to train the next generation. Thank you for your attention.
Thank you, Mr. Very nice talk. I like the general rules. Very important. Now the topic is open. The floor, if you have any questions to ask from that side?
Michelle, in absence of OCT, how do you decide anterior or posterior myotomy?
Yeah, I mean, that had depended, first of all, on what technique you are the most comfortable with, and number two, what kind of scope you have. In Latin America, for instance, there is a limited amount of institutions that are using Olympus. So most of the time you have Pentax or Fuji. The knife on the Fuji and on the Pentax scope comes out posteriorly, which basically lead you to prefer a posterior approach. So with Olympus, the knife comes out more centrally, so you can go either way. But if you are dealing with Pentax and Fuji, I highly recommend to go posterior.
I have a question. If you have a pneumoperitoneum, you can always do the needle decompression. Suppose you have a pneumomediastinum.
Yes.
Sometimes even the mucosal closure also becomes difficult. Did you come across like this?
Pneumomediastinum is not as dangerous as pneumoperitoneum. So you really have to have a lot of pneumomediastinum to have effect. Pneumothorax is obviously a problem. And you will encounter some patients that have a non-significant pneumothorax. Non-significant pneumothorax is any pneumothorax that's less than 20 to 30%. Most of the time the patient oxygenation is fine and he has no problem. The big problem that you see is when there is a tension pneumoperitoneum. Really, the blood pressure is dropping, the heart rate typically is higher, the CO2 retention in the blood increases, and the anesthesiologist becomes typically very nervous. So this is where you have to be extremely aggressive and fast and provide needle decompression. The risk of needle decompression are insignificant. They're less than 1%. You really have to be extremely unlucky to have a large vessel. So I would highly recommend in your practice to incorporate needle decompression. Not only it makes the procedure smoother, but also it makes the post-op of the patient better.
Any particular choice of clips that you would like to use? Same clip, or the first clipping you would use a different kind of clip? Any
Very good question. I like the clip that can rotate. And nowadays, in the United States, there's 3 clips that rotates very well. The first one is the 360 from Boston Scientific, which unfortunately is very expensive. The second one is the large clip of Wilson Cook. And the third one is the second generation clip of Olympus. I think in terms of efficacy, they're pretty much all the same. We have to admit that the latest generation 360 clip of Boston Scientific rotates very nicely. The other 2 clips are probably very similar, but you really need to have large clips to be able to grab both lip of the opening. And
did you ever have rebleeding after mucus close, late night? You have to come back and do something like that?
So this is why you don't close the tunnel until the tunnel is completely clean and not a single vessel bleeding. There have been cases described by a Korean team of basically a hematoma into a tunnel.
A closed compartment.
Yeah, so basically what happened is the patient probably had a delayed bleeding, and the bleeding wasn't enough to basically cause a hemodynamic instability, but it was enough to fill the tunnel, okay, with a hematoma. This was managed conservatively. It was managed conservatively with antibiotic and NPO with parenteral feeding for a few days. But I think if you have active bleeding, you do not hesitate to control the bleeding, even if it means going back into the tunnel.
Thank you, Michel, for your nice talk and wonderful interaction. Thank you. Thank you. Very basic.
So we move on to the next class in this poem master class session, and this will be delivered by none other than our own Professor T.S. Chandrasekhar, and he will be talking about the basic of poems, that is including indications, pre-procedure management, and also the choice of instrument during poem.
There is going to be some overlap. Already Michel has covered some of the points. And I must thank at the outset Dr. Amal for this, for organizing such a wonderful, exciting third space endoscopy program. And he's got a very wonderful setup. You must all of you come and see here. And after seeing all these advanced procedures, I feel the talks may look superfluous because basics, but very important is basics going to be the foundation. And it's a master class, indication and choice of instrumentation. Some of the instrumentation you already discussed about this. And I was lucky enough to see the progress of this piece here. Easily what kind of instrument we are using and now the kind of instrumentation, how it's quickly developed is a very interesting to note that. I think all of you know about achalasia. And the most important thing is sometimes the diagnosis can be delayed. Even psychiatrists will see such patients. And Professor, just to show in action how he on term defined the poem by dividing the circular muscle layer of the lower esophagus. Now again evolved, he started cutting the longitudinal muscles also. I think we had a discussion about this. And we need to have the most important thing is you can't make a guesswork and start doing the poem. You need to have the manometry, very important, high resolution. Timed bariums all very important. You want to know how effective the procedure has been, very important. Of course, endoscopy not only for diagnosing and ruling out pseudoachalasia, diagnose and to know the diameter, it also dictates the kind of procedure you want to take. Is very hugely dilated or it is not grossly dilated, and pseudoachalasia, you want to make out apogee endoscopy. I think all of you are familiar with the type 1 achalasia. type 2, and type 3 is little less common. And I always think this is the reverse. And some of them will have very early stage, maybe type 3. Muscles are still contracting and the lower sphincter is very tight. And type 2 may be little lesser contraction, and type 1 no contraction of the esophagus body. But all of them, all three of them will have the pressure in the lower sphincter. Why is so important? Because this is I borrowed from Mohan. I was discussing this is own experience. And type 3 definitely poem, there is no doubt, because you can have a longer myotomy, younger patient. And poem is advantage is very, even in a failed balloon dilatation, Heller's myotomy, sometimes with a difficulty, botulinum injection also you can do that. But those who don't have facilities, the balloon dilatation is still being practiced, type 2 and 1, elderly, and the esophageal lumen is not grossly dilated. Where we stand for Heller's lap myotomy is type 3 and 1 younger. This is still evolving, no final data is available, and we need to have more data to tell you that where exactly the poem is placed. Now, right now it appears that younger patient not grossly dilated and failed cases from other procedures. Checkup and type 3 is very important thing for the poem because we can cut longer. And I just want to tell you how the conventional treatment failed and poem is very useful. Prior botulinum toxin injection will be very challenging. I discussed with my colleagues also. I had 2 patients where botulinum injection given elsewhere and they were in abroad, and I had to do poem. I had really difficulty junction dissection. The surgical Heller's myotomy, challenging dissection but excellent efficacy if you are able to carry out the procedure. For end-stage achalasia, I just want to read it along with you. Patients with severe sigmoidization megaesophagus respond poorly to Heller's myotomy, may ultimately require esophagus. This lap Heller's myotomy poem appears to cause minimal adhesions, and therefore it should not significantly affect subsequent esophagus. Very important statement. The third one is, could be considered as an initial treatment in this patient with esophagectomy, reserved for those with inadequate clinical experience. I had 2 patients in my series esophagus. With a careful dissection, we could successfully carry out the poem. So what matters is not the, it's only the relative difficulty may be there, but if you are able to define properly and refine technique, you will be able to do it very comfortably. Poem in children and the elderly. The youngest reported is 3 years and the oldest is 97 years. So poem can be done in extremes of age. But more than the indication, everyone knows the contraindication I want to tell you. Coagulopathy, doses of the portal hypertension, platelet count is less than 50,000, and submucosal fibrosis such as irradiation and ablation therapy and EMR and severe pulmonary disease. The contraindications for poem. Operative evaluation is very important. Of course, ECG is very important to find out any abnormal movement and to rule out pseudoachalasia. Time-to barium esophagogram for the prognostic point of view. High resolution manometry to type the achalasia. Cardiopulmonary evaluators, pre-procedure anesthesiologist evaluation mandatory. Sometimes we need to do CT and US to rule out when you are doubtful cases pseudoachalasia. I think some instrument, I just want to tell you that already you have been very familiar 180 or 190 series, or the equivalent of Olympus, maybe the 9.9 diameter with a 2.8 channel diameter. Initially we were using triangular tip, and the triangle tip from Olympus. Now Olympus has come with a TTJ also. So here it can mark, incise and dissect, and you can't inject it. And diathermy we have discussed enough with the settings and other things. So nowadays 600 series is also available, you can do comfortably, and there is a mode available, particular mode for poem mode itself available. You can switch on that mode and go ahead with this. Instrumentation, a flushing pump is very vital because you want to compress the bleeding vessels with the water jet And this is a wonderful equipment, we have that. And a carbon dioxide insufflator is a must, without which you can't proceed. And nowadays we don't use the balloon dilator. When they started their career, some of the workers, they started using to submucosal dissection, the dissection, but now no longer balloon dilatation is being used. The other instrumentation, hemotype applicator, I think Dr. Mishra has told about. This one equipment may change the entire procedure, shorten the procedure, because you can inject, you can incise, you can dissect. This was lacking in to start with a triangular tip Olympus, and it is freely available methylene blue. We don't use the indigo carmine. The other accessories are the distal hood attachment. I think we specified during the workshop what should be the thing. So beveled type is very important, not the regular circular type. And the quiet grasper, without which you can't proceed. Large vessels need to be grasped with this. This is Olympus. And the Y connector. Sometimes 190 series you may not need the Y connector. And 180 series if you have that Y connector. And this is not a sphincterotome. The needle knife is sphincterotome. You want to do the incision. And sclerotherapy needle, some authors we use that. We routinely use a sclerotherapy needle to make a submucosal bleb. Then we'll have a needle knife, the knife incision. After that we proceed with the TTA or the hybrid knife for dissection. Olympus initially had TT spray catheter. Now they have the TTJ knife, so it does all three functions. But right from RB they had a hybrid knife. It can do three functions, early and RB jet also. So it shortened the procedure. So multiple equipment usage is not necessary. Many areas you need to shift it. The advantage of hybrid function, no change of instrument, preparation of medium, and mechanical and thermal protective function. The risk of bleeding is minimized. So I can conclude now. I told you about this is safe and effective procedure and technically demanding, but it can be made safe and effective because instruments quickly evolved, offering good margin of safety. That's very important. Thank you very much for this.
Thank you, Dr. KSC. It was an excellent talk. We welcome one or two questions from the audience.
Yes, is it true that the cost will be lesser if you use Olympus accessories?
Yeah, definitely. Because the hybrid knife, they have the RB jet, that is the one cost in the cartridge. That usually costs around 30,000. So when we are using RB, the cost was little higher. And we started the Olympus kit, the cost can be minimized. There's no doubt about that. But the comfort level may be little higher with the hybrid knife. There is also, so the quality sometimes, the comfort level goes with the cost also. Any question? Any other question you have? I think if you have any more question, Mohan is coming to give the talk on the various other aspects of
There is one question from the audience.
Yes. Yeah. While some more question is being posed, Mohan from AG Hyderabad is going to talk on precautions and the technical steps.
Question from the audience is Heller's myotomy with salvage procedure.
Yeah, that's what we can do poem, no problem. Technically may be a little difficult, but if you have the expertise, we can do that. Okay, now Mohan Ramchanan is ready with the talk.
Good afternoon. Am I audible over there?
Yes, you are audible.
Okay. So, Anand is setting up my laptop for the presentation. My aim is to give you some of the very practical tips then as a beginner, how you are going to approach this procedure, which is really fascinating. And as an endoscopist, doing POEM not only it helps to improve your endoscopic skills, but also it as an endoscopist myself, I have grown a bit towards surgical side. Now I am able to manage more complication in my own routine endoscopic practice. So POEM not only helps you to develop the skill in POEM itself, but also makes you more braver and more aggressive in managing your day-to-day other clinical cases, including say perforation during colonoscopic polypectomy or massive bleeding during EMR. So these are no longer major complication for us as we are growing and doing more of POEM cases. So third space endoscopy has definitely brought this advantages to us as an endoscopist. So we'll be speaking about this, and also after this case we'll be showing you a live case of POEM also. And during that we can discuss the minor tips which are there for the refinement of the technique. I know many of us have started doing, and many of us have different approaches for doing POEM. Some people are doing anterior, some people are posterior, some people are using different quadri machine, different quadri setting. So there is no the technical guidelines available what is best. What I feel is that the way you are being trained, you can continue to do that, but it is important for us to be versatile. Like if you are doing posterior, you may not be, you should also do anterior in between, because one of the extension of doing POEM is to do stir, like removal of tumors, which may come into a different angulation for you. So if you are well versed with posterior myotomy, then suddenly if you get a stir on anterior direction, then it is difficult for you to orient yourself. So it is better for us to keep on doing cases in different directions. So there is no yet data available which the technical aspect, whether the clinical success is better with anterior or complications are more in one particular orientation. Till that our data emerge, we should be doing POEM in different aspects, because our aim is not only to learn POEM but also to get well versed with the anatomy and to identify the planes, the mucosa, the submucosa, the muscle, and we should know any problem. So we will be just quickly be ready with our scope, with our presentation. Some problem in. So meanwhile, till that time, any questions from audience we can discuss regarding this procedure.
Mohan, some people are using inverse. What is the advantage of that?
I don't know, because some people may come up with their own technique, but as long as you are okay with longitudinal incision, because our aim should be to have a proper closure. So what I feel is the proper closure can be done very easily by available technique in India is only longitudinal incision, because it is sometimes difficult to close a horizontal incision by clips. But if you have endo sutures available, you can close any type of incision. But for in India, there is no endo suture available, so it is we only bank upon the endo hemoclips available for us to closure. And I feel the longitudinal, clean longitudinal incision is the only way where we can close this incision properly. I have not heard about this reverse T incision. The advantage and disadvantage may be to get into the incision, but I will tell you the technique of how to enter into submucosal plane once you do a longitudinal incision. And once you follow that technique, there is no chance that you may not be able to enter into the tunnel. But I feel in inversely, the horizontal component makes the entry into tunnel more spacious, and then you can enter into the into the tunnel very easily. No, but videos won't work. No. Huh? That.
Question is how to control the bleeding at G junction.
Yes, that's a very important question, because it is not only for us to control the bleeding, but also to preserve the mucosal integrity. And once you are working at G junction, the mucosa is very, very close to the muscle side. And at that point of the time, you have to decide whether the bleeding is very profuse. So, if at all possible, if the bleeding is minor, or if it is from mucosal side, I try to avoid cautery using, because if you use cautery on mucosal side, it causes lot of injury over there, and ultimately there will be a hole into the mucosa. So at that point of time, what I do is I go in with the shaft of the scope, stay into the stomach, and then try to stop the bleeding by the tamponade itself. But if the bleeder is on muscular side, then you can liberally use the electrocautery on the coagulation mode, and ultimately you are going to cut the muscle. So using the cautery at the G junction on muscular side is not at all a problem. It is only the mucosal side. So if the bleeder is on mucosal side, use very little cautery, or if at all you can leave it, you can go further into the tunnel and try to stop the bleed by tamponade.
People have sometimes used Sangstecken balloon to prevent the bleeding post.
I don't think, we never use balloon, because the bleeding is never so massive. There is no massive, so the best is to use lot of spray of water, so that you can go directly and pinpoint the bleeding site, and then hold it with coag grasper. If you use balloon, then balloon needs a space forward also. So if you are talking about a balloon tamponade, like in Sangstecken tube, then it was not required in any of our cases of, say, last 600 cases. So it is virtually, I think, theoretical to use Sangstecken balloon for bleeding. And in POEM, the bleeding is never hemodynamically a hemodynamic problem. It is the problem that the blood usually trickles down into the submucosal plane, and then it makes the planes more dirty, and then you may not be able to say which is submucosa, which is muscle, or which is mucosa. So that problem needs to be solved. So it's not a hemodynamically problem, but whenever possible, use lot of irrigation and stop the bleeding by using coag grasper.
You use regularly this to know the junction. Is it mandatory?
Say it again, Dr. Rawal.
To know the G junction, whether you have crossed it or not, in your center, IITV is always used. Is it mandatory?
No, I am not able to hear again. Can you say it again?
In your center, why do you use IITV to know that you have crossed the G junction?
No. See, that again I will show you in my talk, that fluoroscopy is not at all mandatory. But since we started doing POEM on a ERCP table, and then because it is just a push of pedal, and then you will know that you are in quite deep into the stomach, that is it has become like our habit. But if you follow the some principles, how to identify the G junction, how to go into the stomach, you never required a fluoroscopy for this.
Not working, can we take few questions?
Yeah, what we'll do is, we will go to the live. Patient is already sedated. So Mohan will come back and give the lecture. Okay? Is all right? We'll move into the theatre.
Okay.
Thank you, chairpersons, and we move on to the live. I would now like to invite the chairpersons for the live session, Dr. Jaising Sinde, Dr. Malay Sharma, Dr. Nitin Behel, Dr. Utkrant Kurlekar, and Dr. Suhas Wage. I would like to invite chairpersons for the live session, Dr. Malay Sharma, Dr. Nitin Behel, Dr. Utkrant Kurlekar, and Dr. Suhas Wage. Please come on the dais.
Okay, so here we are along with the live session, second session. He is a 36-year-old male with no comorbidities. Past history of poem was done. Along
Dr. Lalit Chimpi to please join on the dais.
Past history of poem was along with pyloric dilatation was done in August 2016. His dysphagia remained. He became alright of dysphagia, but pain in abdomen and recurrent postprandial vomiting persisted. Endoscopy was done, which showed that the LES is possible, but food residue in fundus after 12 hours of fasting with tight pylorus. Gastric emptying study was done, which was suggestive of type 2 gastroparesis with 35 retention of contrast. So we are going ahead with poem. Over to Dr. Michelle Kali.
Good afternoon. Very happy to be back here with this amazing case. So the procedure we're going to be doing, which is basically the GPOM, is obviously inspired from the original poem in the esophagus. But I want to insist that there's a couple of things that are different. The first thing is in the stomach, you really can get lost. The stomach is not like the esophagus. It's a big organ. And one of the biggest problems you do when you do the GPOM is not to get lost. So the couple of things we do. Number one, we're going to try to find exactly where the pylorus at. It's around 75, 76 centimeter from the dental arch. So we're going to basically make a tunnel of approximately 7 to 8 centimeter, no more than that. So to avoid getting lost into the stomach, I typically start by injecting a little bit of normal saline mixed with indigocarmine from the pylorus backward up to 7 centimeter. Out, please. The needle. Okay, so I'm going to do a kind of like a trail inject. Here it is. Nice. Okay, we're going to do one more here. Here. Inject. Okay. Let's do one more. Out. Here. Inject. Here it is. You need a nice little pathway. Keep it out. Here.
Market your tract
Yes,
of
yeah.
the direction.
Yeah, so, because you don't want to get lost. So we're going to obviously be in and out of the tunnel a lot, but we also want, once we are in the tunnel, to kind of keep ourselves out, please. Inject. Here it is. Okay, and then here, out, inject. I do 7 to 8 centimeter max, so let's see what we got now. Here, we are around, in the long position, around 80. So starting about here will be actually maybe another 2 centimeter out, please, the needle.
Because this is a relatively new
Inject here.
procedure. What are the kind of patients that often come to you for GPON?
Well, this is a very, very good question. So I actually predict that we're going to be doing much more GPOM than we're going to be doing esophageal. So you have to select your patient very nicely. Inject here. Because the best patients are actually the iatrogenic people that had an injury of the vagal nerve. Those are the best patients.
Those surgical patients?
Yeah. For patients that had a vagal nerve injury from previous surgery. Okay, can I have the T-knife, please? Gastric prep patient, if they have a vagal nerve injury, may qualify. I think it's very important to remember that we're dealing with a problem at the level of the pylorus or at the level of the pacemaker. So my best patients are patients that either have idiopathic gastroparesis, vagal nerve. The worst population is actually diabetic. I will not do a diabetic gastroparetic unless I have a normalizing hemoglobin A1C. Because if you don't have A1C under control, it doesn't matter what you do, nothing's going to work. So I always enter a contract with the patients and make sure that they do actually they do control their blood sugar out, please, before I offer them any GPO. Out, the needle. Needle out. Okay, good. So, the opening here is different. It is a horizontal opening. Here it is. I'm going to inject a little bit here. What's happening with the, can we fix the, yeah? So I'm going to open horizontally here, and you will notice during the procedure that the secret of GPOM is lateral opening, lateral spread. If you don't open laterally correctly, you will loop and don't progress into your tunnel. So that is very important. That's one of the biggest difference with regular POM. How are we doing here? Trying to fix the injection. See if we can cut some more. Oh, we can, yeah, that's good. So its opening has to be horizontal, as I said. Still waiting for a ability to inject, that's very important. Okay? Trying to purge. Really? Okay. Okay. What's the...
Hello. So we will like to shift to OT5 for next case for a while. Yeah. This is a case of 52-year male who presented with dyspepsia and retrosternal bulging for 2 years. The Endoscopy revealed a nodular lesion with central punctum, but there was no increase in the size of the lesion in last 2 years. The histopathology of was NET and chromogranin A level was 537. US showed heterogeneous predominantly hypoechoic lesion restricted up to layer 3, and CT abdomen showed arterially enhancing small nodule in medial wall of first part of duodenum. The plan is to go for ESD or EM. Over to Amol sir.
Hello.
Michael, sir.
Hello. Am I audible there?
Yes, yes. You are
Okay.
audible. Yeah. You are on.
So this is a patient with a duodenal neuroendocrine tumor. The chromogranin is high. You can see the lesion. It's in the duodenal bulb. One of the tricky areas where perforation is more. There's a risk, higher risk of perforation. So we just contemplating just now, Pankaj, Harshal, myself, what would be the best approach? Whether we should do a cap EMR because it's not as big as it, as you thought it would be. So we can probably try and do a cap EMR. So let's see how it works. So what I'm going to do is I'll first inject. So that goes without saying. And in the duodenum, the other thing is you can also have a delayed perforation. So there is a school of thought that you may want to do a primary closure. So for that, we also have a full thickness clip which is available, the padlock clip. So we'll just try and show that also probably. Give me the needle. Okay, eject. NEDs don't lift very well. That is one thing. Keep the needle out. Keep the needle out.
दिखाने के लिए Do you always recommend to apply clips or close the defect in duodenum?
In the duodenum, I would be more inclined to do that. Unless, the dissection goes very clean and I am 100% sure. See, not just the perforation also, the other thing is bleeding. Delayed bleeding is also very common because it's in a high acid environment. And so delayed bleeding is quite common. So clips will also prevent that.
In duodenum, it is better to close the defect.
Yeah.
That is what we should, I think, convey.
What I'm going to do is, I'm going to put the snare and see if I can get it in. If I can get it in well, then I will hold it and I will apply. One of the risks of trying to do an EMR in this situation that you may transact a lesion. And then you may not get a good margin. So that's the only risk. If I feel that I'm confident that we've got hold of the entire lesion, I will do that. Otherwise we'll come back and we'll do a incision and then take it up.
Hello,
okay, open the snare.
Hello, Amol, Dr. Wagner here.
I am not using the regular cap for the cap EMR. Okay, enough.
Hello, can you hear me, Amol? Hello, Amol?
Yeah?
Am I audible?
Yeah.
Yeah. How reliable is this lifting sign you feel in EMR?
See, in the sense, reliability in the sense of what?
That the lesion is not going
Hello?
that the lesion is not crossing through the muscularis propria. You said it is easy to
Hello?
lift the you said it is easy to lift the duodenal this duodenal lesion.
We can't hear you.
We can't hear you. I don't think I am audible there as well.
Rajan,
you are audible here. Amol, can you hear us on this mic?
Sir, are you able to hear us?
Yeah, we are able to hear you.
Yeah. Reliability in terms of what?
One second.
When you are doing a EMR, you would allow the lesion to be lifted easily, isn't it?
Yes.
So now if it lifts, how sure you are that it is not crossing the muscularis propria, or if it doesn't lift, how
Okay,
sure
this
you
can
are?
cross. This can cross. Duodenal, particularly duodenal bulb lesions, they are notorious to have a deep adherence to the muscle layer. So you may catch hold of the muscle layer. So that is the reason you have to be very careful. And the other thing, you should have a plan to close the defect and even the full thickness defect if the need be. The patient is also consented for a, in case there is a full thickness perforation. So that is there.
Would you go with EUS in each and every duodenal lesion, or you?
Yes, we would do an EUS before actually planning. There. So here it definitely shows that it is in the submucosa. Okay. Now open the snare just a little bit. Open the snare just a little bit. What I'm going to do is I'm going to suck a little bit more. Okay. Close, close, close. This seems to be pretty much there. As the blood pressure, okay, the blood pressure is around 96 systolic, so that's good. Okay, now I'll apply.
Submucosa.
Submucosa. Okay, so let's see what we've done. Let's get this out first for histology.
What current do you use? You use endocut? You try to use coag to prevent bleeding?
No. I would use endocut and then go in again and do a point coagulation or put a clip. In fact, in the duodenal bulb, I would prefer to have mechanical hemostasis rather than the diathermy, because the risk of delayed perforation is higher if you do too much
coagulation, yes. So these are a few small things which are different in duodenum than in maybe in stomach or
preferentially use clips for hemostasis in the duodenum. So let's see what we've done now. Okay.
Oh, there is a small leak there.
Huh?
There is a small
bleed there. You think there's a leak as well?
I think so. Just where there is Kali, just where the bleed is.
No, what I'm going to do is I'm going to apply a padlock as well. Padlock only. No, the padlock will also cover both. Because I don't think there is a...
We have lost the video. We lost the video here. Amol?
Yeah?
Yeah, we lost the video here.
Okay, they're getting it back.
Okay.
Can I have a small grasper? So the small grasper.
There's a vessel, I think. There's an artery.
Amol, I think
because otherwise it's going to keep bleeding until we apply load the padlock and go in. It's going to cause a big clot over there, so I don't want that to happen.
I will agree with
the other thing which you need to do is very often you need to come back into the stomach whenever you are exchanging your accessories.
I will agree with padlock, Amol.
Huh?
I think you should apply a padlock clip.
Yeah, we will.
No, we will. Open.
Just, this is the artery, so we'll just take care of it first.
So don't you think both can be included in the clip? The artery also?
Open. Huh? No, then it will burn through. Open. Close. Open.
I don't think there is a...
Do you think this vessel will come within the clip? No.
Close. Open. Close. Okay, open. Okay. Close. After this, okay. Okay.
क्वाइट कर दे.
Rajesh, you need to do this first.
Not doing it. You should do it more, yeah.
The bleeding seems to have stopped now.
Yeah. Bleeding seems to have stopped. Now that we've done coagulation, now we'll bring the scope back and we'll go into the padlock clip. Are you shifting or are you continuing?
Yeah. You can shift for 2 minutes and come till we load the clip.
Okay. Unless they want to see the loading of the clip.
Amul sir,
No.
can we move on to the next set and come back to you, sir?
Yeah?
Can I say your mic on, sir? Naresh sir, your mic on, sir?
Nice, huh? Okay, good. So we're having some issue here with the injection. So we switch to another knife, the T knife from Olympus. Inject here until we inject. Until we get the T knife up and running. Okay, inject here. The needle has to be in when you do that, right? The needle is in. You see there's a fiber here. Okay, I'm not sure about this needle at all. I'm not sure. I'm not. Can you put it in? It's a problem that you have to constantly put in. That you have to constantly have to be in when we inject. It's very disturbing, actually. Something that you have to get used to, obviously. So while we're fixing the knife.
Sir, can we move on to the next set and come back to you, sir? Amal sir, are you back with you, sir?
Okay. Okay, so we've already loaded the padlock. I would just like to show you this. Can you focus here?
Can you show the external view?
Yeah.
We switch out the light here.
Okay, so this is how, it's like a EVL band cartridge, and you can see the spikes over here. So this is how the clip looks when it is loaded onto the cartridge under the distal end. And when it fires, it is a star-shaped clip. So it closes as a star shape. So it just causes a purse string. And these spikes actually go into the tissue and hold the clip together. And one of the advantages of this as over the Ovesco is that the deploying system is outside the scope, alongside the scope, using this clip wire. And this is the handle over here which Rahul is holding. So that your channel remains free. In case you want to use an additional instrument to grasp the tissue, you can do that through the channel. Because otherwise, when you are using the Ovesco, you have to use a double channel scope. So we'll go in again.
What is the disadvantage? What is the diameter of the clip?
See, I think the clip comes in two diameter, two sizes. The upper GI one is 11 millimeters and the lower GI one is I think 16 or 17 millimeters.
18 millimeters.
18.
18.
16, yeah. Takagar says it's 16, so I don't know. You can check it out with the guys at the booth. Probably.
So it's a little smaller than the OSCO clip.
Yeah, OSCO comes in three sizes actually.
But
this is a little bit tricky because to get across, what you need to do is now come face on. I have a possibility that I might fall back. Someone hold the scope here. Okay, now that you've got the defect, okay, not yet, yeah. Okay. Now I'm going to suck, okay. We've got a big bleed there, but nothing to worry. I think we'll just fire off the clip in a moment. Okay. Okay, suck.
it is okay. Fire. Yeah, I think it is fired.
Yeah, put it open there.
Fine, fine. Gaily, clip gaily. This is applied.
Yeah.
Even the vessel has come in.
Yeah, even the vessel and everything, it catches hold of everything.
Yeah, we'll just take the cap out and maybe go in again with the scope.
And then go in with the scope, then it will.
Then we can see it
It will be
properly.
see back.
Suppose you have a larger lesion and
Yeah.
the defect is small enough. Scope is not going to entire thing, then what do you do?
You use you take the central part where actually where the defect is. Or you can use more than one. And that's also there.
But then also you'll have a little gap is there in between.
How cheaper than your OSCO?
Much cheaper.
Much cheaper. Much cheaper than the OSCO.
Cut. You have to, I think, use a knife blade and cut it.
No.
This is made in India.
No, it's a American product actually. They are marketing it in
Marketed
India.
by a company in India.
The name Padlock.
Padlock. Godrej padlock.
I asked whether it is
It is Indus Medical, I think, from
Okay, so that's the clip now underneath. Those are the spikes that you can see.
imported by. How long do you keep the patient nil by mouth? One day?
I would
2 days?
probably, start the patient fees tomorrow. Yeah.
See those spikes. Can you see that spikes?
From the clip.
Yeah, we can see it quite clearly.
Right.
And there's a good bit of tissue inside. So
Yeah, I think that's a good job done.
yeah, good.
The clip is also very good. Effective, you can see that for hemostasis, because even in a DUP, you can just go there, suction, and irrespective of the fact that whether even if there's active bleeding, just fire the clip and it closes the defect very well. Thank you so much.
Amol, how much does this, there's a question from the floor, how much does it cost?
I think it's much cheaper than the OSCO clip. I think the company has a booth outside, so you can go and check them out and ask them the prices, because you've got the two variants, probably there will be a
$300.
price difference in the two sizes also. Okay?
Thanks,
I think
Amol.
we'll move to the next room.
Yes, sir.
Thank you.
Sir, your mic on, sir. Mic.
We are not able to get the audio here. Anand?
Sir, just a minute.
Yeah.
Now, did this patient have any Botox or anything? Because there's a lot of scarring for some very weird reason. One session where that's because there is some scarring here. That's, okay. Yeah. Is that? Well, it's tough. It's yes, some scarring. So we have some issue with the knife now. We finally are under control with the knife, trying to separate the epithelium from the muscularis. I'm having some issue doing that, obviously. Knife is like. It's very important to create a plane between the muscularis and the epithelium. I'm having some issue here, creating that plane, obviously. So from time to time you have to check the belly, make sure the belly is fine. You can see here that we've been having a hard time separating the epithelium from the muscularis. So here there's really no secret, you have to inject until you have some kind of a split. We're injecting here, trying to, the ice is right there, not separating very well. There it is. I try to cut those fibers. Inject some more here.
The areolar tissue a little tougher here in the south.
Yeah, but in this case, it's usually not as hard. It's a little bit tougher than the esophagus, but this is unusually more difficult for some reason. We're trying very gently to find that third space. A little bit more challenging here.
Now we are presenting the new case. It is a 40-year-old lady presented with dysphagia and regurgitation for 6 months. Upper J endoscopy suggestive of achalasia cardia and esophageal manometries suggestive of type 2 achalasia cardia. Now we are demonstrating the technique of the poem. Over to Dr. Ram Chandani.
Okay, good evening.
Good evening, Mohan.
Yeah, so now we'll demonstrate another technique of poem, and in this technique we'll be demonstrating the anterior poem. Okay, so the first thing which we decide is the length of myotomy. So to decide the length of myotomy, you have to at the G junction, and you should have the manometry report in your hand. If your manometry report is telling it is type 3 achalasia, then it will require longer myotomy, maybe 15 to 20 centimeter. But if it is type 2 achalasia, then a 6 centimeter myotomy is required. Now in this technique, the poem is done in a flap wall technique where I'll show you. So this is the GE junction at 40 and you come 6 centimeter proximal to it, that is 34. So this is the, from here I will start the myotomy. But I will give a 2 centimeter of overlap, so 2 centimeter more proximal and 2 centimeter of mucosal incision. So by the rule of thumb, you have to add 4 centimeter to your intended myotomy length. Now suppose you are doing 6 centimeter myotomy, you have to add 4, that means you have to come 10 junction. So the GE junction was at 40, now I will start at 30. If I want to do a 15 centimeter in spastic esophageal disorder or type 3 achalasia, then I will add 15 plus 4 is equal to 19, so I will come 19 centimeter proximal to myotomy. So this is about the length of myotomy. The second important thing you have to see is what is anterior and posterior. So you can see a bulge of vertebra on at 6 o'clock position. Is it clear? The vertebral bulge, can you see?
Yeah, at around 7 o'clock.
Yeah. So that is 6 o'clock. So this is at 5 o'clock and just bang opposite to this. This is anterior, this is posterior. So this is anterior. So we'll go at 30 centimeter anteriorly by this. So this is 30 centimeter and this is anterior at around 2 o'clock. Here I will inject. And injection required, so I'll start injecting beforehand. So can you inject? So once we inject and then pierce, the saline will find the least resistance path and that will be submucosa. And so once you get an adequate bulge over there, you can stop. And then the second step, so now adequate separation of mucosa has been achieved. So now I'll show you a technique for beginner. This is not for who do day in and day out, because this will require many accessories. So this is for beginners to be safe. Now in this flap technique, you need to cut the mucosa and preserve the muscle behind. So if you make an incision, a small incision using needle knife like this, out. So I'll use this needle knife to make a small incision here. So I'll try to choose a avascular plane here. That is my needle. This is where I will make an incision. So I'm using a different cautery here. So you have. So that is the small mucosal incision I have created. So the important thing is you should know the depth, because if you cut and you are not able to see those bluish fibers, that means your depth is not adequate. So once you create this mucosal window, then you use this IT knife. Now IT knife will go directly into this, like this, inside, and then you have to push the scope downwards and you have to cut. See that? Just cut. And then you assess that whether it is adequate or not. Should be around 1.5 centimeter or slightly more than the cap. See that? Still I want slide one shot more. And once I do that, then I am ready to enter into the submucosal tunnel. But don't hurry, no hurry. So I will use now the TTJ knife, triangle tip J knife. Okay. So here, if I try to enter it now, without doing adequate submucosal dissection here, I will increase the mucosal incision. So what I do is here, is try to dissect the submucosal loose areolar tissue from above only. Like this, not injuring the muscle. just go lightly in and try to dissect here. And if you want to deposit some saline here, inject here, so that is the pocket which I will go inside, but I am not hurrying to go inside. I am just trying to make some space for myself by removing these very, very superficial fibers. Then I will see whether I will be able to go inside or not now. Still I can see the muscle at anterior point, but still I am not very sure that I will be able to insert this. So in such situation I use sometimes the inject here. Okay, so I am trying to create the space so that I can make some dissection over there out. So this dissection is important. I am not hurrying to go inside, because if I hurry too much, I may enlarge this mucosal incision. So I am just trying to dissect there. And now I will see whether I am able to get inside. Now I am able to get inside there. And you can clearly see the, so I am using the spray here. It's very high. Yeah, so you have to make it slightly lesser. This is a new spray for me. So I am not, but it's quite good. Yeah, but you can slightly lessen it. Yeah. So now the anatomy should be clear to everybody. So this is the loose areolar tissue of some mucosa. This is the circular fibers of the muscle. And here at 6 o'clock is the mucosa, which is the forbidden area for me. So I will do dissection right in this arc only. And the most important thing is, don't work too much away from you. Work very closely. So see that my cap has stretched the fibers, and I have removed my finger from the air-water channel. So there is no air at all. It is my cap which is making the distance, which is important, because ultimately, if you inject too much of CO2 there, you will have capnoperitoneum or capnomediastinum. So to avoid that, the first thing which you should do is to use ultra low flow CO2 tube, and then use your cap to to make the proper dissection like this. So you use your hand. And I am not even seeing the mucosa here. Mucosa is here. So it should be well away from the mucosa, and your dissection, your knife should point toward the muscle, because if your muscle is injured, there is no problem. But the mucosa should, the perforation in mucosa is defined as perforation of the mucosa in achalasia, because the disease part is the muscle and the healthy part is the mucosa. So mucosa will be the ultimate barrier between the mediastinum and the lumen. So you have to protect the mucosa. So you can clearly see the circular fibers. Is it clear? So that circular fibers, I am making an artificial imaginary line so that I go downstairs, always perpendicular down. If you are dealing with a sigmoid esophagus, this technique may help you, because if you make you can see clearly the circular fibers here, and I am going an artificial, imaginary vertical line downwards. Gradually the dissection is going down in downward direction. And here I feel the mucosa is coming too close to the muscle, so here I will inject. So I'll get the blade inside, and with using the same knife, we can inject here so that the saline and indigo carmine is deposited inside the submucosal space. And we again have now adequate separation between the muscle and the mucosa, and our dissection will continue towards downward direction like this. Like this. So you can see the edge of the muscle over there. You just aim at there and dissect. Again, using the cap with minimal use of CO2, you keep on dissecting like this. So fluid is slightly darker, so I may miss any vessel which may...
Mohan sir?
Yeah?
Can we move on to the next set and come back to you, sir?
Okay.
Alright, sir, your mic on.
So the problem with this patient is subscarring, which makes tunneling extremely difficult. So we had to really struggle to get in. And now finally we're in. It's a very difficult tunnelization. Sometimes you can see that with people that have ongoing chronic gastroparesis or people that have Botox injection. Typically balloon dilation doesn't give you so much scarring, but you know, it's more the manipulation with Botox which is the #1 problem. But I think we finally here are into the tunnel after a lot of struggling. You know, this was a very difficult tunneling.
How many G poem you have done?
I've done a total of 50 now.
50?
Yeah.
What was the common indication?
Well, I tried to select them based on an idiopathic indication, because I think those are the best. And of course, if they have a iatrogenic indication with suspicion of vagal nerve injury, those are very, very good. Those are the best.
They are the best. Vagal nerve injury?
Vagal nerve injury are the best.
Yes.
Idiopathic,
You have a diabetic gastroparesis?
I want the hemoglobin A1C close to normal or normalizing before considering this, because you can do whatever you want. If you're not controlling the sugar of the patient, that means that your GP will not function.
So you don't do it in organic obstruction?
I'm diabetic. I need to make sure that the diabetes is under control.
Diabetes under control. In spite of that, the patient has got gastroparesis.
Yeah, because if the sugar is not under control, you can do whatever you want. It's not going to work.
What are the common problems you encounter? G poem and compared to esophageal poem?
So I think they're similar. The other issue where you can't get in, because it's very difficult to separate the mucosa from the muscle. We're going to try to see that where we are here.
The stomach is difficult to split compared to esophageal?
I mean, it may be difficult when you're scarring or Botox. So you see here, we started the tunnel. This particular was difficult.
Otherwise, poem...
This particular case was difficult. You see, I had a hard time entering here, but I finally was able to tunnel. And you see, we have to make sure we keep the direction towards the pylorus. So you constantly have to go in and out, you see? And now we know that we need to focus on a little bit more to the right side.
Which is more demanding, esophageal or gastric?
I think the tunnel of gastric is harder.
Harder?
Yeah, it's a little bit harder. I mean, with the esophagus, you can only go straight. Here you can really get lost if you don't pay attention.
Creating tunnel in stomach is difficult.
Yeah, a little bit more difficult. You have to constantly make sure that you're going in the right direction.
The other way, the setting of the diathermy, the equipment, instrument, everything is same.
Everything is the same. And you tend to start the myotomy the other way around, because you need to focus your myotomy on cutting the pylorus, obviously.
Thank you, sir.
6 centimeter from the pylorus?
Yeah, 6-7 centimeter, and you definitely cut the pylorus first, and then another 3 to 4 centimeter max towards the entrance.
How many centimeter you go beyond pylorus?
Oh, you stop at the pylorus.
Stop at,
because,
not like esophagus.
No, because
beyond G junction you go.
Otherwise you are in duodenum.
Oh.
That would be a
Stop
problem.
at the level of pylorus.
Yeah, you cut the pylorus and then you're done, basically.
We are parallelly seeing the poems going on in the other room. So
Yeah,
the areolar tissue in the esophagus seems to be more loose and kind of easier to dissect than that in the stomach.
That's what Dr. Michael is telling about it.
And not particular in this case, but overall, generally it looks.
Generally, he's telling creating tunnel in the stomach is much more difficult, particularly more so in this case because this patient has got a kind of scarring.
Yeah.
In fact, he had to really go beneath the mucosa in a harder way. You could find out he was literally sweating.
Yeah, it was. I was sweating.
Sweating.
I think sweating is a good
Morning
word.
you said you were sweating, but you were not. But today I saw you sweating.
I totally was. Yeah.
Huh?
Yeah, this was much harder than the other case. Absolutely.
In terms of bleeding, Michael, which is esophagus, you get more bleeding.
Well, there's some large vessel. There's some large vessel in the stomach.
The stomach is a more vascular rather than
So you have to be very careful.
So generally, G poem is more difficult in terms of creating tunnel. And number two is you encounter large vessel in the stomach. But you have to be very careful. Is thicker esophagus muscle, the muscle layer is thicker or the gastric muscles?
Oh, the gastric layer in most cases is a bit thicker. Absolutely. Oh, yeah.
Gastric muscles are more thicker. So that also may encounter some problem in that. Huh?
Enough to have just a clinical suspicion and endoscopic confirmation of gastroparesis, or you would go ahead and document it with a mobility study as well?
You are telling 50 cases, the commonest indication is idiopathic gastroparesis. I don't know how often we come across idiopathic gastroparesis. How many of you in the audience you come across idiopathic gastroparesis?
And how do you document it?
How do you, what are the diagnostic criteria?
It's the diagnostic of exclusion.
Right?
It's diagnostic of exclusion.
Exclusion, number one.
You have to make sure the patient is not diabetic, that he doesn't have iatrogenic injury of the vagal nerve. You have to make sure you're taking anti-narcotic. The biggest trap is to do a patient that is taking narcotic. That is a no-no.
Narcotics, no?
Yeah, those are the worst patients.
Do you do a nuclear scan or what are the...
I think you systematically need to do a gastric empty study because that's like a gold standard. It's like the manometry of the GPO, if you want.
There is a question from the audience.
Manometry of the?
Of the GPO.
GPO.
So you have manometry, which is the gold standard before doing
gastric pyloric junction manometry.
You need to do a gastric empty study, absolutely.
You got a point from Dr. Michael. He says diabetes should have been under control. There should not be any organic disease. The patient should not be on narcotic drugs, number 3. Number 4, historical evaluation. Then documentation with the nuclear scan or manometry, GPO manometry.
Yeah.
So gastric pyloric manometry needs to be done. So
Dr. Chandrasekhar, there is a question from the audience.
Yeah. What is that? May I know who is chairing the session? May I know who is moderating from that side? And what's the question from the audience? Is it over? Yes.
There is a question from the audience saying that if you are not crossing the pylorus while doing G-poem, how is it going to if you don't cross the pylorus and go across into the duodenum while dissecting, how is the patient expected to get a benefit?
No, you have to completely cut the pylorus. I mean, you don't get into the duodenum, but you cut the pylorus. That's what I mean.
You don't have to get into duodenum, but you have to completely clear all around pylorus.
Correct.
So all around
you have to do pyloromyotomy, basically.
The question they are asking repeatedly in E poem, esophageal poem.
Yeah.
You do the.
You reach the fundus almost.
Across the G junction, 2-3 centimeters you cut it.
Yeah.
But here you don't do that.
And do you have any specific landmarks to identify that you have done completed the pylorus?
I mean, in the regular poem, can I have a correct grasper? You're gonna cut through the EG junction into the stomach. You're not going to cut into the duodenum. You're going to see that you are basically facing the duodenum. You're going to have the correct grasper, please?
It's a big vessel.
You're going to see that you are basically injecting the duodenum, and you're going to completely cut the pylorus. Like literally, are bleeding it. So you'll be facing the small intestine, but you are not open. But can you get a cut?
Can you go to the next room and come back
Close?
here?
Yeah, sure, close. Okay, open. Close. Close.
Huh?
Open.
Started little this room, huh?
Close.
This room, huh?
Like that. Open. Close.
Mohan sir, are you back with you?
I think I have finished.
On your back here.
Okay. So now we have finished the tunneling. I will show you, this is the tunnel, and this is the muscular side, this is the mucosal side, and you can see the only important thing which I wanted to tell you was how to identify G junction once you are into the tunnel. So this is the narrow part here, and also you can see these are the palisading vessels of G junction. You can see the mucosa, the parallel vessels. So these are the G junction vessels, and also once you get into the cardia, you see the muscular vessels. These are spindle vessels. You can see those spindle vessels, especially at 11 o'clock position. These spindle vessels are very classical of gastric cardia vessels. So that means that your tunnel has now gone into the gastric cardia by 2 to 3 centimeter. So this is for sure the gastric cardia, the spindle vessels on the muscle, and these are the palisading vessels of the G junction. So pretty sure that we have gone, but still if you are not sure, you can come back into the lumen. Come back into the lumen like this. You can see the mucosal incision over there. This is the lumen part. And you can see the bluish discoloration which we have caused here, and that has traveled down at the G junction, and then we retroflex it. And you can see this bluish discoloration of the blanching of the mucosa. Is it clear over there?
Yeah,
Is it naive case or already done some?
Naive case. So this tunneling part has now extended into the gastric cardia also. So now we have the step which was to separate the strip of the mucosa away from the muscle, right from the esophagus, has been completed. Now we can cut the muscle and we will not injure the mucosa. So this whole exercise is to separate the mucosa away from the muscle. And then we will try to find out where is our mucosal incision.
This bluish discoloration you showed G junction nicely, no?
Yeah.
This should be on the lesser curvature or greater
No, if
curvature?
you go anteriorly, it will go towards lesser curvature.
And the
Posteriorly, it goes towards the more of greater curvature.
So that's a very important point Mohan has done in the anterior route. So you could demonstrate along the lesser curvature. But some of you may be doing through the posterior route. So that will be along the greater curvature.
So now what will we do is, we will cut the muscle. But cut the muscle from where? So you have to identify the lower edge of the mucosal incision. So this is my lower edge of the mucosal incision. So I will not cut the muscle from here. I will give a 2 centimeter gap here up till here, and then start cutting the muscle. Because it will be ultimately a flap. So even if your mucosal incision is not airtight closed, the muscle behind it will be intact. And there will be a 2 centimeter of mucosa and muscle intact. So this is how the Sumiyama described the mucosal flap wall technique to actually be, because otherwise you can do through and through muscle and mucosal resection. So that is not very safe, but people have described that. So I am now cutting the muscle by spray coagulation. So I am just trying to spray, make it spray.
Mohan, some people start from G junction, muscle cutting.
No, then you will be lost. The planes will not be as good. So I am just trying to see that. So I'll just grab these fibers here and cut downwards.
How many
like
attendees
this.
in the auditorium are doing
And
poem
then
procedure?
you can see those longitudinal fibers over there behind. Is it clearly visible over there?
How many of you are doing poem procedure in the auditorium? How many of you are doing anterior?
I'm not able to hear.
You are not audible from the auditorium.
Can you see the longitudinal fibers behind?
Anterior, how many? Posterior?
Unfortunately, your audio is not.
Partial thickness, how many?
No, Dr. Mahadev is just taking audience
I'm
count
just
of
taking
who is
audience
doing
poll about their experience of poem. So how many are doing full thickness myotomy? How many
They are asking,
circular, only circular myotomy?
How many, when do you do full thickness myotomy?
Partial thickness, how many? Partial.
Amit, your voice is not audible here. You are not heard. Can you tell the audio people that?
Actually,
AV people that?
Now can you hear?
Slightly better than.
Now can you hear?
Yeah, okay. What's the question, Amit?
No, I'm taking audience poll.
Yes. Okay.
Just asking how many are doing poem, how many anterior, how many posterior.
Can you hold up?
Then also asking what is their preference of full thickness or partial thickness myotomy.
Okay. You tell us the result.
Till now, 60%, 70% are posterior myotomy. And majority of them are, I think, full thickness myotomy.
What is your take, Amit?
That is exactly what I do.
Posterior. That means you have influenced this crowd much.
Posterior myotomy and full thickness
And
myotomy.
this crowd is, the audience is mainly from western part of India.
No, not necessarily. They are from the whole country.
The whole country, but predominantly, I think you have created very nice impact here. Posterior and full thickness.
But you know, TSC, now even Dr. Inouye, who started doing the anterior technique, he's also started the posterior now.
I am very comfortable with the posterior approach, Amit.
Very good.
Because I always think that heart is close to me in the anterior. And the posterior, only the mediastinum is there.
You asked a very pertinent question just now to Mohan.
Yes.
Why not start the myotomy from the OG junction and start coming up?
That's what I asked him.
So are there any situations where you have to do a distal to proximal myotomy? Mohan.
Suppose sometimes what I feel is that if the G junction is very tight and it was very difficult for you to insert the scope inside, then if you come outside, then sometimes the mucosa is so close to the muscle that you may injure the mucosa. So at that time of the point of the time, sometimes I do that, but mostly I follow the one algorithm that is, and you can see the nice planes over there. These are the longitudinal fiber which have been preserved, and this is the anatomy of circular fiber over there.
Yeah, but Mohan, if you see your picture there, you can see the pleura outside, right?
Yeah,
or the heart, pericardium?
Yeah.
So that means your longitudinal fibers are also splitting.
So that, Amit, you will agree with me, these fibers are nothing but like strings.
Correct.
You know, so they are just hanging. So as soon as you insufflate CO2 over there, they start separating. So you can never cut the longitudinal fibers because they are spread all across the circumference.
Correct.
You can separate them.
You are only splitting them.
You are splitting them. You are not cutting. You can cut the circular fiber, but you can only split the longitudinal fiber. So it is, I think, is a placebo effect of, say, doing a circular or longitudinal myotomy.
In effect, all are full thickness myotomies.
Yes,
Because
this,
when you cut the circular, longitudinal automatically separate. Because of the rubber band effect. Now sometimes there is a situation while doing poem that you have done a tunnel, but the submucosal space is just not opening because the muscle is very tight. In that case, you start from distal to proximal. Once you start cutting the muscle, the space will start opening up. And then you will start seeing the muscle.
Normally, Amit, you start from proximal to distal or distal to proximal?
Proximal to distal.
Okay. Now, myotomy first technique, sometime in cases where you said, no? That time myotomy first, huh?
What?
As you said, the space is very narrow, then you cut the muscle.
Then you do distal to proximal, cut the muscle first from distal so that the whole space starts opening up. And then you can get a good plate to start.
My machine is not working. CO2?
Yeah, increase the effect.
So that is important for having good cautery machine. But since now, still not. Now it's some effect is coming. Now it is cooking. But okay, so stop. So see that I have applied lot of power on muscle.
Said 1 and 2
but had this been on
centimeters.
mucosa, I would have been very, very careful. Okay, so this is the bottleneck.
It's not
You can
exact
see-
centimeters.
See that
In
bottleneck?
type 1, you should do minimum myotomy on the esophageal side. Lower esophageal sphincter and stomach remain the same for all three types. But because in type 1, esophageal body peristalsis is already not there, you should not do a long myotomy. Do a short esophageal myotomy. Type 2, do a medium length esophageal myotomy. Type 3, do a long esophageal myotomy.
What is medium length and long lengthy?
Medium length is 7 to 8 centimeters. Long length is 10 to 15 centimeters.
That is for
And
type 3, no?
Type 3. And type 3 is 15 centimeters myotomy.
15 centimeter.
Usually, because you have to cut the entire length of the esophagus.
I mean, suppose if I have bleeding coming from deeper,
yes,
not from muscle, then is it a concern?
Yes.
How will you?
No, not a concern. Usually this is because as the muscle separates, there are some horizontally traversing perimediastinal or periesophageal vessels.
Okay.
And these are the ones which are bleeding. So usually you will find that vessel just below the muscle cut edge.
I just want to ask you, safety profile wise, anterior better or posterior better?
No, there is nothing like that. Safety depends upon the operator.
It depends on the operator.
The one who is doing the procedure. It's like driving a car. The safety doesn't depend upon the car, upon the driver.
Now we have reached to the G10, and then
The same
suddenly there
patient-
can be a give way, and it can hit the mucosa. While if the muscle is at here, 6 o'clock, you have to lift and cut. So there is less chances of
Posterior
mucosal
myotomy.
injury.
Then you do anterior myotomy. Yeah.
So the mucosal injury may be more if you are a beginner and doing anterior, because the control is not there.
You know, TSC, as endoscopists, we are those who perform ERCP, they are used to elevate the elevator, of a ERCP scope. So when you do posterior myotomy, we hook the knife below the muscle and elevate it towards the submucosal tunnel with your big wheel. So therefore it becomes a little bit more easy and natural.
Actually, after several thousand ERCP, it becomes automatically easier for the posterior approach.
Yes.
That's what I realized it.
Yes.
But Amit, I don't know whether you agree with me or not. If you cut the posterior fibers, you also cut the sling as well as clasp fibers. And there are reports that the posterior may be associated with more reflux because we are not doing any anti-reflux procedure here. While anterior myotomy, you cut only clasp fibers and preserve the sling fibers, which are important for maintaining angle of his.
Yeah, for that, you know what we do, Mohan? During posterior myotomy, when we go to the OG junction,
Yes.
instead of going straight down at 12 o'clock or 6 o'clock,
Yes.
we go a little bit to the right.
Okay.
And that is how we don't cut the sling fibers.
Okay. So that technical aspect needs to be told.
But I want to ask both of you, the surgeon, they cut the sling fibers too.
But they do amyloglycation also.
And they say effective amelioration of the symptom because of the sling fiber, they cut it.
So akinesia cardia is an incurable disorder. So you have to make a balance between LES pressure reduction and also prevent the GERD, the reflux. If the quality of life becomes bad because of GERD, then no point in doing reduction in LES. So there is a debate whether to do anterior or posterior. The studies are ongoing, which will tell us that the adequacy of relaxation is better with anterior or posterior. Simultaneously, the long-term pH studies are required to show whether the reflux is more with posterior or anterior. So to have an equal clinical success with anterior and posterior and more reflux with posterior, then anterior will be preferred. While if the reflux rate and clinical success are equal, then it depends upon the they can do.
For beginners, what do you recommend? For beginners,
can you make out while doing the procedure the clasp fibers and sling fibers?
No. You can't make out during the procedure.
Amit?
Yeah, you can hear me?
Yeah.
During procedure, you can't make out these fibers. But the anatomy, if you just visualize the anatomy in your mind, the easy thing to do is as soon as you reach the OG junction, start taking a right turn. Then you go automatically on the lesser curvature.
So this is how I cut the last fibers of the muscle where there can be chance of bleeding. So you can see now, by the time I have completed, the longitudinal fibers are gone. And I made it sure that I don't cut every fiber longitudinal, but by the time I finish, it is almost like full thickness
It's like
myotomy.
a full thickness myotomy.
Full thickness
Yeah,
myotomy,
exactly.
yes.
Exactly.
And then this is the end of the tunnel.
So
and then you
very
go,
nice, very nicely done, Mohan. Very nicely done.
And then you can see, thank you Amit, and your words, meant a lot for us. You are such a great teacher for all of us, and your even a small word of appreciation means a lot for us. Thank you.
Is there any modification in technique when you are doing post Hellers or post fundoplication, or you continue with the same technique? Are there any tricks of trade there?
Could you get the question?
What is the question?
If there is a fundoplication done already and recurrent achalasia, and then you are going to do a poem, is there any modification in technique necessary at all?
So you can take a chance if you are very well, because since we started doing anterior, and we know that Heller's myotomy is done anteriorly, and theoretically there will be more fibrosis in anterior plane. So theoretical choice is definitely posterior to start with, because you will not find submucosal fibrosis. But say out of 10 patients of post-Heller's myotomy, you will be still successful doing anterior myotomy in 8 patients. We have data on that. But in 2 patients, you may require a rescue tunneling, that is to do posterior. So if you start with, you can do posterior, but if you don't know posterior at all, then still you can try the anterior one. So now you can see the LES reduction pressure, you can see that how well it is going. There is no resistance at all, and there was no bleeding into the tunnel. So now our aim, we will close this mucosal incision by using hemoclips.
Mohan,
yes sir.
You see some of this mucosal ecchymosis in the tunnel, in the lumen, along the tunnel. Some areas on the mucosa you can see redness, maybe a little bit of thermal injury. Do you need to bother about that, or you can just leave it?
No, not at all. So this can be because of repeated passage of scope. Thermal injury usually cause blanching, but this type of reddish spots are because of repeated passage of scope, especially once you are doing demonstration close.
Or maybe staining due to the blood also, no?
So first clip I apply on the normal mucosa, so that it creates, see that if you see this type of wide, you will be bit afraid. But if once you apply this, it creates a sort of a tent for you, a tunnel elevation, and then you can close this mucosal incision using this subsequent hemoclips one by one, and like a closing of a zip. Okay. So again, go back to the base of the first clip and apply here. Apply. That's all.
So we'll be shifting to OT5.
So I'm using the therapeutic scope, and the beauty of this is that if your accessory is out through the accessory channel, the suction still is very strong. So if you use the normal diagnostic scope, when the accessory is this is out, then your suction don't work. And here you can see the suction is very, very good.
This is a double channel?
Not double channel.
Mohan sir, next set is ready. Can we move on the next set and come back to you, sir?
Okay. There is a question.
Yes.
Mohan.
Yes.
That this ecchymosis of the mucosa, does it happen because of the spray mode? Because of too strong a spray mode?
As you saw,
Dissipation of current.
Spray, it is not towards the mucosa at all. So we spray only on the muscle part, but you can see the ecchymosis. This is the tunnel part, and this is the ecchymosis here, bang opposite it. So there was no spray here, but because of repeated passage of this cap, you can see here. So on the right at 3 o'clock also, which is the behind part of the tunnel, there we can agree with the spray coagulation, but what about at 9 o'clock? It was not there. So this patient can have a tendency because of the repeated passage of the scope, it has occurred.
The important message is that if you see such type of things in the mucosa, don't get scared. There's no need to apply a clip on it.
Bhavan sir, can we move on the next step and come back to you, sir?
Okay.
Yeah, thank you, sir.
Here is the case of 26 years. This is a case, 26-year male, known case of Peutz-Jeghers syndrome with recurrent sessions of upper GI and lower GI.
Thank you, Dr. Lalit Simpi and Dr. Suhas Wage.
Recent colonoscopy showed sessile
Thank you for
polyp
chairing
in
the live
sigmoid
session.
colon.
And I would like to
Now
request
the plan is
Dr. Vikram
characterization
Bhatia.
of polyp and EMR or ESD accordingly. Over to Bhandari, sir.
Dr. Mahesh Thomre and
sir, your mic on,
Dr.
sir.
PC Dalai to please be on the dais.
Sir, your mic on, sir.
Yeah, Ajay, are we on?
Yes, sir. Yes, sir.
Vikram, can you hear us?
Yes, we can. We can.
You can hear us?
Yes. yes.
Okay, so this youngish gentleman with post-sugar polyps previously has had multiple polyps removed in the upper and the lower GI tract, and now he's got a fairly big one there in the distal colon, the sigmoid. And Pradeep is trying to look at it and see, does it make any sense on NBI?
Yes, I mean NBI is showing you like a villous pattern there, but this is not the classical pattern that you see in a typical adenoma. So to me, on NBI, this doesn't look like an adenoma. It's likely to be one of those juvenile polyps. And the surface and vessel pattern of those juvenile polyps is not very well described. But what it does tell us is sort of a semi-pedunculated polyp. And these polyps, juvenile polyps, are quite vascular. So that's what the thing that we need to think about here is we are in the left colon around 15 centimeter. It's a vascular polyp, so the risk is more about bleeding than perforation. Of course, perforation is always a risk when we do anything in the colon, but that's the thought process going through to say how do I minimize my risk here. So I would try and inject and lift this.
Pradeep, we got some tiny little polyps just below that. Can we just characterize that for the audience and show them what kind of, are they hyperplastic polyps? And can just get...
There are a few more here, I think.
Yeah.
There.
So can you get the NBI on?
Yeah.
Yeah.
Okay, so that's a classic hyperplastic polyp there. It's more vascular than what you should normally see, but if you look at the pit pattern, these are very broad pits, which you don't see in an adenoma. The adenoma pits are very compact and small, so you can easily confuse this as 3S, but this is not 3S, this is type 2 pits. So that would be a hyperplastic polyp for me.
Dr. Bhandari?
Do you agree?
Yeah, I agree, absolutely.
Dr. Naresh?
Yes?
You told us this is a patient of Peutz-Jeghers syndrome, but then we see a solitary polyp in the colon, which doesn't look...
Now there are multiple small polyps all across, and this is the only large one that we have seen in the distal colon, and he's got some rectal bleeding, I believe.
Yes.
So the idea is to...
No question, we remove it. Doesn't look like hematomatous polyp though. Mostly Peutz-Jeghers are multiple.
The classifications that have been developed have been largely for hyperplastic and adenomatous polyps. The other polyps have actually, no one has studied them or characterized them enough for us to think. So you could actually look at a juvenile polyp and it looks so vascular that you could mistake it for an adenomatous polyp just by looking at the vessels. So there are some shortcomings of the nice classification and whatever, including that of serrated polyps. We do know that serrated polyps are significant, but we tend to classify them as type 1 nice or hyperplastic polyps. So similarly, these are things where still we do make mistakes because we have not factored these polyps into the classification.
When we look at the surface, it does look like villus and gyrus pattern to me superficially. So why do you suggest this may not be an adenoma?
Well, it looks like an adenoma, but it might not be, because it's slightly unusual for that pattern. But its significant size, it does need removal, so we'll focus on resection. One of the other things I wanted to highlight to the audience is, if you haven't done a lot of injection, there are two techniques for injection. One, when you are very early in your injection learning curve, we teach our fellows to start injecting outside the mucosa, and you push inject. So as soon as you hit the right plane, you'll get a submucosal lift, and then you know you're in the right plane. The other is, which I use, is you push the needle right in, and then you inject and start pulling the needle back. So as soon as you hit the plane, again, you'll get the lift. So I'll demonstrate today the push injection technique. So
Okay, Pradeep, before you start that, why do we need to do that in a polyp like this? What are we trying to do and why are we trying to do it?
That's a very good question. This is almost pedunculated but not pedunculated. So you could potentially, and because you're left colon, you could potentially do a snare resection without injection. But to me, that's still not as safe as doing it after injection. So I prefer to inject. Also, the injection has got a little bit of adrenaline. It's a vascular polyp, so it will cause some spasm, so there won't be immediate big bleed if there is. But that never reduces your delayed bleed, so you need to be conscious of that.
Okay, if you had a nice peduncle, would you just lop it off just like that, or would you still take precautions? What are those indications that you still take precautions of using some other technique to minimize bleed?
That's a very good question and a very practical one, because we see a lot of pedunculated polyps. What we feel is, if you have a pedunculated polyp which is more than 2 centimeters in size, then they are generally big. They'll have a big vessel in the pedicle, so the risk of bleeding is very high. In those polyps, we could do a variety of things, but for us the preferred technique is we inject a little bit of our injecting mix with adrenaline in it for two reasons. One is the adrenaline will cause some vasospasm, so if there's a bleed, it's not a big bleed straight away. And the second is, if you do get a big bleed and everything is covered in a pool of blood, that blue injection tells you where the problem was, allows you to get back to do some therapy in a big mess. That's why we prefer that, and it's very simple to do. Some people use endoloops, and that's also a very effective technique. You can put an endoloop. It's a little bit fiddly. The endoloops have got a very long tail.
Very floppy, very floppy.
Yeah, and can be very annoying at times, so we don't like it.
When would you use a clip?
We always use clips. If we do use a clip, we use the clip after polypectomy.
Not prophylactically?
No. I find it very disappointing to use before. And also, putting metal clips at the base, then cutting about it, it can cause conduction of current in all different ways. So I try avoid doing the clipping before.
So just to again go back to a point, suppose a young gastroenterologist is doing a polypectomy. Does he need to be always armed with clips and endoloops and things like that for a routine polypectomy, or can he say, these polyps I'll safely do, these polyps I need to have a setup that's, because this is a situation in India where everyone is not really armed with all these.
That's very, very, very practical, very, very good question. I'll highlight two things. One is, we published a lot on a system called SMSA system, where we use size, morphology, site, and access. So you look at 4 things in a polyp: the size, morphology, site, and access. Based on that, we give a score, and that tells you which is a high-risk polyp, which is a low-risk polyp. And that's why we're promoting our fellows, that when you are training, you only do SMSA 1 and 2. When you've done more than 1,000 colonoscopy, that's when you do SMSA 3. And SMSA 4 are almost like surgical polyps, which are done with very few experts in the country. But to put it simply, polyps less than 10 millimeter or less than 8 millimeter, flat ones can be very easily resected by cold snare. Very easy, no risk, and job done quite well. Pedunculated polyps, I don't think you need loops or injection or anything. Just put the snare at the right place and use forced coagulation. Very slow, forced coagulation.
Cook it well.
Cook it well, and then you don't get any problems.
What is the size of the pedicule? I mean, would that be a factor that think?
Yeah, thick pedicles can be a big factor because sometimes the coagulation doesn't go through the thick
There may be
pedicle.
multiple vessels
Yes.
in a...
Naresh.
Yes?
Let him proceed with the procedure.
Okay.
Needle out. So what I'll do is inject the push technique. So start injecting now. And I'm going to push there. So I hit the plane and you get the lift. You just stop there and you try and achieve adequate lift in one prick rather than multiple pricks.
What is the trick that you had to get? Just
and stop. Thank you.
What helped you sort of find that plane?
So it's just that he started injecting before I pushed the needle in, and then you slowly push the needle in. As soon as you hit the submucosa, the lift starts. So that's very good for beginners who haven't done a lot of injection.
1 minute. 1 minute. There's a question from the audience. Just
Sure.
hold on. What is the question?
Snare.
Is there a difference between EMR and saline injected polypectomy? And when to choose one over the other? That is the question from the audience. So Dr. Vagre is asking that question.
Is there a difference between EMR and saline assisted?
No, well, it's a big debate, EMR, what is EMR? Because that attracts a bigger tariff, so it's political debate as well. But what we say in UK, we call EMR when you need to perform multi-piece resection. If you can resect a polyp in single piece, then we do saline-assisted polypectomy. Generally, if a polyp is more than 2 centimeters in size, you won't be able to resect in one piece.
So piecemeal polypectomy is EMR.
Yeah.
Thing. Anyway, we won't let this go out of the hall.
So to
because,
answer the question,
we need
to answer your question, EMR is just a fancy name for saline assisted polypectomy. And EMR is done for flat lateral spreading tumors, whereas saline assisted polypectomy is done for pedunculated polyps or small lateral spreading tumors where everything can come in the snare, but everything is saline assisted.
Yeah, it increases the safety margin, and so it's an important technique to master.
So one of the other tricks I use for colonic EMR is, you can see sometimes the space in the left colon can be very restrictive, and a lot of people push the snare out, and then they ask the assistant to open the snare, and suddenly a 15 millimeter snare opens up, which pushes your scope back, you fall back, or it can cause some trauma. So I like to open my snare inside the scope, and then I slowly progress it forward in a very controlled fashion while I'm manipulating the scope to bring it right above it, like that. I'm just using the control, the endoscope, and then pull the snare back in a very controlled fashion. Start closing there, please. Close, close, close.
Yes, Rajesh, what is your question?
Close. Yeah. Good.
What do you do at this time, Pradeep, now that you've got your snare around it? What do you tell your assistant, and what do you do with the scope?
So that's a very important point. First thing I do is, I just move the polyp. When I move the polyp, I'm watching the opposite wall. If the opposite wall is moving, then I've got too much, there's a muscle or something in it, so I'll open and start again. If I'm happy, there's no movement of opposite wall like in this case, I'll now tell my assistant very clear instruction, because I'm worried about bleed here, so I'll go, say we'll go through from 1 to 4. I'll count 1, 2, 3, 4. By 4 it should be through. So they can time as they're closing it. If
Okay.
it was a flat lesion with low risk of bleeding, we cut through by 3, 1, 2, 3.
Okay.
And I control the pace at which I count.
Okay,
so my
Pradeep.
assistant just goes with me.
Pradeep.
Sure.
The question is, Are you going to use a pure coag current or endocut current?
Yeah.
What type of current?
That's a very good question. As I said, in colonoscopy, this is a dynamic phenomenon. You need to look at the morphology of the polyp, whether it's flat or pedunculated. This is sort of semi-pedunculated. You need to see whether it's left colon or right colon. This is left colon. So, pedunculated polyps in left colon, the biggest risk is bleeding. Flat polyps in right colon, the biggest risk is perforation. So for flat in right, it's always endocut. For pedunculated polyp in left colon, for me, it's almost always forced coagulation, pure coagulation. And that's what I'm planning to do here, unless any of you differ from me.
Any other opinions from the audience?
I think you made a good point on that.
Post-coagulation.
That it's a dynamic thing. You may start off with coag and then go to endocut, depending on how much you want to cook the
I think in the orbicutry, the setting is, it's a autonomous setting. It's not that.
So we're going to start now.
Current is there.
I'm going to count.
But that is if you press the yellow pedal. You can press the blue pedal, which will be only coagulation.
Amit, are you happy for us to reset?
Yes, yes, we are very happy.
Okay. Here we go. 1,
Yeah.
2, 3, and 4. Good. So that's a very controlled cut. And the most important thing, don't take the snare out. Look at the site of EMR or polypectomy. There's no vessel, there's no bleed. Because if there is a vessel or a bleed, you just use the tip of the snare, do some soft coagulation, and that does the job. If the snare is taken out, you lose that opportunity. And suddenly you have 10-20 ml of blood, you can't see things and everything goes wrong. So don't let your assistant pull the snare out. So now I'll just make sure the site is okay, there's no vessel there, there's no bleeding.
There's no great muscle that you see.
That is excellent.
Okay.
Excellent.
Pradeep sir, can we move on the next step and come back to you, sir?
Very clean, very clean.
Yeah.
Very nice demonstration, Pradeep.
Thank you very much. We'll just suck the polyp out and we'll be
The
finished.
question of yours, when to choose EMR, when to choose ESD. You should choose ESD when you want to remove the specimen en bloc. Now, that is when you are suspecting a early cancer or high-grade dysplasia. Usually in the colon, in the rectum, whether you do a piecemeal EMR or a ESD, the results of recurrence are the same. There are no difference. That has been proven by long-term studies by Michael Burke from Australia. However, at other locations like stomach and esophagus, if you are suspecting high-grade
Kale sir, your mic on, sir.
then you should do a ESD.
Kale sir, your mic on.
Okay, so we are still into that difficult tunnel, but we're really getting towards the end now. So we're trying to find the junction where we can see actually the pyloric rim. This is where we know that we are at the end of our tunnel.
So Michelle, your pyloric ring fibers are at 12 o'clock or 6 o'clock?
No, it's going to be, it's a posterior approach.
But here you are seeing it, that whitish area above is the mucosa of the stomach, of the duodenum.
What I'm trying to do is find the rim. Once you get the rim, then you know you've reached the pylorus. That's basically what I'm trying to do here.
Okay.
What his question is, what structure you see 12 o'clock? Is it a mucosa?
Yeah. So here in front of me is actually the mucosa, yeah.
That's the mucosa. The whitish structure is the
I should be seeing
mucosa.
the pylorus somewhere around here.
Little paler, but he says 12 o'clock is the mucosa.
12 o'clock is the mucosa.
Mucosa, but it's paler.
Because Michelle will agree that when we are doing a GPOM, it's also very important to see the muscle fibers well. Only then you will realize that you have reached the pyloric ring.
Absolutely.
Yeah.
And you can see actually here, below here, it's actually the muscular layer right here. See that?
Yeah. That is the muscular layer.
And there's a lot of scarring. This is why the vision is so difficult.
Yes, agree.
In this case. There's really a lot of scarring.
How do we know that we have reached the pyloric ring?
Well, we're going to see a ring. That's the trick.
A ring, huh?
Once you see the ring, you know that you are at the right place. And I think we're very close. See, I'm trying to clean this area here, because it's going to probably be seen soon.
Amit, what is your experience with the poem?
G poem.
G poem.
It's a very good procedure if you select the indications well. And now there is a sufficient literature that even in idiopathic gastroparesis, not only diabetic, but idiopathic gastroparesis also, if you have a delayed gastric emptying proven on nuclear studies before, and if you do this procedure, these patients have 70% chance of relief of vomiting. The only difference between this G poem and normal poem is how in normal poem we go beyond the OG junction. Here we do not go beyond the pylorus.
Yeah, I'm a little tangential here. I would like to find my, my angle. You have to constantly go in and out, go in and out. The problem is the scarring make everything so much harder in this case.
Yes. So, so intermittently you are checking from the lumen whether you are going in the right direction,
correct,
right?
Which is technically demanding?
Oh.
Regular poem or G poem?
I think G poem is a little easier than regular poem, unless there is a situation like this where there is an extra inflammation because the vessels in the stomach are a little bigger than the esophagus. But because the tunneling is shorter, that procedure is technically easier than the normal poem, esophageal poem.
Here the tunnel is almost like horizontal. There it is vertical, no?
Not tunnel, you mean the incision. The incision he has made in the stomach is horizontal here.
No, horizontal.
But I do a vertical incision, even in the stomach.
So make vertical in stomach also?
Yes, I do a vertical incision. The reason is, if you put a horizontal incision, you cannot close it with normal hemoclips. Then you need a suturing device, which Michel has. We do not have a suturing device in India.
So that's the reason why you make a vertical, no?
Longitudinal incision. Longitudinal incision. If you make horizontal, no, you can't close it with clips. How? See? He will do it with suturing device.
Carbon dioxide, that no?
Yeah, Michel, this is a very nice demonstration of how in a difficult situation you are finding the path. You are going in the right direction.
Yeah, I mean, unfortunately, you can let the scarring, you know, sometimes, you know, like distract you, but you have to correct
exactly
your direction to get to the pylorus.
Yes.
You are changing the direction now, no?
Because he pulled back the scope and he realized that he needs to go in the right, on the right.
So he was going more towards the left and tangentially change the direction to the right now.
Yes, and now you have started seeing probably that ring.
I mean, 5 years before, no one would have thought of there is a new entity like third stage endoscopy is coming up, no?
Pardon? What?
5 years before.
Yes.
We thought the ERCP is the only thing and we almost mastered. Then a new procedure like third stage endoscopy came and all of us are kept busy now.
Yeah, well, I mean, it was right, here's the ring. The only thing is there's a bit of vessel here.
This is the ring.
And this is a classic situation where you have to cut the muscle fibers from distal to proximal. In GPOM, we don't start from proximal to distal. After you have exposed the pyloric ring, then you hook a IT knife beyond the pyloric ring and pull it backward. Pull it proximally. And that is how we cut the fibers. The reason is that the duodenal mucosa is very close to the muscle fibers. You cannot separate it. and we can easily make a hole in the duodenal wall, in the mucosa.
Now we seem to be in a better direction. What's that?
He has just gone out. Hello.
Yeah.
Dr. Chandrasekhar, we are on the podium. We can see you and we are watching you.
See, he's just trying to dissect as much as possible, technically demanding because of the fibrosis, scarring. So he's trying to change the direction from the left to the right.
As we see, he's changing to the right side, tilting to the
and
right.
every time he's checking his direction,
Right.
he wants it around the 6 o'clock position.
Right.
So he's just changing from this.
Do we also need to climb up a bit? It's more vertical also, or it's just horizontal at this point?
Yeah. More towards horizontally.
Right.
You want to change to other room also, you're welcome, because we can come back always.
Yeah, okay. No problem.
You are happy in the other room?
We just fixing our tunnel.
Yes, we don't know if any other room is on, so we are watching you till they changes.
Okay. We'll get
So we are dealing with the tunnel here.
Still not ready, man.
Yes, the decision is on the endoscopy room side.
Yeah. better, no? View will know better.
You can see the scarring here.
Yes.
Yes, actually, one needs to really struggle here
Mhm.
because of the intense scarring.
Right. You're not able to take a right turn here.
Actually, we need to go a little more right and little more deeper to get a complete view of the pyloric ring.
Right.
And what is the structure 12 o'clock is the mucosa. Has to be very careful.
We have a hard time separating here.
Yes, creating
This is the problem we've been having all along, separating the epithelium from the muscularis. It's a very, very difficult plane to work with. And as you know, if you don't have separation, you get nothing.
So normally the submucosa is very thin and loose in the antrum. So this is slightly unusual.
It's a very, very difficult case.
Really almost inseparable that we need to be very careful. We should not perforate the mucosa.
Right. Really bad luck because this is where we're going to work and it's just the area.
Michael, you have done 50 cases. Did you see such cases like where the mucosal scarring is very...
I've seen it, but those people typically have Botox. This is why I'm so intrigued by this patient because I see those kind of difficult separation in people that get a Botox injection. This guy is behaving like a Botox without Botox.
Oh, without Botox but behaving like Botox, huh?
Yeah.
The lot of scarring is there. We need to go to the left only. Come to right and go little deeper. Partly we could see the pylori, yeah. Partly we could see the... Trying to get it there.
I'm trying to...
We are just shifting to the room number 3. This is a 22-year-old female presented with hiccups and NUD symptoms for 2 months. On routine gastroscopy, she has a lesion in the gastric antrum, which is submucosal lesion. US showed 3 into 2 centimeter lesion, which is arising from the MP layer. Plan is to do EFTR. Over to Dr. Pankaj. Thank you.
Hello.
Hello.
Yeah.
Yes, Pankaj, we can see you.
Yeah, okay. So this is a patient with, can you see that lesion there?
Yes.
Yeah, it's around 2.5 to 3 centimeters. Huh?
So what I'm going to do is not wasting any time because we are already running quite late. Usually in these lesions you don't require to do any marking, but what happens is in majority of the times what we have experienced, and I don't know what Amol would suggest, it is better that we put some marks so that after injection when the lesion is lost, we know where to put the incision. Yeah, so we'll just... Yeah. We don't need any big margins there. But we'll try to just put a few marks so that we are not lost when we are doing the case. What we are trying to do is see if we can resect this full thickness, and then Dr. Amrita is going to show us a technique of suturing the defect. So that is what our plan is.
So no, can you explain the plan to us here in the audience, please?
Yes.
Can you explain the plan to us in the audience, please? What do you plan to do here now?
The plan would be that full thickness resection of this lesion and then closure of the defect using an endosuture, Apollo endosuture, or the overstitch. That is the plan.
Again, this is an exposed full thickness resection. So the terminology I'll go over a little bit tomorrow in terms of the talk, but exposed versus non-exposed. Exposed is when you perform the full thickness and then close afterwards. Exposing the peritoneum basically is what exposure refers to.
Non-exposed one is you can probably put sutures underneath. We discussed that just now. You can put sutures underneath, actually plicate the lesion at the gastric wall, and then lift it up and then probably chop off the lesion from underneath. That's another way of doing it.
Yeah, there have been some devices that have been worked on in animal models, and I think one that's available currently in Europe called the G-plicator maybe, that allows for that sort of apposition of the serosal layers first and then resection above it so that you actually perform the closure first. But it's not a device that's readily available. And while the overstitch device allows you to do that technically, for a lesion such as this, where you can't quite be sure where the base of exactly how deep the lesion is to in the muscle layer or beyond it, it might be a little bit difficult to actually put sutures in at the base. So that's why we'll resect it first and then close the defect.
That's right.
So when you choose such a needle for full thickness resection, would you be bothered about the exophatic or the extramural extension of it? So suppose it was extending out a reasonable amount, so would that lose the candidacy for this? How do you choose lesions for such a procedure?
For exposed versus non-exposed?
No, I meant if it had a significant extramural extension.
Yeah.
So would that be amenable to such a procedure?
No, well, actually, what do you think?
Actually, Vikram, from what I gather, see, EFTR is primarily designed for endophytic lesions, so lesions which are protruding into the lumen.
Right.
Predominantly exophytic lesions, I think still the laparoscopic approach would be a preferred approach.
No, I agree. I meant some of the lesions also have a exophytic component of variable extent.
Yeah, if it is a small exophytic component, probably you can do an endoscopic, you can do an EFTR. But if the majority of the part is outside, then probably you can get your laparoscopic surgeons to do it. And if it's probably equal, then you can probably even do a endo-laparo combined procedure, something of that sort.
Or you can, if you have enough room with the sizable tunnel and the approach is okay, you can do a stir within the gastric body. But it certainly has been described to do a combined laparoscopic, endoscopic, where they go in with a single port, push the lesion into the stomach and kind of invaginating it.
I think that at least in our setup where endoscopic suturing is not still available, that combined approach I think is still a good approach for majority of the people.
Endophytic lesions, I think until you have a good suturing device, would be risky to attempt endoscopically only. Typically, you should have lesions which have a small muscle attachment.
Yeah.
A small muscle attachment is easier to close using the current clips and the full thickness clips that we have. Because if it's a very wide attachment, then you're going to have a big hole in the muscle, and then that can have issues.
Yeah, I think ultimately your available resources for closure.
Also,
I think ultimately you have to see what are your available resources for closure to help guide what kind of resection you're going to do.
most of these cysts are very vascular. So are you also worried about bleeding here?
Yeah.
So
We have to be careful while we are dissecting.
You'll probably see some large vessels when you go deeper into the submucosa, feeding the lesion, and you need to coagulate them well.
The nice thing about suturing is that, when we do, for example, gastroplasty with the suturing, we do hit some fairly large vessels because it's a blind stitch. But when you actually cinch the stitch, you're essentially tamponading the vessel. So it's a nice way to create hemostasis, despite the fact that you sort of have hit, caused the bleeding with the procedure itself. So in this area where the vessels are larger, it's even more reassurance to use a method such as suturing.
Dr. Amol, there is a question. Why not choose this for STER? Why not tunnel into it?
Tunnel in the antrum.
Is it possible?
It is possible in the proximal stomach sometimes, but in the distal stomach sometimes becomes difficult. Now this case may be possible.
I think it might be possible with the stir, yeah. Right along the posterior side, yeah.
Particularly if it is on the anterior wall, then probably stir is not possible because you can't get into the tunnel. Your scope keeps falling out.
Right. Somewhat like the G poem.
Yeah.
Yeah. I think, this might have been an option for the...
Right. You see the distal attachment to the muscle. As you get deeper, you will start lesion. Once you start seeing the lesion, you enucleate the lesion. Start enucleating the lesion.
That's the lesion.
This lesion we will find.
That was a good one. This lesion we are sure to find. That's the one.
That's the lesion over there.
Amol,
Yeah.
will EFTR results into antral motility disturbance because this is sitting almost at incisura?
Very vascular, yeah.
Tremendously vascular.
See, it's going to be, you're enucleating it practically from the muscle. So the damage to the muscle is minimal.
Right there, right? You can almost use an IT.
Compared to a kind of resection.
Yeah, I'll just...
Maybe some amount, because of the location of the lesion, there could be a dysmotility later on. In that case, you may need a G poem later on. I don't know.
The next course, next year's course.
On the CT, can you see the vascularity of this tumor?
Yes, extremely vascular.
It is tremendously vascular, and the person who did the CT was telling me that this could be a neuroendocrine lesion.
No, but even cysts are pretty vascular. This definitely looks like a cyst. It's not a...
Let's see.
You switch to a...
Vascularity, you have to just see that it doesn't start.
But it's somewhat contained along the capsule, so that kind of, like using the IT in this situation is helpful because you can...
See the big vessels.
So as we see it right now, what you are doing is removing the mucosa and some mucosa from over it, sort of unroofing.
Just trying to enucleate it from the surrounding tissue.
Unroofing it, if I might.
Yes.
Yeah.
Okay.
Point of time, we change the position of the
So that you can bring the lesion into a dependent position. Yeah. Yeah, I think that's an understated technique, or especially in ESD, like the cardia is changing the patient position.
Important actually to.
Wow, those are impressive.
Very nice, Pankaj.
Trying to expose out everything that we can and
Try to locate the attachment.
Just enucleate it out.
yeah, there will be.
That's why you first get it off the mucosa.
We are going to suture it, yeah.
There are a couple other techniques you could try, like a loop and clip technique, or
Loop and clip technique, or you can put a full thickness clip. If here probably I agree that the defect will be too large for a full thickness clip, but here you can use a loop and clip technique.
or you could use two, for example, two Avescos.
Loop and clip. It works. It's a little bit tedious, but I think there's a detachable loop now available. Now that makes things a little bit easier because you can leave the loop and then go back in with the scope, and you can use a single channel scope.
Point down there where the attachment may be.
Yeah. No idea. I've been talking to the Apollo guys for every time I go to DDW, but they don't want to come to India, I believe. Amita, maybe you can go back and ask them.
I will.
You can tell them that
you have all the cases for it.
They'll have good business out here. Maybe they can come for our next course.
Yeah.
Okay, this is almost like a stir that you've done now. Because you've got the mucosal flap off.
Yeah, I'm just trying to stay close to the capsule. Yeah. You can shift, not an issue. Well, how far we can progress.
So what's the end point here, Amol?
There's the attachment.
That is the attachment. I think so. That's the attachment.
Amol, how far will you de-roof here?
We'll get the entire mucosa out.
Okay.
You can see the attachment right there at the bottom.
There is the attachment here.
So if we can get it all the way around the rest of it.
Yeah, maybe we'll just extend our incision. I think so.
Pankaj sir, thank you sir. Can we move on to the next letters?
Finally, you can see the scarring. We finally were able, through the scarring, to get to the pylorus. You can see the pylorus right here, which is that ring on the left side of the screen posteriorly.
Dr. Kale, can you point that out for us?
And in front of, this is the pylorus, right? I'm actually putting against me the pylorus.
Okay.
And in front of me is actually the duodenum right there. You see the scarring is tremendous. It's a lot of scarring. So we basically spend all this time cleaning, to be able to actually get there.
So now what you see is the pyloric ring.
Yeah. And now you can see the pyloric ring. And I'm going to basically at this point use the reverse technique to cut it. So this is one time where you actually want to cut the other way around like this. You see that?
Right.
Here. Just like that.
So this is the pyloric ring gone.
That's the pyloromyotomy that I'm doing right now. Very gentle, layer by layer. And the key is not to touch the duodenum. Because that will be a problem. Close. and I extend the myotomy. I'm doing it the other way around. I extend the myotomy 2 or 3 centimeters more. You could do the IT knife, absolutely. You can definitely do the IT knife if you want. It's safer, but I mean, you have to remember that here I'm not touching the duodenum at all. So I should be able, by pulling the pylorus against me like this, to avoid any issue.
Dr. Kale, a single quadrant incision should be sufficient?
Single what?
One quadrant incision like you are doing here should be sufficient?
The pylorus have to be gone. And you see, I want to really make sure the pylorus is completely gone.
Right.
And then 3 to 4 centimeters proximal to it. Yeah, I mean, in the stomach, you basically go to cut all the way until the serosa. Absolutely. So, and typically, do this, be safe enough. See, this looks pretty good. I'm going to cut a little bit more of the pylorus stream here. There we go. And now I should be able to cross more easily into the duodenum, and indeed, you see, I don't know if you remember the resistance that I had, and here I just was able to very easily to go through.
Yes, very nicely seen.
So I think, here the challenge was the scarring. The scarring that really we had to deal with. Once you get through the scarring and you have your tunnel, you're basically done. So that's it. So I still gonna do gentamicin wash if it's okay with you.
Right, that was absolutely brilliant, Dr. Kale, and we can have a big hand for him, I think.
Of course, yeah.
Done with you. That was brilliant.
Thank you, sir. We will move to room number 5.
Thank you, chairpersons.
Hello. This is a.
Thank you, chairpersons. We'll now move on to the next set of chairpersons. You want to wait?
This is a 56-year female who presented with dysphagia and regurgitation for 6 months. The upper GI endoscopy revealed achalasia cardia.
Thank you, sir.
Manometry
We'll move on to the next set of chairpersons.
The manometry
Thank you very
revealed
much.
type 2 achalasia cardia. This is the barium.
May I invite Dr.
The plan is to go
Palli Appan, Dr. Mandar Doipude,
Thank you.
Dr. Govind Raj, and Dr. Varun Mehta to please chair the last few cases.
Sir, my concern.
Am I audible over there?
Yes, you are audible.
Yeah. So basically this is a type 2 achalasia cardia and we are going to perform poem. It has been discussed at length in previous to procedure and we are pretty late, so I'll just start with the procedure. Harshal is going to assist me, and the instrument what we are going to use is basically initially for injection we would be using a sclerotherapy needle, and once we cause a bleb we'll do entire procedure with a TTJ. And the cautery I'm using is an Arbe cautery and the scope I'm using is a 190 HQ. So we just went in, the G junction was at around 40-41, so we are going to make a bleb at around 30. And I usually do posterior, and how do you make a posterior is by seeing where the spinal impression is, and also you would see where the fluid is getting collected. So we would just, can you just start injecting? Take out the needle, start injecting.
Sir, sorry for interrupting. Can we move on the next slide and come back to you, sir?
Yeah.
Thank you, sir. Pankaj sir, are you back with you, sir?
Yeah. Okay. So I have progressed a little in the dissection. We are trying to separate the lesion out. And in the meanwhile, Dr. Amrita is preparing her suturing device. And if you are interested, we can show you that while she is doing it. And in the meantime,
needle.
Yeah.
So the suturing device requires a double channel scope to really work properly. I mean, it's feasible to do it on a single channel.
Needle.
Yeah, can I have some gloves? but the accessory fits through the second channel, so that's why it's really made for a double channel scope in terms of the fit of the device itself, which I can show you here.
You want to target the same place.
Pankaj, Amal?
Pankaj sir?
Yes, yes.
Yeah.
Pankaj, audible?
Yes sir, yes sir.
Hello, Pankaj, if it's a just
Hello.
an Amal. Hello.
Yeah.
Amal, if it happens to be a gist, and what's the chance of peritoneal spillover and recurrence?
See, if you don't damage the capsule, I think the risk is pretty minimal. But if the capsule is damaged, then there is quite a bit of risk. You have to be very careful to remain extracapsular. It is an extracapsular enucleation that you're doing.
Okay.
So maybe we'll put it on the patient. So I'm going to tell me if it's a good time to show loading the device, or should we wait until he's...
I think you can show.
Okay, sure. The water is...
Because this will take some time to separate.
Okay, so when the packaging comes, it comes with this device that gets fit onto the scope, and then the needle holder, which is here. I'll take that off in just a second so it doesn't go all over the place. Yeah, so this is, no, keep it on. It's okay. So this is the handle of the device. This is going to fit onto the, where the caps are up here. There's a little lip that you can see, so we're going to put that into the lip and then just push down, and it snaps right into place. So this is our control, where we're going to control the actual device. And then this wire runs along the shaft of the scope, and this port here is going to fit into your large channel of the double channel scope, and it fits on nice and snugly like that. So what's going to happen is when I close the handle, you'll see the needle holder closing. I don't know if you can see that. See that?
So
Can you see that?
Amal, double channel scope is a must, no? For this.
Yeah,
double channel scope is a must. It's doable. I have done it before with a single channel, and the company is actually making a device in order to fit a single channel. This device currently is also made mostly just for the Olympus scope because of the double channel nature of it. So now we're going to actually load a suture in.
For single
So
channel,
we
you
will
need
take-
a therapeutic scope.
What's that?
For single channel, you need a therapeutic scope. I mean, a scope with a therapeutic channel.
With a single channel, you need a therapeutic channel. So now I'm going to take the suture that I just soaked in water. So this is the suture. You can see here. And I will take this device. This is the needle, the suture holder. And I'm just going to fit this into place. And it catches hold of that little metal tag. This, at the end of the procedure, this little metal tag is going to be what's left in place to form one side of the apposition of the suture. So I'll just take this out of the device. You can take
Amal, what suture material is this?
This is Proline.
It is Proline 20.
Okay.
And the company does make dissolvable sutures as well. So, okay, so now we're going to be ready to load the suture on. So I'll have you hold the scope there. Okay. And now what I'm going to do is I'll take this part. Okay, so I'm going to open this. It's really important to open the, so remember again, it's opening and closing. So when we're loading the suture, we're going to keep it in an open position. I'm going to take this suture and I'm putting it down the larger channel. That's the channel closest to me. And you can see it's carrying down the suture with it. Come on. street and not here outside. Okay, good. So I'm going to push this all the way down. You'll see it come out the... So the first suture is always the easiest. I mean, to load the first suture is always the easiest because it's outside the patient. But subsequent sutures will actually load inside the patient. So you can see here, this just came out the channel. This is has the suture attached to it. The little metal tip is in there, and then the suture is attached to that. So one thing we want to do here is create a loop so that there's some slack on the suture. And the best way to do that is to extend the driver and then pull back quickly. And you can see there's a little loop that gets formed. What that helps with is when you're going through particularly full thickness, it helps you actually bring the suture through better and gives you a little bit extra slack to be able to load a new suture and take the next bite. So now I'm going to actually load the suture. So one thing we do is we make sure this driver is all the way inside so it doesn't bend the needle. Now I'm going to close with the handle. I'm going to close the device. So that brings the suture holder there. And now I'm going to push down on this handle. And you can see, I don't know if you can see there, but the shinier metal piece that just got attached to the curved needle. So now I need to transfer the suture over to the driver. So I'm going to press on this blue button. And what that does is it releases the teeth that are holding on to that little metal tag. And then I pull back just a little bit. And then I open. And you can see we've loaded the suture onto the driver.
Wow, that's very good.
And so in terms of just to show you what's happening outside the body in terms of when we do the actual suturing, we'll go inside. Always make sure it's in a closed position when we go in so that not to create any trauma. We will bring the tissue into the pathway of the needle. So sometimes we need to use a helix device, which we can show you in a few minutes, to actually retract the tissue into the path. We'll then take the bite, so close the handle there, and then
show
push.
the handle, please. Can you show the handle?
So again, it's just closing the handle. And now what we have to do is we have to go back and get that, transfer the suture back to the suture holder on this side. So again, we push down here, and now the step, you feel it click. So it's actually grabbing with those teeth, it's grabbing that metal piece again. And now instead of pushing the button, we're actually just going to pull back, and you can actually feel it pick up the metal tag. And so now the metal tag, when you open the handle, is right here. So then we'll go back, and so now what's happened on the tissue side is that it's taken a bite, it's put the suture through the tissue. Now we have to reload. So again, now we're inside the patient, so we don't have the luxury of, creating, having this much room to create our loop. So we'll just pull back all the way, again, so that we don't see any of the metal. We're not going to bend the needle. Close it. Push down on the handle. You feel it click because it's grabbing with the teeth. And then push the blue button. And then pull back. And you again transferred or loaded the suture. And then you can take your next bite. At the end of the suturing, when you're ready to cinch it, you are going to... So let's see if we take another suture here. We're going to go grab it. We're going to pull it back. And so now let's say we're ready to cinch it. We're going to push this out and actually now release this to nothing. So there's nothing to accept it. And it's going to release the metal piece into the lumen. We'll take this out and then we'll attach the cinch that has the second tag to create the apposition. That will show you during the procedure itself because otherwise we would have to waste this suture. So we're essentially ready. I'm just going to close this again. It's important to close it to keep it safe. So we're ready whenever Pankaj is ready for us to suture.
Do you need to use overtube to pass the scope to avoid injury?
So it is advisable to use the overtube, particularly when you're beginning to use this device, because manipulating it through the oropharynx can be sometimes a little bit difficult. I don't really use the overtube anymore. I feel quite comfortable passing it. If you're going to perform a procedure like a gastroplasty, it's advisable because you have to take the scope in and out so often, sometimes to clean the scope or if you have to change anything with the device. But for a case like this where it's just one or two sutures possibly, I don't think you need an overtube.
Amrita, how effective is gastroplasty using this device?
It's very effective. It can get up to about 30% excess body weight loss with sutures holding out. Now, we have, I think, looking at least 1 year data, if not longer, out of the 3 centers. I think Michelle's partner, Reem Shirai, is actually part of a multi-center study that's quite robust in its data.
I think of the patient now.
And the patient left lateral?
Yeah, I think so now.
We can hang that. Yeah, okay.
Dr. Amol?
Maybe we can yeah.
Other than that, such like patient, we are doing a full thickness resection and using a suturing device.
Yeah.
What would be the other indications for such devices?
So, for the suturing device?
Exactly.
Closure of fistulae is another.
The gastroplasty we just mentioned. In the gastroplasty, you basically place plications from the antrum up to about the fundus in an anterior greater wall and posterior formation. Fistulas are good. I also use them to fix stents in place to prevent migration, like fully covered stents, particularly for benign disease. What else do we use them for? Actually, some people have described them as a traction method when performing ESD. Taking a bite in the lesion and in the normal mucosa and then taking a bite on the opposite wall of the antrum, for example, to create countertraction.
Thank you, ma'am. Can we move on to the next step and come back to you, ma'am? Panelists, sir, your mic on.
I'm on. I'm on or there's a muscular attachment. Yeah. There's a pseudo capsule of the muscle actually.
Okay. Is CO2 on, guys? CO2 is still on? Okay, we are live. So, one of the biggest problems when you have so much scar and you dissect a lot under the opening is like the opening can get disrupted, so which explains how many clips you see I have here. So, you have to religiously close completely the defects. Another solution is to use the overstitch device of Amrita open. So, I'm not, unfortunately, you only have clips rotated bits. So very important to choose clips with large dimension like a rotator. That's it, no more. Here. See, I'm taking both close gently, close, close, close. Yes, yes, less, all the way. Here. And you see, it's very important to take both lips of the defect to have a nice closure. You see, it's like a very nice zipper line here that I'm closing with clip. Can I have at least 2 more clips here? And we should be fine. So very, very important to remember, yes, that sometimes the opening can get disrupted when you cut all the conjunctive tissue under it, but it's typically not that hard to close, so don't get scared, because there's no, what is this? It's an Olympus one, because now the 2 lips are close to one another, so we should be able to get away with that. Okay, open, rotate, open, bang. Okay, that's it. Close here, close, 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 yes, yes. Yeah, this is the bad. I will put 2 more, one on top here and one on bottom. Just to be completely safe. So, and then typically after a gastric poem, I keep them NPO overnight. And then we get a contrast study the next day. And then we put them 3 days on clear diet. Okay, open. 3 days on soft. Open. Rotate.
Any particular choice of different clips for a G poem since you are using a more of horizontal incision?
I'm sorry, can you repeat the question?
Since you are having a more of a horizontal incision, any different choice of clips that you could use for G poem as compared to esophageal poem?
Hey? No, I mean, I like the rotatable clip. So I like the 360 Boston or the Wilson Cook clip or the Olympus second generation clip. I mean, I like the one with large jaw that rotates. I mean, the first generation Olympus are nice now that everything is approximated, but I wouldn't start with that. I would probably finish with that. Okay, open here. Rotate. Open. Open. Yes. Close. 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 All the way. See, now they are approximating. It's very easy to place them. I want to put one more on top.
Sir, thank you, sir. Can we move on to the next slide and come back to you, sir? Nilesh, sir, audio back with you, sir.
Okay. Am I on?
Yes, sir.
See, we did what we did when you were away was make an incision, and we did an incision with a TTJ knife. So we injected and made an incision at 6 o'clock, and then we started doing our tunneling from 30 centimeter, 29 centimeter. Right now we are at around 36, and our GE junction is around 40. So still we are doing tunneling, and we are doing tunneling again with TTJ knife, and we are staying near the muscle needle, and we are using force coag. I prefer spray coag, but right now this is the only cautery which is available, which is ICC 200, which doesn't have spray coag. So I'm just using force coag. And as others have shown you, the trick is to stay near the muscle. This is the tunnel we have made right now. As you can see, the muscle is quite thick over here, and there are small vessels. We are just coagulating, just put water. And the trick in POEM is we have to do dissection where the dark area is. If you want to go somewhere, we'll finish off the tunnel, or you can stay with us.
Dr. Nile?
Yeah.
Apart from Urbe and Olympus, can you use any other cautery? Like,
you can use Olympus cautery. I do have Martin cautery, but that you can use with force coag as we are using right now, which does have endocut, but I don't know about the endocut of the Indian cauteries, which but I usually use Urbe cautery.
Thank you, Nilesh, sir. Can we move on to the next slide and come back to you, sir?
Yeah.
Pankaj, sir, audio back with you, sir. Yeah, mic on, sir.
Pankaj is doing a phenomenal job here. He is practically enucleated the lesion. You can see the vessels are pretty big, but undauntedly he is continuing the dissection and he is doing a wonderful job.
We isolated the pedicle of the muscle attachment, and actually I don't think it's that large, so it should be.
Yeah, it's here, down here.
Yeah, that is where the muscle is. Probably using the software, someone can probably mark on that, and they can even demonstrate that.
When you switched over to the G-POEM, it did remind me that another use for the stitch that I use a lot is sometimes for posterior poem closures, and particularly for G-POEM, so that I can do a horizontal incision. You can take in one suture, you can close the entire incision, and cost-wise, it's about, at least in the United States, not so much here where you have the clips. There, cost-wise, it's about the same. If you're going to use 6 to 8 clips, it turns out to be the same cost, and it's a much shorter closure.
Yeah, that's true. I mean, we have the reusable clips, not reusable, reloadable clips.
Reloadable, yeah. We don't have those, unfortunately, in the States.
Area of that.
Yeah, that's the muscle attachment actually.
Yeah, very vast.
Trying to separate this from
thing about this kind of full thickness is that you don't have to worry about so much about the mucosa. In fact, you don't necessarily even have to dissect it like we were talking about, because you could just take the mucosa with the whole lesion.
Actually, what's happening is on the other side you've got inside the muscle. On one side, on the left side, you're probably in the submucosal plane where you can enucleate it out. That's a more avascular plane, I believe. You can divide the capsule like this vertically out here, because that will give you purchase.
Yeah. And I don't know if you realize this, but we did go ahead and change the position of the patient.
Yeah, we made the patient left lateral.
Yeah, so we have a little traction of the tumor itself which is coming down here.
Dr. Pankaj?
Yeah.
Any particular reason for using an IT knife here? You are using, I suppose, an IT knife.
Yeah, I am using an IT knife because see, majority of the dissection with the tip which is ceramic, I think it is much better to do a lateral dissection in this case.
And basically you have to pull and cut in this technique because you are trying to enucleate. So there, IT knife is better and it's much faster also.
And trying to preserve the capsule.
Yeah.
In general, when there's a need for some amount of blind placement of the knife, and sort of parallel to the plane of the muscle, then the IT knife is very good.
IT is a preferable knife, yes, for a lot of cases.
Other than that, IT could be, I think, less traumatic. I want to say you can actually control the depth of the cutting also with IT knife.
Just trying to clean out all the saline and so that we have a clear field. We have gone across almost the whole tumor.
Yeah. It might be a little difficult to get the distal portion, but a little bit left on the distal side.
Trying to separate it from here.
Notice that the motion with the IT too is IT knife, anything with the ceramic tip is a little bit different. It's a little bit more of a traction that and a pull towards you, as opposed to some of the dual tip, the dual knife, or the hybrid I knife, where you're making very pinpoint contact. The energy density, if in John Day's terminology, who's very well known and that is part of IRBI and present for a lot of these procedures, the energy density of the I-type and the dual tip is very much at the tip of the knife. And so you want your angle to the tissue to be different, as opposed to the IT type, where it's along the shaft. So the motion of the knife is different. Attachment down there.
Yeah.
Yeah.
That's the muscle attachment.
Yeah.
I think we have to cut through the muscle now.
Yeah.
The muscle.
You're now cutting into the tumor.
That is going full thickness here. Yeah, it is a firm attachment which I'm trying to just
Take a
sap.
hole into the muscle.
That is the last thing which is left.
So do you switch your instrument when you're to make the actual
The whole
hole?
aim of this
There
exercise
is-
of dissection is to make the muscular hole as small as possible.
Yeah.
So that you go to the root of the tumor, the root of the attachment, then by pushing. But if you make a larger hole into the muscle,
So Pankaj, there is a question from the floor.
Yeah, yeah. What is it?
Magis, அந்த mic பண்ண open பண்ணி விட்டுருங்க Magis.
A little bit.
Yes, I can't listen the hear the question. Big attachment here, huh?
The muscular layer. If you go through and damage the perigastric vessel, and patients start bleeding towards the peritoneal side, then what should be the answer? You should go for a surgery only?
Yes, surgery. It has to be surgery. I don't think you can do much more
I
than
have
that.
seen one case described of, if the hole is big enough, actually putting the scope into the peritoneum. And in fact, some people will practice that after doing the full thickness, is to inspect the serosal surface to ensure that you have the entire lesion and that there are no bleeding vessels. So if you put the scope in, of course you're using CO2, probably you'll need to decompress the abdomen, but that's another way to look for bleeders and or potentially control, a bleeding vessel.
But suppose you are able to resect whole tumor, why not intervention?
Yeah, that's true. You have the time to, yeah. Actually be faster than taking them to the OR.
Pankaj,
Yes, yes.
is that full thickness which has been
Yeah,
done?
this is the attachment to the muscle which I am resecting. Can you see that?
Yeah, we can see
On
it.
the right there is muscle,
So there,
and on the left there is a capsule of the tumor.
I think that's the small defect through the
Yeah,
muscle
that's the
there.
small defect which we have already. It is okay.
Yeah, she's still soft.
Would there be some benefit of placing a needle in the peritoneal cavity at this point?
Over the abdomen is absolutely soft, there is nothing.
Yeah, we're feeling it as we go along, and she's still very soft, and there's no change in the vital signs or ability to ventilate.
Yeah, that is what we are constantly looking at. Maybe.
Right now, the actual defect in the muscle appears to be small. I'm not even sure he'll need to make any larger defect in the muscle, so. Yeah. There's also always the question of how we're going to get this out of the patient.
Yeah.
So we were having a discussion about that earlier. The large lesions, I mean, the obstacles we'll reach will be G junction and the oropharynx in these large tumors. So, the goal is to bring this out on block. But sometimes they are so large that you have to go ahead and actually bisect the lesion to bring it out.
Sometimes when they are hanging into the stomach, cut them because there is no effect.
They're too big for a snare.
Oh,
Yeah.
This is too big. Still, I think we have to change the position now.
Back to the supine.
Right. Let me see. Just let me see. Just let. That is still not full thickness.
Right. I don't see preperitoneal.
Yeah.
Yeah.
She's soft.
Pankaj, if
Yeah.
it is a full
Yeah.
thickness and if carbon dioxide escapes into the peritoneal cavity, will you be able to keep distensioning the stomach or will it become difficult?
I didn't get the question.
He asked if there is full thickness, will we be able to distend the stomach when we go to close it? Because now we won't be able to hold air. Hold the CO2 if it's full thickness.
I'm not getting that. You can answer that if you can. I'm not just.
That's a very good question.
Because me being a surgeon, when we do a TEP repair, we give a little bit of carbon dioxide to have a third space there. And when it escapes into the peritoneal cavity, it becomes very difficult to do a TEP repair. Similar way, if the air escapes, the carbon dioxide escapes into the peritoneal cavity, you will never have distension of the stomach. Then how will you keep closing the stomach then?
So we'll just decompress first.
Well, I think that, so for one thing, this defect in itself, I don't think this is full thickness, so I don't suspect that we're going to have a problem stomach distended in this particular case, but larger defects, yeah, I agree that that can be a problem. And that might help, that might guide your closure technique as well. You might not be able to actually have the time to come out with a new scope and a new device to be able to go back in because you'll lose your visualization. Soft.
Abdomen is soft.
Yeah, abdomen.
So you can give one transfusion afterwards. You already had anemia.
Dr. Mohan?
Yeah.
In addition to the usual ESD what we are performing, any other full thickness resection devices available?
Yeah, so you can use a OTSC clip, which is the type of OTSC clip which is meant for subepithelial tumor. You have to grab this tumor the root and then simultaneously once you catch the tumor root by a clip, then there is a simultaneous snare which cuts the tumor above it, so that by the time tumor is cut, the rest of the edges are approximated. So that device is also available.
So that device is made for the colon. It's a 20 millimeter cap, so unfortunately it can't be placed easily into the upper GI tract. There have been 2 cases described of duodenal lesions that were removed that way, but it required dilation of the esophagus in order to do that. So right now it is only approved and used for colonic indications. But it works quite nicely. Some people have tried placing an upper size of Vesco and snaring above it. It's a difficult thing to do though because the snare doesn't sit nicely inside the Ovesco cap. The difference with the full thickness device itself is that the snare actually is attached right after the cap, so it follows and it fits right inside the top of the cap, so it's especially made for that purpose.
Morgan? Morgan?
Yeah, tell me.
What just now Amrita was telling, no, Ovesco is approved only for colon, but in all the conferences we have been seeing it being tried and used in upper GI.
Yeah. So as she told, 2 cases have been described which required a dilatation of the esophagus for the device to pass over there because the device size is too big. So it's not approved for upper GI use. It's only for colonic use.
Sir, can we move on to the next slide and come back to you, sir?
Yes.
Sir, audio back with you, sir.
Hello,
Audio on?
Nilay, you are on.
Nilay, we are on.
So we have just reached probably crossed the G junction. These are now the stomach is starting. You can see the space is opening up. You can also see the additional longitudinal fiber, and now this is probably stomach. We have not gone out of the tunnel yet. Just inject somewhat. Okay. So in a minute we'll go out of the tunnel and see where exactly we are, but I think we are in the stomach. What do you say in the hall? You can see the palisadal vessel over here at 6 o'clock, and also some. Are you on?
Yeah, we could see. We could see. Yeah.
Can you see these vessels are of stomach?
Yes, Nilay. Yeah, we could see very well.
I think we are okay. What do you say, Harshal?
Yeah. I think we should go and check.
Yeah.
The outside.
That's it. Okay, I think we'll now see the tunnel where we have reached. So that's the end of the tunnel, which is at 44. It's very tight over there. This is the entire tunnel. We'll see if we are not still in the stomach, then we'll extend, otherwise we are fine. I think we are okay. Now let me do the retroversion and see.
Yes.
Can you see the bulge? Yeah. We can go 1 centimeter more, but I think we are okay.
We are good. Yeah, I think we are good.
Do you agree in the hall?
Yes, I think you have gone sufficiently.
So let us go in again. We can clean the scope, clean the knife. Johnson Barrett, yeah. So what you can do is to clean the scope, you can use the Johnson bar. So that will clean the lens. I'll also suck fluid in the under GA with bulb, so we are okay, but still it's better we suck the fluid from here, and then we'll clean everything and we'll go in again.
Dr. Nilay, what level of carbon dioxide would make...
It should be very little. Unfortunately, most of the CO2 inflators, they don't give us the very low rate of flow. So you have to take out the finger in between. You have to be very cautious. You can apply certain, the CO2 is too much. What you can do is, what we do is we apply a mosquito over the tube and try to reduce the CO2. If it is too much, then we can also We can also deflect as Dr. Kaila showed us in the morning, or you can stop the procedure for 5 minutes and just wait. Right now ETCO2 is not high, it is only 26. So we are fine. Let us see and where exactly was the mucosal opening, and then we'll go in again. You done anything? I don't know.
Milay?
Yeah.
In your experience, what is the percentage of needing decompression, abdominal?
Not really too many times, but yes, most of them they do have some pneumo, but you don't have to do anything about it.
What's the common complication you have seen so far? No?
Fortunately none. Fortunately none, because I don't know if something happens. We are really into it to treat those things so aggressively. But this is basically a very safe procedure. If you do it very meticulously, cautiously, there is no need to hurry up. You can do it. You can take your own time. You can do it with some time. I always keep my poem procedure when on Saturday or some other days when I don't have OPD. So initially that is what you should be doing it. See, basically Amol has asked me to do this procedure because not all the time experts should do it. So this at least someone who is not so expert also should share the procedure, his experience. Now we have to be very careful in stomach because many times we don't see the vessel. We don't see the vessel and then suddenly it bleeds. I see a vessel over there which is beneath. What I'll do is I'll apply coag there and see what's happening beneath. I'll try to stay away from the big vessel. Now you see the big vessels of stomach. Okay. So this kind of vessel can be coagulated just by coagulation. If it doesn't, then you need to use coag grasper. But I think we are okay here. But we may have to clean the needle. What do you say, Arshad? Are we okay now?
I think we are good. We should start with the myotomy. Clean, bloodless job.
Yeah, so our tunneling has been done. You can see this is like 43, 44. This is the maximum resistance where what we are getting at this place. So this is the junction, G junction. In fact, while pushing, we have split some muscle fiber, as you can see over here, but that's fine.
Very good dissection, Nilay. I think
you very much.
you are an expert. I don't think you are an amateur or a novice in this.
So thank you. Now we'll start the myotomy, and as the previous demonstration shown you, that myotomy has to be around at least 2 centimeter below the lower end of the incision, because we don't want to create the full thickness. So this is 29, so this would be the lower end of incision. So this is 31. So we'll start our myotomy from here. And the first thing what we do is find a plane between the circular muscle and the longitudinal muscle. That we do it gradually. We don't just do it straight away. So I'll use.
Can we go to the next theatre and come back?
No problem.
Yes, sir. Thank you, sir. Yeah. Pankaj, sir, audio back with you, sir.
Dr.
Audio back
Pankaj.
with you.
Yeah.
Dr. Pankaj, are you cutting into the tumor?
Just a little bit, so I have just gone out. Probably that is the densest part of the adhesion which is there.
Pankaj?
Yes.
Is there any cutoff? What is the largest size of tumor that can be managed endoscopically?
No, you should not venture beyond 5 centimeters, 3 to 5 centimeters. 3 is ideal. This was supposed to be 2.5, but I don't know. This appears to be very big. US also it measured 2.5 to 3. We can decompress it. We can.
It's not that bad. Yeah, let's do it. We actually turned her onto her right side. Helps
Needle.
fair amount in terms of bringing.
Pankaj, sir, can we move on to the next slide and come back to you, sir?
A 42 years male who has history of dysphagia since 2 years. On OGD, it was suggestive of eclasia and a large subepithelial tumor at the 22 to 28 centimeter causing luminal narrowing. Manometry was suggestive of type 2 eclasia. Did a CT thorax in US, which was suggestive of a 5.1 into 3 centimeter lesion arising from the submucosa of esophagus causing luminal narrowing, likely leiomyoma. So we are planning POEM plus STIR. Over to Dr. Bapai, sir.
Yeah. At this stage, we'll have a change of chairpersons. Thank you, chairpersons. I would like to invite Dr. Uday Singh Patil, Dr. Umesh Mehta, Dr. Ramesh Patil, and Dr. Sheetal Darfai.
Hello, Suhas.
Yeah.
Am I audible there?
Yes, you are audible.
Okay.
Yeah, we are just having a change of chairpersons.
Okay, so
Yeah.
this is a very interesting case. He has eclasia, presented with dysphagia. When we did the endoscopy, that's the area is not very tight, but it still shows, type 2 eclasia and barium and manometry. But As I pull back the endoscope, you can see that can you see over here? I'm at 24 centimeters and there's a leiomyoma on the anterior wall. This is a pretty large multilobulated lesion over here as well as over here. And on EOS it's about 5 by 3 centimeters. That's the size. So initially what we thought is probably we could do one tunnel and we try and get do both the things at one time. But you know, the G junction is at 40 centimeters. And Michelle, what do you think? Because Michelle and I, we've been talking about this in the last 5 minutes, how to go about this case. So Michelle, what do you think?
I mean, the problem here is the leiomyoma is very far from the perfect or the most convenient site of entry if we do regular
Yes, yes.
So there's an extra 10 centimeter here.
Yeah, extra 10
that
centimeter.
we don't need.
Right.
So I think just in case we end up full thickness, you know, on top, maybe we should separate the recession of the leiomyoma from the poem.
Right. Now, what I thought was, Michelle, in that case, probably, although the leiomyoma is pretty large, I think his dysphagia is still primarily because of the achalasia.
Yeah.
So I think we should treat his achalasia first, and probably at follow-up, we can probably do the stir for the leiomyoma. So we can even bring him back next year for the course. If he's asymptomatic for that, you know, that kind of a thing. So, and also, you know, I don't want to start a double whammy kind of a case at 7 p.m. in the evening, because that'd be there. So what I'm going to do is I'm going to do a standard posterior poem, because again the leiomyoma is anterior, so in that case I would need to do an anterior tunnel, and somehow I always prefer to do the posterior myotomy and the thing. So this is what we do, and we'll bring him back after a few weeks, and maybe after about 6 weeks, and then probably we can do a stir in the other direction. So that's the plan. So I'm not very sure how many people are there in the hall. We've had a very long day.
I think the hall is, everyone is just waiting. They are all there. They're quite interested.
Drinks or what? I don't know.
I can't say. No. They are really interested in the cases. Don't worry.
Okay. So what we're going to do is, I think Nila and I will be doing the poem over here. Nila is almost finished, more than halfway through. I'm starting this. I don't want to go completely on. I think if you can finish off some of the talks, maybe Taro's talk over there, and Pankaj and Amrita are still on the EFTR, so they need to be on the job. So they close the defect and get the lesion out. And we'll probably come in between. Maybe Anand can give you a PIP of one of the rooms so that we can have you can see what's going on over here.
Yeah.
Okay?
Yeah.
You can go whichever room you want to go to.
If you
Nila, you are not audible.
Yes, sir, now you are my answer.
Okay, so we are doing myotomy. The curve of the esophagus is like, it was going like very circular, so we are following just the curve of the esophagus. Initially we were on the left side, then we had to move on the right side, but now if you see the myotomy, now again I have to move on the left side. You can see the entire curve of the muscle. So that is what we are going to follow. So right now you can see there are circular muscles down there, and and below them are the longitudinal. So we are still cutting just the circular muscle, and we are letting the but as been pointed out earlier, it is impossible to now again I'm changing my direction of the muscle cutting so as to remain in the middle. I'm just making certain adjustment and trying to be
Nile, how much time you have taken to finish your first poem, and nowadays what is your average time?
I'm not going to reveal it because the first time I took 3 hours. And today how much time I have taken I don't know, but we can calculate it later because that today is my last poem.
I think you should pretty much, yeah.
So what you do is you put your needle in between the plane and then lift. And then go ahead. My assistant is helping me out to keep the scope in the position. Normally it is not, myotomy is easier, but as you can see here, the curvature is a little bit vague. I think now again we have a direction change, but also I'll be, in a moment I'll be starting a full thickness myotomy. So you can see still part of the law, is it? Yeah. So now I'm starting my full thickness myotomy. I think that's, yeah, I need to start my full thickness myotomy now. So I'm going below always lift because you don't want to take the structures which are lying below in the mediastinum. So
Nilay, in your own patients,
yeah,
what difference you have noticed pneumatic balloon dilatation versus POEM, the results wise?
Actually, don't worry. Pneumatic balloon dilatation does cause some fibrosis, but the experts have not found out to be different POEM experience, except that the time is a little bit more. Otherwise, it's okay, whether it's a pneumatic balloon dilatation or Heller, whatever is fine. I have not seen too much of a problem with pneumatic dilation, even though you can theoretically have more fibrosis. But that's okay. It just takes some more time.
Is it your policy to repeat the manometry after the procedure, and if
I'm
you want
sorry?
Procedure, manometry.
manometry post procedure?
Post procedure, we do it after 6 weeks. You can see peritoneal fat now.
Yeah.
So we entered and we gone beyond the, at 6 o'clock, can you see the peritoneal fat?
Yeah. Okay.
So if I see a lot of vessel, then my initial cut would be coagulation current. As you can see it's a different current. So initially you can use endocut, or if you see a lot of vessel around, you can use post coag current. Now there is a big vessel, so I am trying to avoid it if I can. And I'll use coag current initially, and then I'll use endocut. So I avoided the vessel which is there on the left side, as you can see. Oh, is it? It's okay. Yeah.
You're still okay.
I just was saved by God. Okay, let's have a quick grasper. As Mohan showed us, it's a last cut. Also, you can see there is a vessel, so too much vascular area. So I will be cutting the last part of the muscle with a quick grasper. Of course, I think even knife is okay. Give me the knife first and then the quick grasper. It is many times we take the knife out and clean the, you can see these vessels, these are very classical of gastric vessels at 6 o'clock. They are very thick vessel and running from here to there. Quick grasper. My problem is there is some bleeding by the side of that big vessel. It's going to be a tricky situation. Stop quick, please. Stop quick. Don't open. Don't open. I'm trying to take it away. 1, 2, close the neck. 4. Open. Okay. Let's see what we did. Okay, we are safe. Fine. Now quick grasper. Open. And you have to rotate it. सर इसको निकाल देना, कनेक्टर को निकाल दे और फिर रोटेट कर, बंद करके रोटेट कर, बस अभी है, बस बस बस, ओपन, लगाया, क्लोज. So whenever you are using quick grasper,
you have to use it like this. You have to pull. And the current is shockwave, effect 4 or 5, volts 80. Okay, now we'll cut. बंद कर क्या? चल गया. I think we are okay. What do you say?
Yeah.
Yeah. See, we have enough peritoneal fat so as to suggest that we have crossed the G junction. We don't want to cause any problem now. I'll just clean the tunnel and see if there is any bleeding. I'll not touch this vessel. It's you don't have to do anything about it. Only you see carefully whether they are bleeding. Even a minor bleed we have to tackle, because once we close it, if patient bleeds, then we are in a big problem. So this is the entire myotomy, as you can see, and we took the curvature. That was full thickness myotomy, and this is circular myotomy. I'll clean it and see if I have any oozing or see. Give me. Quick grasper. तो कोई ग्लास पर भी क्यों ले हैं अपने हेमोस्टेसिस कर देते हैं. I will just do the hemostasis, come out, see whether there is any mucosal leak. If it is not, I'll just close it. So if you want to move, fine. Otherwise, I'll just give me a second. I'll show you the complete myotomy. Close. Quick. Open. Close. We are fine with that. There is some ooze. You can just touch it also. Open. Close. So basically these are small vessels in the muscle edge. You can use force coag also. Open. Yeah. Again I'll elevate. I want. Oh, it has slipped off. Okay, just don't do anything. Don't open it. Let's apply it like this. Okay, now let us clean again and see. I think the muscles, they are, yeah. साफ करने दे एक बार, भी साफ कर दे अपना. Elevate and apply soft weight. 1. Cage पे touch कर देते हैं. Yeah, you are right. Just don't open it, huh? I'll just. सबको आहे ना भैया.
हो पण 2 दिवस बंद करायलाच लागेल. त्यांना पाहिजे तर आज ओपन सकाळी उद्या संध्याकाळपासून एक्झाम पण बंद करायचं. प्रोसिजर करायची.
ओके ओपन.
स्प्रे चालू ठेव. इको स्प्रे.
Coming. No. Yeah. See how the small vessels in the muscle can bleed? Close. And water is an enemy of soft coag, so it has to be a dry place. If it is water, soft coag will not be adequate enough. Yeah. So this is the upper part of our myotomy. Initially just the circular, later on both, and we are well beyond our incision. So it's not a full thickness perforation. And we can go in and see. The best thing is how we go in, see how easy it is to go. And also we'll do a retroversion. You can see a big injection blab. So we have done a good job at least. Now let us see if there is any mucosal breach. Harshal is helping me out. Thanks, Harshal. If there is any leak, just let me know, guys. So we'll do now closure. Yep. As Mohan showed us, the first clip has to be on the normal mucosa at the apex of the breach. That's what we are going to do. Open. निकाल कोई बात नहीं. अभी अंदर डाल और थोड़ा.
घुमाने का है.
Now sir, can we move on the next and come back to you, sir?
Yeah, sure.
Yeah. Amal sir, audio back with you, sir.
Okay. Okay, so we've completed the tunnel. It has some bleeding with the incision a little bit in the beginning. Then we managed to get in, and with Michelle by my side, it was really easy to get across the G junction. That's the G junction.
You can see how it opened up. You see what?
Yeah, this is
the sphincter.
it just goes up. And we've completed the tunnel over here. We've gone about 3 centimeters distally. And now we'll start out with the myotomy. So let's come back. Okay, so that's where we entered. So you can start from here now.
Yeah.
Okay, give me the knife. I normally do a full thickness. I start with a circular and then convert it into a full thickness as we go along. Because anyway it splits, so then you can hook your knife in a little bit better. The initial entry is very important here also. What you do is you go fiber by fiber, lift up a few fibers, do a surface coagulation, hook in a little bit.
You use coagulation for that?
I use coagulation
Okay.
and then cut. Maybe a little bit of coagulation because otherwise there's a bit of bleed. I'm using a cut. That's the longitudinal underneath. See that? There's the circular and then the longitudinal. And that's the plane that you try and maintain. Initially for the first couple of what is important over here is that keep your knife close to the endoscope. Don't let your knife be too much out, because then you can control the knife better.
Nice plane between the circular and the longitudinalis. Very nice plane.
Now we're going full thickness. Now this is what happens when you go close to the G junction. Usually you will end up with full thickness because that's where probably some of the oblique fibers start coming in. And here it really doesn't matter because that part is covered by this is probably the intra-abdominal esophagus, part of the esophagus. Probably just all you need to be very careful about over here. So here is coagulate a little bit and then cut because the periesophageal plexus of veins can sometimes give you nasty bleeding. And it's very treacherous to control that bleeding sometimes. It takes up a lot of your time. You have to insufflate a lot, irrigate a lot, and patient can land up with a little bit of surgical emphysema.
Amar sir, can we move on to the next slide and come back to you, sir?
No problem. Sure.
Amar sir, mic on, sir.
Yeah. Am I on?
Yes, sir.
Yeah. So we completed the closure. We placed 4 clips, but I think we can place one more in between. But to place in between is not a good idea. I think it's okay. Leave it. Basically, we have to be on both the sides and see both the margins have been taken up by the clip. So we went into the left side, now we are going into the right side and we are coming back and see it from the right side whether all the margins have been taken up in the clip. So we are okay, I think so, yeah. You don't have to be very near, but probably we'll put one clip over here. You can go into the other room. I just put one clip in between these 2 clips. But even if you don't put, this is fine because if you see the opposition of the margin is very good. But just to take extra care, we'll do it. So with that, I thank you all the chairperson. I thank Harshal for great help. I thank anesthetician. I also thank Prakash amongst men for helping me out.
Yeah.
Thank you very much.
Thank you, sir. Thank you very much, sir.
Good job, Nilan.
Thank you.
Amul sir, your mic on, sir.
Okay.
Sir, lectures ready. Can we go to the lectures, sir?
Yeah.
Can we present the lectures, sir, from here?
See, what you can do is probably check what's going on in room 3. Otherwise, you can go for talks. See, we've almost completed the myotomy. We are at the G junction. We've just crossed it actually. So just a couple of last.
Pankaj sir, can we move on the?
Yeah, you can.
Pankaj sir, your mic on, sir.
Yeah. Okay, see, we have practically done a full thickness resection, and this is the last attachment which we are still trying to remove. The tumor is too big. I think we are going to skip our dinner today. Because still you can see this entire thing which we have removed. See that? It is huge, really very huge. So maybe you can go back. In the meantime, we will try to see we can just dislodge it and apply a few sutures here.
Yes. Thank you, sir. Thank you very much, sir.
Okay. Neil?
Can you hear me? Okay, sounds good. Okay, good evening, ladies and gentlemen. Okay, so I'd like to talk about the debate. Well, hopefully I'd like to talk the debate with Morita, but he's busy now. So I'd like to talk about the endoscopic resection of large colorectal tumor and EMR and ESD. Of course, I'd like to talk in favor of ESD. So let's get started with the current indication for endoscopic resection for large colorectal cancer. And according to the Japanese large retrospect for hope in surgery cases, and SM deep invasion, more than 1,000 micrometer in submucosal invasion depths was the risk factor of lymph node metastasis. So the patient with those risk factors need to receive surgery even after RZ resection. So in the US, as you may know, EMR, endoscopic mucosal resection, is the mainstream for the large LSD. And as you can see, Dr. Michael Boak's group from Australia published a paper showing the treatment outcomes of EMR or large colorectal tumor rather than 20 millimeter in size. In their study, recurrent and residual adenoma rate was 20%, but most of them could be treated by the repeated endoscopic treatment, endoscopic resection and ablation. So, and but they concluded that there was no death from EMR. So, I think in most of the laterally spreading tumor, piecemeal EMR will be fine. But, so how do we, Japanese endoscopists, think of piecemeal EMR? So, let me show you a multi-center prospective study in Japan, which investigated local recurrence after endoscopic resection and to analyze the risk factor of the local recurrence. This study prospectively allows 1,800 patients who receive the EMR, including piecemeal EMR and ESD of the large colorectal laterally spreading tumor, greater over than 20 millimeter. And this study analyzes the local recurrence rate and the risk factor of local recurrence. In March Barrett logistic regression analysis, as expected, piecemeal resection is the most significant independent risk factor of local recurrence. That's quite natural. And as for the local recurrence rate was 6.8% and 1.4% in EMR and ESD group respectively. And local recurrence rate was significantly higher in conventional EMR group. Among the local recurrence, allow me to talk about the histology. Most of them were identified as dysplasia confined to mucosa, and they were successfully treated by repeated endoscopic resection. But some patients in the EMR group developed local recurrence with deep SM invasion and MP invasion. Of course, these regions were initially diagnosed as intramucosal region, a benign region with high-grade dysplasia. What happened? Actually, we previously performed the piecemeal EMR for large laterally spreading tumor, as is shown in this slide. So in this case, we performed the scheduled piecemeal EMR after the detailed observation of peak pattern. And as shown, number of the specimens is over 10. And 1.5 years later, only EMR scar was seen. But 30 months later, here you can see SMT-like protrusion with a little nodule on the top was seen just on the EMR side. So this patient actually underwent salvage colectomy. Surprisingly, this lesion invaded to T3 subserosa. Probably this is an underestimation of the depth of invasion by specimen fragment. According to our study, invasive recurrence rate was about 1%. So nowadays, we move to the ESD era, and we can perform unbroke resection for such kind of very, very large laterally spreading tumor. We achieved the unbroke resection for this region, and histology shows like this. So this region mostly confined to mucosa, but red line shows a submucosal invasion. This is a microscopic appearance. So most of the region are confined to mucosa, but look at the red line, very, very small, but deep submucosal invasion was identified on histology, measuring the 1,000 and 300 micrometer in depth. So now we can precisely evaluate the depth of invasion with unbroke specimen, but if you try to perform piecemeal resection like this, probably tiny and but deep submucosal invasion might be missed. Okay, so this year, Dr. Douglas Rex published an editorial of ESD, and he shows management of the after piecemeal resection. He says benign lesion and high-grade dysplasia can be followed up, and the patient with any submucosal invasion need to receive colectomy because the invasion of depth is generally unreliable because the specimen fragments are typically poorly oriented. I think it is a very, very simple and clear algorithm, but we Japanese endoscopists believe some of the very tiny but deep submucosal invasion could be missed by the specimen fragment. Of course, many of them doesn't develop recurrence. However, we believe some of them develop invasive recurrence as shown in this slide. It is characterized as SMT-like elevation. So ladies and gentlemen, please keep in your mind. So when we try to perform endoscopic resection for colorectal tumor. Treatment outcomes need to be comparable to surgery. It is very important point. So piecemeal EMR is technically very easy and time-saving method. Of course, I agree, and it allows a favorable outcome in most of the LC, but not in all. So invasive recurrence due to the incomplete histological evaluation is problematic. In contrast, ESD procedure allows us a high unblock resection rate, and the local recurrence rate is extremely low. And the unblocked specimen allows us precisely evaluate the histology, especially in the depth of invasion and lymph vascular invasion. Therefore, I believe ESD is an ideal comparable alternative to surgical resection. Thank you so much for your kind attention.
Any questions from the floor? Thank you, Professor Abe. Thank you so much.
Amal sir, audio back with you, sir.
Okay. May I have question to Dr. Abe? May I have question to Dr. Abe?
Yes, sir. Go ahead, sir.
Yes. A very good lecture, Dr. Abe. I'm Pradam Chai. What is the smallest size of the colon lesions that you allow, that you suggest us to do the piecemeal EMR or the snare removal? What is the smallest size? Yes.
Yeah, so our primary endpoint is unblock resection. If you feel the if impossible, please.
You're not audible.
You're not audible.
Amal, we can hear you. We cannot hear.
Okay. So before that, could you say that again slowly? So let me make sure your question again.
You are not audible.
Okay. So could you please tell me your question again slowly?
Sir, please repeat your question, sir.
Kindly see the audio, or it's not audible. Dr. Abe is not audible.
Yes, can you hear me? Yeah, okay. So I couldn't hear the question very well, so could you say that again slowly and clearly?
Professor Abe, you're not audible.
I just want a confirmation.
Yeah. Now you're audible.
Okay, can you hear me?
Yeah, you're audible now.
Yes. So my So first of all, I'd like to confirm your question again. Could you say that again?
What is the smallest diameter? What is the smallest diameter that you will perform ESD from colon lesions?
Yes. That really depends on situation. So if the envelope resection is possible by EMR, please go ahead to EMR. But if the lesion is very, very small but the recurrent lesion after EMR, prior EMR, we need to perform ESD. This is not the size limitation. Even though the lesion is 5 millimeter, but the lifting is quite poor, we have to do ESD.
Is there any difference in recurrence rate of only ESD and hybrid technique, ESD with EMR?
Of course, yes, hybrid technique is acceptable, of course. Yes, well, our primary endpoint is envelope resection, not ESD. So if you can perform EMR in envelope fashion, I think it's okay.
Is there any difference in recurrence rate?
Yes, of course. Local recurrence rate is significantly higher in EMR group. So to keep the secure margin, we should select the ESD rather than piecemeal EMR. Thank you.
Thank you, sir. Amul sir, your mic on, sir.
Hello?
Yeah, we can hear you.
Okay, so before we sign off from here, I think Pankaj and Amrita are still going on with that case, and probably we'll show you a video recording or something of that sort, because we'll probably close for the day, because it's pretty late, and we'll take the remaining 2 talks, Amrita's talk and Taro's talk tomorrow sometime. Before to introduce our team here at Dinanath, at the unit. So this is the team because of which these kind of courses become possible. Because of them, then we can show these many kind of procedures, and we can do these complex procedures and still feel very safe and comfortable while we're doing them. So we have our team, the technical team, Vilas, Samaji, Sujit, Rajesh, Rahul is still there with Pankaj, and Amrita, Prakash is here, Mansingh is here. Then the admin headed by Amrita, Trupti, Tina and Dipali and Anuradha. And she is Meena, our resident doctor, and she is the main backbone behind taking care of the patients. And she is Shivangi, who's been communicating with all of you all for the course, and she looks after all these academic activities. So beyond them, there is a lot of other staff as well, but probably that will not fit into the frame of the camera. And so I would like to thank all of them and thank all the staff over here. And
a big round of applause. Amol.
Yeah. There's a big applause.
Thank you so much, and see you in a little while over there for dinner. And tomorrow morning, let's see, so you can work out. So in case you want to start about 15 minutes earlier,
yes.
Probably you can just announce
I think we start.
so that we can close the lectures.
We start at 8:30.
Yeah. And we'll probably get a recording of what we've done today for Pankaj and Amrita's case and show it sometime during the day tomorrow morning. So we'll try and do that. Okay.
Yeah.
See you. Thank you. See you in a little while over there for dinner.
Yeah. Thank you all, and the dinner will be served in Sabha 1 on this floor. 7:30 onwards, but we already past 7:30, so any time after. Thank you very much. Thank you, chairpersons. Sabha 1.